Okay, so guys, I welcome you all to the first ever mega recall of the INI-CET MDS 2024 exam with us at DBMCI MDS. All right, now whenever there is an exam, okay, जब भी कोई exam होता है, so our focus is to get you the correct questions which were asked in the exam, get you the correct answers, okay, that will give you the correct answer to every question, and also to explain it to you why this option is correct and why other options are wrong. Okay, हमने अपना previous कल के analysis में देखा है that almost all the questions in yesterday's INI-CET exam were concept based, clinical based questions. All right, or clinical information integration of subject से आता है when you associate physiology with medicine, materials with prosthodontics, and combine your knowledge of basic sciences and clinical sciences. All right, so without taking a lot of your time, let us begin this first ever mega recall in the MDS segment done by DBMCI MDS. Our first faculty here is none other than Dr. Ruchi. I welcome Dr. Ruchi. Dr. Ruchi, are you there now?
Yes, Dr. Imani, thank you so much for the warm welcome and introduction. And
let me just quickly tell you about
Dr.
Dr. Ruchi. Dr. Ruchi is our AIMSonian here. She's done her post-graduation in prosthodontics from All India Institute of Medical Sciences, New Delhi. And she's our senior faculty in prosthodontics. And she'll be taking all your questions of prostho. Over to you, Dr. Ruchi.
Thank you so much, Dr. Imani, for that warm welcome. I welcome all of you, dear students, to this wonderful session and initiative by DBMCI, which has never happened in any dental NEET or MDS or INI-CET preparation, a mega recall event. So together here, like you all know, we will be doing recall of all 19 subjects one by one through the same video. So without wasting any further time, I would want to start the session off. Kick it off with prosthodontics, which is one of your most important subjects of final BDS. So let us begin with the session here. Now, yesterday, the reviews that I got about the INI-CET paper was that it was slightly tricky and difficult. Questions were unexpected, especially from topics that you had not considered or much prepared. While I talk about my own subject, prosthodontics, I feel that the difficulty level was moderate and the distribution of questions is what I would expect from prostho, which is 2 to 3 questions from complete dentures, 4 questions from removable partial dentures, 2 questions from FPD, and 2 questions from implant. A total of 11 questions were there from prostho. Now, like we have always discussed, your conceptual questions targeting your understanding of core concepts of the subjects would primarily be from removable partial dentures and complete dentures. I saw the same here in yesterday's paper. Direct fact-based questions from FPD, again the same which was projected, was seen in yesterday's paper. And the trend that I have observing in the last few papers of INI-CET is that implant is the game changer, where anything can come from implant. The same is what we saw yesterday, but the difficulty level of that was still moderate, not very difficult. So I would consider this to be a well-expected paper for prostho, and something that if you are due prepared with our live as well as recorded sessions and you have focused on your core concepts of prostho, you would have been able to solve all of these questions. So let us start with the first question over here. Starting off with the first question from complete dentures, the question was, in natural dentition, tooth contact does not occur during what? Options are deglutition, parafunction, mastication, and rest position. Now, the question is very simply asking you that the occlusal contact of teeth does not occur during what activity? As you can observe here, 3 activities. Deglutition, parafunction, and mastication. These are either functional or parafunctional activities. The only position where occlusal contact does not occur between the opposite dentition is at rest position. Now, while we were learning jaw relations, specifically vertical jaw relation, we had discussed that at the rest position of mandible, there exists a space between the maxillary and the mandibular occlusal surface. That space is termed as your freeway space. A normal freeway space of 2 to 4 millimeters is expected in any patients. Usually we adjust it at the range of 2 to 3 millimeters in a patient while making complete dentures. So at the rest position of mandible, there is space between the maxillary and mandibular arch. In all of the other activities, whether you are swallowing, whether you are masticating, or in any parafunctional movements, teeth will come in contact and generate occlusal forces. It is only during rest position that these contact does not happen. The space that you can see between them is called as freeway space. Now, this is a concept that was repeatedly taught by us while teaching vertical jaw relation. And like I have discussed in my previous YouTube sessions also, I have always shared vertical jaw relation is an extremely important topic for your exams. Usually the questions that we have seen are effects of increase and decrease in vertical dimension. Plus this is also surrounding that area, right? So this correlates with the projection that we had for our paper, that the question has come from our previous year topic, which is very important. So question number 1, tooth contact does not occur during what? The correct answer for it is during rest position. Now, in continuation with your previous question, question number 2 is also from the same topic, which is pertaining to vertical dimension and its adjustment, and another very important topic of complete dentures, which I have, I think, hammered to all of you, that troubleshooting in complete dentures is very important. I remember I shared a table with all of you in our live and recorded classes, and it is also present in our notes. So I've shared a screenshot of it, and the question was what? A complete denture patient complains of muscle soreness after wearing dentures for few hours. This is due to what? Option number A, reduced interocclusal space. Option number B, excess muscular force exerted by the patient. Option number C, excess force exerted by the patient just to retain the denture. And option number D, increase in interocclusal space. So the correct answer to this is reduced interocclusal space. And the reason for it is, I'll tell you why. When the interocclusal space, which means the space between the two dentures or the occlusal surface of the two dentures, is reduced, that is in a way your freeway space only. When that reduces, that means that the vertical dimension of occlusion is more. We have increase in VDO. Now, like I had taught you, again, during vertical jaw relations, VDR is a value that we obtain from our patient or we measure from our patient. And VDO is something that we establish in our patient while giving a prosthesis. Supposedly, you do it in a manner that you obliterate the interocclusal space and you do not maintain it. What this does is, it does not provide the provision for a rest period for even your muscles to relax. So the teeth are constantly in near contact or absolute contact with each other. And because of this, over a period of time, your denture bearing area and the supporting structures of the stomatognathing system, which are your muscles, they will become sore. This is an effect that is not seen immediately, but it is seen after wearing the prosthesis for few hours. So if we go back to our question, it says patient complains of muscle soreness after wearing denture for few hours. The correct answer to this is reduced interocclusal space. The other three options, if we see, are wrong because these options do not have this effect per se, plus they will not lead to a delay in the pain response after a few hours, the effect would be seen rather immediately. So, and option number D, increased interocclusal space will never have this consequence. So this is a part of understanding vertical dimension also, again, which is a very important topic. And this is a part of understanding troubleshooting also. And very beautifully, two things have been merged here and presented to you as a question, which we already know are very important topics of complete dentures. The same was actually discussed in our live and recorded classes, and it is present in our notes also in a tabular format, which is easy to understand for all of you and grasp. So the concept behind this is the understanding of vertical dimension. And the correct answer is reduced interocclusal space, which can lead to soreness of the tissues after wearing dentures. So that is the correct answer to it. Now question number 3, and we can say that jaw relations dominated complete dentures. हो गया hide. So sorry for the interruption. Question number 3 is use of anterior jig in complete dentures is for what purposes? And I would say jaw relations as a topic completely dominated your paper over here, especially complete dentures. I was expecting one question maybe out of phonetics and one question out of, say, I would say anatomy part, the retromolar pad area, which I have already stressed upon a lot, but jaw relation just swept off the floor completely. So here it is from centric relation. Actually, the question is use of anterior jig in complete dentures is for what purposes? Option A, helps achieving balanced occlusion. Option B is trying. Option C is recording centric relation. And option number D is phase bow transfer. Now, anterior jig is a small device that we give between the upper and lower, precisely incisors only, so as to deprogram the muscles, and it helps us effectively record the jaw relation, centric jaw relation to be correct. So the answer here is option number C, recording centric jaw relation. The occlusal prematurities of, say, your other teeth may direct your muscles in a way that it will develop a closure pattern, which is called as a muscle engram. To break that, we give a deprogramming device like a small Lucia jig or an anterior jig. We make our patient wear that, and after that, because the closed fixed pattern or habitual pattern is, I think, lost at that point, you can easily guide the patient back into the centric relation and correctly record it. This particular technique is valid for all parts of construction of a prosthesis, be it removable or even fixed dentures. So the correct answer here is recording centric relation. Option A, B, and D are not relevant to anterior jig. So they are wrong options over here. So 3 questions from complete denture, all 3 questions from jaw relations. And I repeat, jaw relations, troubleshooting, phonetics, anatomy. These are the topics that we have repeatedly covered in our most important topic sessions also for NEET and INI. The same which was projected and understood by us has been repeated in the paper. I hope you were able to solve this in your exams. Do let me know, were you able to solve this or not in our comment section and chat, and I'll just have a look through it. Now coming to removable partial dentures, question number 4. In a patient, maxillary and mandibular cast removable partial denture were adjusted individually with natural occlusion. When the patient was given the final prosthesis together, the natural teeth were in hypoocclusion. What is the cause of this prematurity? So what I understand out of this question is that the examiner is saying a patient is partially edentulous in maxillary and mandibular arch, and 2 different cast partial dentures, one each of maxilla and mandible, are constructed, and they were individually adjusted in the mouth with the existing natural teeth, not together. Now, when the patient is given both of these prostheses together, natural teeth are in infra or hypoocclusion, and we are asked the reasons for it. Reasons of this are what? Option A, prematurity between maxillary denture base and mandibular natural teeth. Prematurity between mandibular denture base and maxillary natural teeth. Option number 3, prematurity in between the 2 denture bases of maxilla and mandible. And option number 4 is prematurity between occlusion of the artificial teeth. Now, the most important giveaway point, which I understand here, is that they were individually adjusted, which means that individual adjustment cannot be the cause of it. So what is the existing cause? And we have been given pairs of 2 over here, right? So if I consider that they were correctly adjusted individually in the mouth, option number A and option number B already become wrong, because they relate to individual adjustment of one arch with the other arch, which was already done in the patient. So naturally, by logic and exclusion also, we can see that option number C and D are correct, and which is actually correct. When you insert both of the dentures against each other, the most common point is at the posterior part, where the heels of the denture base are going to touch, and that can lead to a prematurity. And the second where it can happen is between the existing artificial teeth of maxillary and mandibular denture bases. So those are the 2 areas which were not adjusted in this patient, and that is the cause of prematurity. So the correct answer would be option number 3 and 4, which is option C over here. So I have solved this question out of the basic knowledge of the topic also, and by simple logic, by understanding what natural information is given in the question. And when it is stated that they were individually adjusted, that cannot be the reason for it. So automatically, this is how you use your logic also when appearing these questions, which are especially long. They try to confuse you, but if you just be calm and try to find your way or navigate your way through it, it would be easier to solve them. Question number 5. Which of the following is correct pertaining to reciprocal arm in removable partial dentures? Now, this is a question I liked because it requires good understanding of direct retainer assembly as well as partial dentures. And what did it say? The reciprocal arm should be active before the retentive clasp. The reciprocal clasp arm should contact the tooth before the retentive clasp arm flexes over the tooth. The reciprocal clasp balances the apical forces, and the reciprocal arm is always active. Now, when we study the principles of clasp designing, we understand that a reciprocal arm is that part of direct retainer assembly which balances the forces that are generated when the retentive arm is active. We have also learned that retentive arm is not always active. The terminus is only active when a dislodging force is applied. Also, we know one more point from there. These all counteract against lateral forces, not apical forces. Action against apical forces or forces acting towards the denture bearing area is the property of support, which is given by an occlusal rest seat in the retainer assembly, whereas your lateral forces will be counteracted by your reciprocal arm. So keeping all of this information in mind, let us read the options over here. The reciprocal arm should be active before the retentive clasp arm. That is a wrong statement. The reciprocal clasp should contact the tooth before the retentive clasp flexes over the tooth. This is the correct statement over here, and it is the answer for this question also. If we refer to Stewart, which is one of the standard textbooks of partial dentures, we know that when you seat an assembly into the mouth, out of the direct retainer assembly, the first component to actually come in contact with the tooth, there is a line in your textbook, is reciprocal arm, because it will come in contact with the tooth so that it will counteract the lateral forces that are generated by the other components and helps in turn in minimizing the effect of lateral forces on the abutment teeth. So option number B is the correct answer, but we'll see option D and C and D also why they are wrong. Option C says that reciprocal clasp balances apical forces. That is wrong. It will balance lateral forces. So this here is wrong. It helps you balance lateral forces, and it is not always active. So going through all of these options, option number B is the correct answer. Also, dear students, I'll take a moment here as we have completed 5 questions to ask if you have any doubts, queries, or questions. Please actively post it in our live chat. It is open next to me over here. I can check in our live chat. If you have any queries or suggestions pertaining to our recall also, please do mention in our live chat on the link that you can see. Now, question number 6. Minor connector in RPD is what? Framework over edentulous ridge, retentive terminal, occlusal rest seat, and proximal plate of RPI. Now, this here is a slightly, I would say, tricky question for me, and I'll tell you why. If you go through minor connector, we know that minor connector connects different components back to the major connector, whether those components can be direct retainers, indirect retainers, or could be connecting your denture base back to the major connector. Out of the denture base, we note that there is an assembly of framework that is present over edentulous area that unites with the acrylic and brings it back to the major connector. So by that logic, option number A is correct. But we also know that the proximal variety of minor connector, especially the proximal plate of RPI, is also considered as a minor connector. So by that logic, if I go, B and C are absolutely wrong because they are part of direct retainer assemblies. But A and D both are minor connectors. So if I were a student, what would I select over here? Firstly, I consider that this is actually wrongful to ask where two options are probable answers. But if I were a student and I want to answer this, I would select option number A. And I'll give you my understanding why. Proximal plate is a part of RPI, rest, proximal plate and IBR, which together is considered a direct retainer assembly also. It also functions as a minor connector, but you can consider it a component of direct retainer assembly of the RPI variety. Whereas framework over the edentulous ridge is a straightforward minor connector only. It does not play any other role. So by that logic, I would prefer option number A greater than option number D over here. So that is why my answer for this question is option number A, which is framework over the edentulous ridge. Now, question number 7. In RPD fabrication, when a cast gold alloy is used, what should be the marginal ridge reduction of the posterior teeth? This was the specific question that was asked, that when you're making a cast partial denture with gold alloys, then what should be the marginal ridge reduction of the posterior teeth? Options are A 1 millimeters, B 1.5 millimeters, C 2 millimeters, and D 2.5 millimeters. Now, the only different part over here, it's a straightforward numerical question from something that we have repeatedly learned, which are again very stressed upon, are the specifications of occlusal rest seat formation. So when we are learning that, we know how much to reduce the marginal ridge, which is 1.5 millimeter, how much to deepen the central fossa, which is 2 to 2.5 millimeter. All of this we know. The only thing that can trip you off is the presence of this part, which is when a cast gold alloy is used. Now, if you deeply see into your standard textbooks and dive into it, you will see there are two ways in which rest seats can be made upon cast gold alloys, either a new cast gold restorations or an existing cast gold restoration. In both of them, very clearly one line has been mentioned. The preparation is same as sound enamel. That means the specifications of rest seat formation are same as what you do on sound enamel. So by that logic, the correct answer is reduction of marginal ridge by 1.5 millimeters. Also, I would like to highlight that this is something which is present in our notes. I have written it in our notes and it is easily accessible for a student to learn and remember. Also, this has been hammered into you that this is a very important topic for your exam. So that is why I'm saying Prostho questions were moderate. They're conceptual questions, but something that was predictable, that was already taught to you. So that is question number 7. Coming to question number 8. Now we are beginning with implant questions here. It was an image-based question showing you the undersurface of a denture and asking you to identify this particular prosthesis. So option number A, maxillary implant supported over denture with locator attachment, maxillary bar supported over denture, mandibular bar supported over denture with locator attachment, and mandibular bar supported, mandibular implant over denture with locator attachment and mandibular bar supported implant over denture. So slightly confusion while speaking it up, but there were two cases of maxilla, two cases of mandible. In one, they had mentioned locator, in one, they had mentioned bar for both maxilla and mandible. Now, any student knows this is a mandibular arch. not maxillary intaglio surface. So our two options here, I would thank actually the examiner for such questions, because I can already cancel out two options, and I'll urge our students attempt such questions because there is a 50% chance of being right. Now, logic says that bar is always something like this because it has a bar, and you will be able to see the vision of it or the image of it under the acrylic over here. I can clearly see two attachments with a ball and socket joint, which is specifically a locator attachment. So with a very calculated guess also, even if I don't know about the topic, I can mark that the correct answer is mandibular overdenture with locator attachment. Two simple attachments were seen in the intaglio surface, and that is the correct answer to it. Now, if you were a student who does not know the answer, this is the way you navigate through it. With simple logic, you know everything. It is just that you need to apply it over there at the time of the exam. So that is question number 8 from implants. And the question from implants that threw me off is question number 9. In an endosseous implant, after osseointegration is completed, very important line which was written. After osseointegration is completed, which of the following has maximum chances of implant failure? It is asking the most common site of implant failure after osseointegration is completed. Is it anterior maxilla, posterior maxilla, anterior mandible, and posterior mandible? Now, if you check through data, a lot of variables are always mentioned in the study, and then they come to a conclusion. But the conclusion draws towards two main areas. It could be anterior maxilla or it could be posterior maxilla. There are a lot of variables which would lead to a final result out of both of them in any study also. So naturally, even I feel answer could be anterior or posterior maxilla both. The key word that is mentioned in the question is after osseointegration is completed. What if this was not mentioned? If this was not mentioned, the chances of failure in osseointegration are more in D1 bone, which is found in posterior mandible. So I would have attempted that. But since that is already cleared off from the picture, that osseointegration is over, then the available factors actually is the site of the mouth, and then the chances of mucositis, the chances of bone loss, hygiene maintenance. Keeping all of these factors, my answer would be posterior maxilla, which is option number C, greater than anterior maxilla. So my answer is C, greater than A. Obviously, you will find studies which will say that anterior maxilla has more chances of failure because it is not actually along the direction of occlusal forces, it is at an angle. And all of the different variables would also prove that. I'm not saying it is wrong. But if I am a student to pick the answer, I consider it because the type of bone quality is poorest in posterior maxilla. Hygiene maintenance is poor, so post implant osseointegration chances of mucositis are more. All of these factors and the site, it is always said that chances of failure in posterior are more than anterior. So considering all these variables, my answer is C, greater than A, which is maxillary posterior more than maxillary anterior. Now coming to FPD, I've always repeated FPD is very nice in your prostho. Simple fact-based straightforward questions, and this is a question that was there in our Power GT test. It was there in our NEET tests also. It is there in our QBank. It is a previous year question and a very important question, and somehow only contraindication of veneer is asked. It has not even been flipped to indication also. The only thing that I can see as a change here is the options are different this time. So what was the question exactly? Let us see. Contraindications of porcelain veneers are what? Option A, vital teeth. Option B, endodontically treated teeth. Option C, tooth with proximally bulbous contour. And option number D, elongated tooth with enough tooth structure. Now, out of all of this, I can figure out and I can know that endodontically treated teeth is a contraindication for it because there are chances of discoloration of the tooth after endo treatment that cannot be masked with a veneer, plus the destruction of the tooth can be larger, which cannot be supported by the veneer. So it may need a full coverage crown. So all endodontically treated teeth, we cannot put a blanket statement that it can be sufficed with a veneer. And question number C, tooth with proximally bulbous contour. Now, the type of preparation that we done for veneers is sometimes a window preparation, and we although do enter deep into the proximal part, but we do not actually break the contact or establish a new contact in a veneer only. We try to seat as deep as possible in the proximal area so that the junction is not visible directly when seen from the front. But if you want to establish correct interproximal contour, your go-to way should be a crown and not a veneer. So considering this information, in a tooth with vitality and in a tooth where there is enough tooth structure, you can always give a porcelain veneer. So considering all of this information, option B and C, they are the correct answer. So I would search what option number B is there, stating option B and C is the correct answer, and a simple straightforward question from FPD. And the last question from Prostho, the finish line for an all ceramic crown is what? Again, principles of tooth preparation, already been told to you several times, a very important topic. In that there is a subsection on margins and finish lines, and it is asking about finish line for an all ceramic crown. So the finish line for an all ceramic crown, I prefer the answer as shoulder. You may ask, why not slope shoulder? Why not shoulder with bevel? Is it applicable to all cases of all ceramic crown? No. But is shoulder applicable to all cases of all ceramic crown? Yes. There is always a specific indication of bevel, which is unsupported enamel, which is not seen in all of the cases. So shoulder with bevel has a specific indication. Whereas when there is a general question asked to you, that indication of a finish line for your all ceramic crown, that answer is clear cut shoulder. And it is mentioned in our notes also in a very neat, tidy format. You can refer to these notes. Also, this is a previous year question and a most important topic for our exam. So this is how I was discussing and telling you. Prostho, according to me, was predictable. Prostho is something that I feel that we already knew these are the important topics. One or two options are changed or something has been changed here and there. Implant is something that is the game changer, but that is not the only deciding factor. The other questions, how you have performed, that are going to decide what your rank is going to be. So with this, I would conclude our recall for Prostho. I hope all of you were able to solve these questions and had help from our recorded sessions, live sessions, as well as our notes, the power GTs that we had conducted. And I hope all of you were able to solve this. Do let me know your feedback in the live chat as well as in the comments here so that I come to know. Assist us with the recall if you feel anything was slightly different. I consider this as almost a near perfect recall of all of the Prostho questions. And with this, I would conclude our session over here. Any doubts, you can always ask on our Facebook and Telegram support, and we would be happy to solve them. With this, I would also want to introduce our next faculty in line. He is Dr. Kunal, and he is your mentor for orthodontics. So, Dr. Kunal, if you are joined in on this session, I would like to end my part of the session over here, and I hand it over to Dr. Kunal. He'll begin with the recall session of orthodontics. Meanwhile, till Dr. Kunal joins, I can just take up Shivam's question. Shivam is asking, can we answer question 9 based on D4 quality of bone? So just going to question 9. Yes, Shivam, that is also possible, but considering not just the bone quality, all other factors, I have considered option C greater than option number A. And he is also asking question number 5, please explain option A and B. Okay, Shivam, the logic with reciprocal clasp palm is that it should first come in contact with the tooth while seating a prosthesis, and it helps the counteraction of lateral forces that are generated during this process. Also, whenever reciprocal arm is retentive arm is active, your reciprocal arm is going to reciprocate those forces and brace the entire tooth structure. Considering this entire concept around reciprocal arm, the best recall of this is what I have listed here, and the correct answer would be option number B. So apart from this, any other questions, please post it into our live chat. I'll be happy to take up your questions. And I'm waiting for Dr. Kunal so that he can join up our session and start with the recall of orthodontics. Okay, so I can see Dr. Kunal is joined in over here. Sir, over to you.
लैपटॉप में वॉइस नहीं आती है ना, आप कैसे
इसमें करूँ क्या कनेक्ट?
डबल आवाज आएगी?
हाँ तो फिर क्या करूँ?
ये बस आंसर लिखना है ना, फिर हो गया।
बस हो ही गया, बस एक सेकेंड। यस,
तो लाइव के बाद ही लाओ कॉफी।
हाँ ठीक है, इसके बाद ही
आ
ले आना,
गई है बट
कोई बात नहीं, इसके बाद ले आना आप फिर। अब तो हो ही गया, टाइम ही हो गया। 11
तो मैं बाहर हूँ, कॉल कर देना अगर कुछ होता है।
चलो स्टार्ट करूँ मैं? स्टार्ट करूँ मैं? स्टार्ट करूँ ना मैं? बस वो मैं माइक ऑन कर देता हूँ, स्टार्ट कर दो, डन। All right, good morning students. Good morning all of you. So how was the exam yesterday? Although I had a talk with a few students yesterday, so I have got mixed reviews about the level of the question. Specifically, I'm talking about orthodontics part in the question paper. Some people said that it was relatively moderate. Some people said it was relatively, it was quite difficult actually. There were more of clinical based questions. And as per the recalls, what I have got so far, I did not see any of the repeat questions in the INI-CET May 2024 exam. Right? So without wasting much time, let's start with the discussion. So I'm Dr. Kunal Agrawal, your original guru for Orthodontics in DBMCI MDS. So the first question was, it's a clinical based question. At what age mesodense should be extracted? Now you have to understand what's the mesodense. Can anyone tell me if you want to talk about the options, or if you feel the options are not correct as they had appeared yesterday in the exam? So you can very well comment in the chat box. I'll be very happy in fact, I would want few of your inputs, because there are certain questions I couldn't find options. So even the questions were little incomplete. So I want your inputs so that I can reframe the question, reframe the options, and I'll try my best to give you the right answers. So if you find that this question or this option is not right, it did not appear in the exam, you are very, very welcome to write the corrected version of the question or the option in the chat box. Okay? So the question was, at what age mesodents should be extracted? Mesodents, it's a supernumerary tooth, and it's a supernumerary tooth present in the maxilla between the central incisors. Everybody knows that. Options were immediately as it is discovered on radiograph. Second option, only after 12 years of age during initiation of fixed orthodontic therapy. Third option, after complete root formation of permanent incisors. Or the fourth option was after half to two-thirds of root completion of incisors. Now, it's a pretty tricky question, I would say, because exam setters are little clever. They are quite clever. They have a upper edge in making you confused regarding answering any question. So the confusion lies between option C and D. After complete root formation of permanent incisors, or after one half to two-thirds of root completion of the incisors. However, I think, as per my clinical knowledge and as per my experience so far, both of these options are not right. The correct answer, according to me, should be option A. Immediately added is it discovered on the radiograph. Because mesodens is such a tooth. It's a supernumerary tooth. It hampers a normal eruption pattern of the central incisors if it is present, detected, or undetected. Right? So the first and the foremost thing, what should be done as soon as it is discovered in a routine radiography examination is that it should be extracted as and when it is discovered. Now, a brief introduction about supernumerary tooth. As I said, it's a conical supernumerary tooth. It's a mesodens. It is present in the palate between the central incisors. It is discovered routinely whenever the incisors are not able to erupt during the normal course of eruption. The parents take the child to the dentist for a routine examination, and upon shooting an OPG or an occlusal radiograph, it's an accidental discovery that the impacted teeth could be because of presence of the supernumerary mesodens tooth. Now, as the wisdom says, and as the clinical experience says, it should be extracted as and when it is discovered. So option A is the correct option. Next question, image-based question. What is the plan shown in the image below? It's an image-based question. So is it a hybrid pendulum appliance? Is it a hybrid T-Rex appliance? Is it a frog appliance? Or is it a first-class appliance? Now, I hope you people know what are these appliances. Frog appliance was relatively new, and I have mentioned about frog appliance in my recorded lectures. Although I have not described it in detail, I've just mentioned it for the sake of your information. But now is the time that we discuss it in quite detail because it has come in the exam from now, right? So the correct answer is it's a frog appliance. Now, what's a frog appliance? Frog appliance, as it is shown in the image below, this is a frog appliance. So it's a molar distalization appliance basically. This appliance is used for maxillary molar distalization. Now we have seen how many types of distillation appliances are there. There are removable appliances, there are fixed appliances. Even there are appliances which take the support of fixed mini screws into the mouth. This is one such appliance. Why is it called a frog appliance? Because a schematic representation of this appliance, as you can see in the image below, it more or less it represents a frog sitting and it is ready to jump. That's why it has been termed quite in a very funny way as a frog appliance. Now it was first marketed by a company called Foresterdent. Prosthodontics. It's a German company. It is designed with fixed screws for molar crystallization without tipping of the molars. Now, the advantage of this appliance is that, as you can see in the image here, these are the maxillary parietal screws which take support from the anterior part of the parietal screws. You know, how is it different from the pendulum appliance? In the pendulum appliance, there is a, just a second. In a pendulum appliance, there is a non-parietal button. I've included a diagram of pendulum appliance as well. This is a non-parietal button, which is the acrylic part of the appliance, and it is used to take the support. It is used to take the anchorage from the anterior part of the palate, and rest of the wire components emerge from it. Whereas in frog appliance, the anchorage is derived from the palatal screws, palatal temporary anchorage devices, which are placed into the palate just lateral to the mid-parietal raphe, right? So how does it work? This is a higher-X screw. This is a higher-X screw assembly. It can be used for lateral expansion of the arch as well in case of transverse maxillary deficiencies. Then it has got very thick arms which are attached, which are soldered to the molar bands. These are the two which are soldered to the bands, and it has got TMS springs as the normal architecture is for the pendulum appliance. These TMS springs, when activated, they produce a dislocating force to the molars. Right? Now, why this higher-X screw is there? It can be used for transverse maxillary expansion as well. Now, as and when the transverse maxillary expansion is over, you are supposed to cut these two wires so as to make the molars free to be dislocated. And once this is done, once these strong wires are cut intraorally, then you are supposed to activate these helices in a distal direction so as to cause distal movement of the molars backwards. So this is how the frog appliance works, right? Now, a little bit about the different appliances, whatever are asked in the exam in the options here. Now, this is a frog appliance as I showed you. What's a pendulum appliance? It's a benchmark of all the appliances used for molar dislocation. Introduced by James J. Hilgers in the year 1992. It produces a broad swinging arc that is pendulum movement of force from midline to palate of upper molars, hence the name. Posteriorly directed springs are made up of 0.032 inches TMA wire. This is yet another MCQ for you guys. Springs are fabricated to lie parallel to the mid-parietal plane, which produces 60 degrees of activation after insertion. As the molar distalizes, it moves on an arc, that is a distoparietal arc, towards the midline, producing crosswise in molar. And the force produced by activation of the springs is approximately 250 grams. This is yet another MCQ. I myself was asked this MCQ way back in 2013 in AIMS exam, and unfortunately I got it wrong. Actually, I came back to my home, and I immediately opened William R. Prophet, the textbook, the Contemporary Orthodontics by William R. Prophet, and I found out that the right answer was 250 grams. However, I got it wrong actually, right? So this is the pendulum appliance. It has got a non-parietal button. It has got two premolar occlusal rests and a TMS spring soldered to the molar bands, which is the active component of the appliance. What are the modification of pendulum appliance? We have a pendex appliance. This is a pendex appliance, as you can see. Pendex, pendulum appliance plus expansion device. So it's an expansion device. It is producing slow maxillary expansion, and at the same time, it is producing dislocation forces on the molar. It makes use of a jack screw in the midline and with a parietal sagittal split in the non-parietal button, right? Next is M pendulum. Now this is M pendulum. The only difference between normal pendulum and N pendulum is the direction of these springs, the direction of the U loop of these springs, the TMS springs. You can see here in the original configuration of the pendulum appliance, the springs were directed distally. They were directed distally. However, the U-loop of the spring in an M pendulum is directed mesially. Now, why was this modification done? This was done because it was found by researchers over a period of time that upon activation of the springs in a normal pendulum, the molars used to move, the molars used to roll lingually, or they used to roll palatally. Distopalatal rotation was the side effect of this appliance. To counteract this side effect, the direction of the U-loop of the springs was changed from distal to the mesial. That was the only difference. Another modification is the Hilger's PhD appliance. This is the PhD appliance. Now you can see here, there is no Nance parietal button, there is no acrylic component in the appliance. There is a Hyrex screw in between in the middle for transverse maxillary deficiency. You can expand the maxilla, as well as once expansion is done, you can go for the distalization of the molars as well. So this is Hilger's PhD appliance. Now one more appliance was asked in the option, that is first class appliance. Now what is a first class appliance? First class appliance is a buccal as well as palatally placed appliance. It's a single appliance which is placed buccally as well as palatally. It makes use of a telescopic mechanism through which the distalization of molars can take place. You can see here, the springs are wounded here. Just a sec. You can see the springs are wounded here and here as well. So these springs produce a distalizing force on the molar as and when it is required, right? So the correct option was, it is a frog appliance. Next question. Peak height velocity and peak weight velocity. Peak height velocity can be abbreviated as PHV and peak velocity can be abbreviated as PWV. They may be useful to ascertain the growth in an individual. Very true. Which of these is true about relationship of peak velocity in height and peak velocity in weight? Pretty confusing. So options were, peak velocity in height lags behind peak velocity in weight by about 6 to 12 months. Second, peak velocity in weight lags behind peak velocity in height by about 6 to 12 months. Third, peak velocity in height lags behind peak velocity in weight by about 3 months. And peak velocity in weight lags behind peak velocity in height by 3 months. Now for answering this, you are supposed to remember, you are supposed to understand rather, the graph between peak height and peak weight. What's the meaning of peak height and peak weight? Now you can see in this graph here. So growth can be plotted in either height or weight at any age. That is black line, or the amount of change in any given interval, that is a maroon line, showing the same data as the black line. A curve like the black line is called a distance curve, whereas the maroon line is called a velocity curve. Plotting velocity rather than distance makes it easier to see whether accelerations or deceleration in the rate of growth has occurred or not. Now you can see here, if you look at this graph, a graph is plotted with height plotted on the y-axis and age plotted on the x-axis. On the left side of the y-axis, the height is plotted in centimeter, and on the right, the height gain, that is the gain of height in centimeter per year, is plotted on the other side of the y-axis along the vertical direction, right? Now, if you plot age against the height, you will see, you already know that the peak pubertal growth stage, that the child enters the circumpubertal growth stage around 11 to 14 years of age, 11 to 12 years in case of girls, and 13 to 14 in case of boys. So the range is around 11 to 14 years in general. That is when the child enters the pubertal stage. Correct? Now, during that age, you will observe rather you must have observed in yourself, in children around yourself, or in your own siblings, or your parents must have told about the developmental milestones which have happened in you yourself only, that you shot up in height during that circumpubertal age. That is 11 to 13, 14 years of age. Your height increased exponentially, right? So that is the time what is called peak height velocity. You can see here as it is observed in the graph as well. The maroon shaped graph has peaked, it has spiked up during 13 to 14 years of age. This was a graph plotted for a boy. Hence the peak height velocity corresponded with the circumpubertal age, that is 13 to 14 years in case of boys. Had this graph been plotted for a girl, the same peak height velocity would have occurred here around 11 to 13 years of age, or 11 to 12 years of age, right? Now, this is what is called peak height velocity. Now, evidence says that peak height velocity represents the greatest rate of change in body mass. After peak height velocity, there exists a time delay of 12 to 14 months approximately, where there is an increase in body mass compared to stature, and it is a period of time that is referred to as peak weight velocity. Let me make you understand this again. After peak height velocity, there exists a time delay of 12 to 14 months approximately, where there is an increase in the body mass compared to the stature, compared to the height. And it is this period of time that is referred to as peak weight velocity. That means, what does it mean? You can put it in this way as well, that after the peak height velocity has occurred, the peak weight velocity kicks in. There is a time delay of approximately 12 to 14 months after that, right? So the peak weight velocity, that means the child starts to increase, the child starts to gain the weight after the peak height velocity is achieved after 12 to 14 months of that, right? This is the meaning of this graph. Now let's come back to the question again. So out of the 4 options, second option, that is option B, peak velocity in weight lags behind peak velocity in height by about 6 to 12 months. This is the most appropriate answer. Actually, 6 to 12 months, maybe it could be plus minus 6 months as well. So we can say that the peak weight velocity lags behind peak height velocity by about approximately 12 months. Just keep it simple, by approximately 12 months. So out of the 4 options, option B is the most appropriate and most correct answer. Is it clear? All right. So the next question is, in cervical vertebra maturity index, accelerated mandibular growth is best in which of the stages? Now, accelerated mandibular growth, this is what the question is asking. Now, you know that the cervical vertebra maturity indicators, or any skeletal maturity indicator for that matter, they are specifically employed to understand the growth status of the bones of the child. And it is after you understand the growth status of the bone of the child, the proper treatment plan is executed. The treatment plan is planned, and then it is later on executed for the patient for the best possible results. That is the whole rationale of studying the skeletal maturity indicators. Now, what are the skeletal maturity indicators? We can make use of the hand-based radiograph. We can make use of the frontal sinus. We can make use of the cervical vertebra maturity indicators, the clavicle, the iliac crest, or the pelvic girdle as well, you can say. Then we have the tarsal bones, the metatarsal bones, the teeth calcification, the Dimejian system, Nola's system of calcification, Nola's stages of development of the teeth, and so on. And also we have got other biomarkers as well. We can make use of thyroid hormone, We can make use of parathyroid hormone. We can make use of insulin-like growth factors to ascertain the level of growth which has taken place, and also the level of the amount of growth which is yet to be completed in the patient, right? That is the meaning of skeletal maturity indicators. Now, the question is asking, in cervical maturity vertebra index, the accelerated mandibular growth is best in which of the stages? CVMI 1 and 2, 2 and 3, 3 and 4, or 4 and 5? Now, for that, you have to understand, you need to understand what are the different stages of cervical vertebra maturity indicators as given by Hassel and Farman. Right? Now, let's discuss something about the topic. Now, for the cervical vertebra maturity indicators, you are supposed to look at 3 vertebrae: the C2, C3, and C4 on a lateral cephalogram. Now, the beauty of this is that you don't need to go for a specialized X-ray, because these 3 cervical vertebrae are easily visible in a lateral cephalogram. Why don't we take C1? Because it's an atypical vertebra. Why don't we take C5, C6, or C7? Because C7 is again an atypical vertebra, and C5 and C6 are a little lower down. They are not that easily visible in a lateral cephalogram. So the most easily visible vertebrae in a lateral cephalogram are C2, C3, and C4. That's why these 3 are the most commonly used vertebra in the cervical vertebra maturity indicators. Right? Now, actually, this was first given by Lampersky. There was a scientist called Lampersky who came up with an idea of the use of cervical vertebra maturity indicators, which were later on modified by Hassel and Farman, I think in the year 1975. I may be wrong. Please cross-check it. It was somewhere in the year 1975, somewhere around 1975. So they came up with their own modification of Lampersky system. They said that the cervical vertebrae, the stages in which the cervical vertebrae get matured can be divided into 6 stages. What are those stages? This is the first stage. The second stage. The third stage. The fourth stage. The fifth stage. And finally, the sixth stage. So you're looking at C3 and C4 and C2. The first stage was called initiation stage. The first stage was called initiation stage. You can say that this was C1 stage. The first stage is initiation stage. You can observe here that you have to first see the body of the vertebra. There are many parts of the vertebra. There is a spine, there's an odontoid process, there is a body of the vertebra. Then there are other physical characteristics as well. So, but we have to focus our attention on the body of the vertebra. So in the C1 stage, that is initiation stage, you can observe that the body is a wedge shaped, which is posteriorly directed. So this is the dorsal part, this is the ventral part. It applies to all the different stages of the vertebra. So the body of the vertebra is wedge shaped, which is dorsally directed or which is posteriorly directed. And the overall size, the overall shape of the vertebra is horizontally rectangular, right? That is initiation stage. Then comes acceleration stage. Next is acceleration stage. This is called C2. Here you will observe the body of the vertebra has started to assume a different anatomical shape as compared to the initiation stage. You will observe that the wedge, the posterior slope of the wedge of the body of the vertebra has started to decline. It has started to decline, right? So it has become more flatter as compared to the previous stage. That is more posterior, more steeper posteriorly directed. And also you will observe that the body of the vertebra has started to change its shape from being horizontally transverse, horizontally rectangular to vertically rectangular. It happens step by step, stage by stage. So that is stage number 2, that is acceleration stage. Next is stage 3, which is called transition stage. One second, I'll just draw it again. This is called transition stage. Now, the beauty of transition stage is that you will observe the development of a slight concavity along the inferior border of the cervical vertebra. Instead of the inferior border being flat, you will observe the development of the presence of a small concavity along the inferior surface of the body of the vertebra. And also you will observe that the wedge shape of the vertebra has been completely eliminated, right? And there is a change in the body of the vertebra from being horizontally rectangular towards a more squarish shape. That is transition stage. Next is C4. That is called deceleration stage. This is deceleration stage. Again, you will observe the presence of deep concavity along the inferior border of the body of the vertebra, and the body has assumed a squarish shape from being horizontally rectangular. It has assumed a more squarish shape. So that is the difference in the phenotype. Next is C5. That is called maturation stage. Again, there's a presence of deep concavity along the C3, C4, and also from being squarish, the body of the vertebra has become vertically rectangular. Please note the difference here. In C1, C2, C3, the body of the vertebra was more horizontally rectangular. Whereas in C4, it is squarish. In C5 and C6, it has become vertically rectangular. Finally, the last stage, that is C6, is known as completion stage. Right? You will observe the presence of deep concavity along C2, C3, and C4, all three vertebrae. Plus, you will observe the presence of a well-developed configuration of the body of the vertebra in a vertically rectangular pattern. So this is what Hassel and Farman's system was, the Hassel and Farman system of classification of cervical vertebral maturity indicator was. Now the question arises, what is the peak height? What is the best time to start with the functional plans? So the correct answer will be C3 and C4. Let's see how. If you plot a graph which shows the 6 stages of maturation of cervical vertebrae with growth curve showing peak of pubertal growth spurt, you will observe the peak of pubertal growth spurt is occurring in C3 and C4. The peak was not achieved in C1 and C2, and in C5 and C6, there is some residual growth is remaining, but the peak has been already passed. So the correct answer accelerated mandibular growth is best in which of these stages? The correct answer will be option number C, that is C3 and C4. I hope I am clear. If you have got any doubts, students, please let me know in the chat box. I'll be very happy to address the issue then and there itself. Okay? Next is, what is the indication of lingular appliance? Now, what is a lingular appliance? It's a space maintainer appliance. Right? Everybody knows that. Options are mandibular molar are decayed and need to extract. Second is maxillary molars are decayed and there's a need for extraction. Third is the maxillary incisors are procline, or all of the above. Actually, the third option is not right. So consequently, the fourth option will not be right. Now the confusion is between option A and B. Mandibular molars are decayed and there's a need for extraction. Maxillary molars are decayed and there's a need for extraction. Now, whenever maxillary molars are decayed and there's a need of extraction, we always go for non-palatal button. Whereas the lingual arch appliance is specifically used for the mandibular cases. Whenever there is premature exfoliation of deciduous molar teeth in the mandibular arch, and so as to prevent the mesial migration of the erupted mandibular first molars, there is a need for introduction of this appliance that is called lingual arch appliance in the mandibular arch. So the correct answer will be option A, that is mandibular molars are decayed. We are talking about deciduous molars. Please remember this, we are talking about deciduous molars. The mandibular molars are decayed and there's a need for their extraction. That is where the lingual arch appliance makes sense. A little bit about lingual arch appliance. It's a non-functional, passive, fixed space maintainer. It is used where there is bilateral loss of deciduous molar. A fixed lingual arch is often most satisfactory. Whenever there is loss of multiple teeth in the mandibular arch or the maxillary arch, as I said, it can be used for maxillary arch as well. But the more preferable appliance is a non-spiral button instead of the lingual arch. It is made up of 0.036 or 0.040 nickel chromium or stainless steel lingual arch wire. The U-shaped portion of the lingual arch wire should rest on the cingulum of each mandibular incisor, if possible, to prevent the mesial tipping of the mandibular first permanent molar and lingual retrusion of the incisors themselves. So this appliance takes support from the cingulum of the mandibular molar of the mandibular incisors, so as not to allow for the mesial migration of the permanent molars in the extraction space, and not to encroach on the exfoliated edentulous space and give space for the eruption of the not yet erupted premolars from below. There are two types of modifications. That is a Mershon's modification, where the spurs are placed distal to the canines. The spurs are placed distal to the canines and are used in case of loss of both first and second primary molars. One more modification is a fixed removable lingual arch. The design is such that the lingual arch is inserted and removed from a vertical tube in the molar bands rather than soldering. So it can be removed by the patient themselves. These are the modifications. Now this is a lingual arch. We have two molar bands in the mandibular arch. These are the areas where the exfoliation of primary deciduous molars have occurred. And the stainless steel wire, it is fabricated in such a way that contacts the cingulum of the lower anteriors. So this contact between the wire and the cingulum prevents the mesial migration of the molars. It doesn't allow this to happen. And also, this wire doesn't allow the lingual collapse of the mandibular arch in a posterior direction. So it has got dual function. Another modification is the Mershon's modification. You can observe the presence of a lingual spur just distal to the deciduous canine, which does not allow the lingual collapse of the mandibular dentition, mandibular anterior segment, mandibular anterior sextant into the posterior edentulous space. So that is what the lingual arch is all about. and what are the modifications of that. I've just explained to you in the slides just now. Now, this is an incomplete question and incomplete options. I would require your input right now. Question was, what is not present in a facial angle? I am not sure whether this was the correct option. So I cannot give you a right answer right now without the proper options, right? So let's talk about what is a facial angle. Now, what is a facial angle? It's one of the skeletal parameters in the down cephalometric analysis. There are other skeletal parameters also, and facial angle is one of them. So, facial angle in a lateral cephalogram is an angle between the facial plane and the Frankfurt horizontal plane. Now, what is the facial plane? Facial plane is nasion to pogonion. Nasion to pogonion. Hard tissue nasion to hard tissue pogonion. And Frankfurt horizontal plane is between porion to orbital. What is porion? Porion is the uppermost part on the external auditory meatus, and orbital is the lowermost point on the bony orbit. Right? So the line joining the uppermost part on the external auditory meatus to the orbital is called the Frankfurt horizontal plane. So the angle formed between the facial plane, that is nasion to pogonion, and the Frankfurt horizontal plane is called the facial angle. So this angle here is known as facial angle. The range is between 82 to 95 degrees, where the mean value is 87.5 degrees. What does it signify? It shows either retrusion or protrusion of the lower jaw in respect to the forehead. That is what facial plane signifies. Now, if the angle is around 82 degrees, if the angle is less, that means, what will it mean? It will mean that the mandible is retrognathic. So it will suggest a class 2 pattern. Whenever the mandible is retrognathic, it always suggests class 2 pattern. Whenever the value is around 88 degrees, that means it is in the normal range, around 87.5, 88 degrees. It signifies class 1 skeletal pattern. Whereas any angle above 88 degrees, like in our example, it is 95 degrees, it shows its class 3 skeletal pattern where the mandible is prognathic, right? So that is the meaning of facial plane. I would be very happy if anybody can give their inputs as to what were the correct options for this particular question, because I really couldn't find any proper options for this. And right now, I'm not in a condition to give you the correct answer without the proper options. So I would please request you, viewers, how many viewers are there? There are 4 participants right now. No, there are many participants. I cannot see the participants here. Let me see whether I can see here. One second. No, I cannot see any participants. So if you have got any inputs, they are very much welcome here. Another question, I don't have the question, nor I have the proper answers. The question was something related to debonding of orthodontic brackets. So if you have got any questions, if you have got any correct options to this question, their suggestions are welcome. And I'll come back to this question later on, because without the question or the options, I cannot answer anything. Now, next question is inclined plane appliances used for the correction of. Now, what's an inclined plane? Actually, there are 2 types of inclined plane, and the use of inclined planes depends on what exactly we are going to correct. It can be used for correction of crossbite. Let's see. It can be used for correction of crossbite. And also it can be used as a support phase after completion of active malfunctional appliance treatment. Right? if you remember, I have told you in my recorded lectures earlier that after the completion of any active malfunctional appliance treatment, no matter what appliance is used, whether Frankel appliance is used, whether twin block appliance is used, bionator, activator, or any fixed function appliance is used, anything. The active appliance is when the mandible is taken into a forward position under the influence of growth hormone. Now, it is after the completion of the active treatment, some appliance has to be given on the maxilla, which is going to support the mandible, which is going to support the anteriorly positioned mandible, so that the mandible doesn't come back in the form of relapse. That is where the user support phase comes into existence. And the support phase is done by using an inclined plane. That is one. Second is for the correction of anterior crossbite. So the correct answer will be inclined plane is used for the correction of anterior crossbite in the form of a Catalan's appliance. What's the Catalan's appliance? It's an acrylic appliance, although, but it's a fixed appliance. This acrylic appliance is cemented onto the clinical crowns of the lower anteriors. It has got an inclined plane of 45-degree angle, over which the lingual surface of the upper anteriors are set. So this inclined plane acts as a guiding plane for correction of developed anterior crossbite, right? So whenever you come across a patient who has developed anterior crossbite due to whatever reason, one of the good appliances to consider is Catalan's appliance, because you don't have to depend on the patient compliance for this. You just have to fabricate the appliance. You just have to bond the appliance on the patient's teeth using the glass ionomer cement or any other cement, zinc phosphate, zinc polycarboxylate, anything. And that's it. You just have to leave the appliance in place for some time, and then you will see the results in just a few weeks' time. However, the only disadvantage of this appliance is that it is quite bulky, number one. Number two, there is risk of decalcification of the lower anteriors, because, as I said, it's a fixed appliance. The appliance is supposed to be cemented onto the clinical crowns of the lower anteriors. So the good adhesive which can be used here is a fluoride releasing glass ionomer cement that can be considered for bonding of this particular appliance to the clinical crown of the lower anteriors. So correct answer will be inclined plane appliance used for the correction of anterior crossbite. The other use of inclined plane, as I said, for a support phase. Now you can see this is an inclined plane. This is not a bite plate. Rather, if you look from the profile view, you will observe that this is an inclined plane like this, having 45-degree angulation. The patient wears the appliance in the maxillary arch, and the lingual surface of the lower anteriors get locked into that inclined plane, so that the mandible is not shifted back, so as not to cause any relapse after completion of active malfunction appliance treatment. Clear? Yeah, one more thing. If this appliance is a fixed inclined plane, that is known as Rick-A-nator. It's nicknamed as Rick-A-nator appliance. Okay? Next is skeletal maturity index is not measured by which of the following? Now, again, a simple question. We have talked about different skeletal maturity indicators earlier. Now, which index is, the skeletal maturation is not measured by which of the following? So you know it is measured by hand-breast radiograph. It is measured by cervical vertebrae, as we have just seen above. It is measured by dental calcification as well, by two methods, that is the Dimergen system of calcification and Nola status of calcification. But it cannot be measured by attrition of the teeth. Now, attrition of the teeth is a pathological phenomena. It's a pathological phenomenon. It is not physiological. It happens for a reason. right? So attrition of the teeth means whenever the teeth are occluding, whenever the jaws are involved in parafunctional activity of the temporomandibular joint, example, bruxism, or night grinding, or daytime grinding, bruxomania. In that case, you will observe the presence of occlusal wear facets, giving rise to attrition of the teeth. So that's a pathological phenomena by which the skeletal maturity indicator is not applicable. So the correct answer will be option C, that is attrition of the teeth. Little bit about dental calcification. We have talked about hand-breast radiograph earlier in the recorded lectures. We have talked about cervical vertebrae just now, just a few slides before. So let's talk about the dental calcification as well. One method is use of the mandibular third molars, the calcification stages of the mandibular third molar. In the stage 1, now this is observed in an OPG, X-ray. Stage 1 is when the tooth germ is visible as a rounded radiolucency. You can see here, the tooth germ is observed as a small rounded radiolucency. Second stage is when the cusp mineralization is completed. You can see the presence of cusp tips, which are completely mineralized and they appear as radio opaque on an OPG or even on an IOP X-ray. Third stage is when crown formation has been completed. You will observe the crown formation is totally completed in third stage. Fourth stage is when the root is half formed. You will observe the root is half formed in stage 4. And stage 5 is when the root formation is completed, but the apices are not yet closed. So there is blunderbuss canals in case of stage 5, where the root formation is completed, but the apex is not yet closed. Right? That is one method. And another method is developmental dental calcification redesign Demergence method. So you will observe the stages of calcification in molars, premolars, canine, as well as incisors. So the calcification stages are divided into 8 stages, starting from stage A to stage H. So in case of molars, we have A and B stages, whereas in case of canines and incisors, the first stage starts from stage C. That's the difference. You will observe the presence, in case of molars and premolars, you will observe the presence of calcification on the cusp tips, that is stage A and B. And the cusps have been completely formed in stage B, in both molars and for premolars. In stage C, the crown has been almost completely formed for all 4 types of the teeth, that is molars, premolars, canines, and the incisors. In stage D, the crown is completely formed. In stage E, the root formation has started to take place. In stage F, the root formation is half completed. Stage G, the root formation is almost 2/3 completed, whereas stage H is where the root formation has been completed and the apices have been completely closed. So that is where the maturation of the roots have taken place, and that is called stage H according to Demergence method of developmental dental calcification stages. So this is another method of assessing the amount of maturity which has occurred and which is yet to take place in the patient's mouth, in the patient's skeleton, and hence adequate treatment can be administered accordingly, right? So the correct answer will be, as I said, the skeletal maturity index is not measured by attrition of the teeth, whereas it can be measured by hand-breast radiograph, it can be measured by cervical vertebrae, and by dental calcification. For hand-breast radiograph, we have got multiple systems. We have got Jock, Grave, and Brown's method. Then we have got Fishman's skeletal maturity indicators. Then we have got Grulich, Piles, Atlas method. Then we have got Raj Gopal and Consul's method. Then we have got Singer's method, right? We have got Haag and Taranger method. So these are for hand wrist radiograph, right? And just to name a few, for cervical vertebrae, we have got Lampersky's method. We have got Hassel and Farman, as I have explained earlier. Then we have got McNamara's method. Then we have got Bacchetti and Franci's method. These two are Italian people, and they have collaborated with McNamara to make another method of classification of cervical vertebrae. They have just modified them into CS stage 1, CS2, CS3, CS4, CS5, CS6 stages. Okay, just to name a few, there are different methods given by different authors. Next is, which of the following wires is used in quad helix appliance? I hope this was the question, if I am not wrong, as I have received the inputs from different students. Options were 0.038-inch stainless steel wire or 0.038-inch LG Loy wire. I'm not sure whether these were the correct options. We can have 0.036-inch SS wire or 0.036-inch LG Loy wires as well. If 0.036 was the option, then 0.036-inch stainless steel wire is the correct option. Okay. Now, what is a quad helix appliance? It's a slow maxillary expansion appliance which was introduced by Ricketts in the year 1975, made up of 0.036 inches stainless steel wire. Let's look at it in detail. So this is the quad helix. Quad means 4, helix means helices. There are 4 helices in the appliance. 1, 2, 3, and 4. Right? Then we have got different wire components. This is the anterior bridge. These two are the posterior bridges. This one and this one are the posterior bridges. And these are the lateral expansion arms. So they are made up of 0.036-inch stainless steel wire. Quite heavy wire are used for the construction of this appliance. So the primary objective of using this appliance is for dentoalveolar expansion of the maxilla in the transverse dimensions. It is activated using what particular plier? 3-pronged plier. It is activated using 3-pronged plier. Okay. It is activated using 3-pronged plier. So if you have to expand the anterior segment in a lateral direction, you will put a 3-pronged plier like this, and you will give a configuration in the anterior bridge in a V-shaped manner. So this is going to cause expansion in the anterior segment in a lateral direction. Similarly, if you want expansion in the posterior segment, you are supposed to make the posterior bridge in this way. So that is going to maintain the expansion in the anterior direction, whereas it is going to cause expansion in the posterior direction, like this. Right? Right? This is what is all about the quad helix appliance. What are the indications? It is used for expansion of the narrow upper arch in cases of crowded mixed or permanent dentition, in class 2 malocclusions where upper arch needs effective widening and upper molars need distal rotation, In class 3 malocclusions, where upper arch needs effective widening, in cases of thumb sucking and tongue thrusting cases, there is a provision of soldering the tongue crib appliance on the anterior bridge of the appliance so as to be used as a habit breaking appliance in cases of thumb sucking and tongue thrusting habit. And it can also be used for expansion in unilateral or bilateral cleft palate cases. Expansion of 8 mm produces 14 ounces of force, and average force is approximately 200 to 400 grams. 1 ounce equals to 28.3 grams, according to the table of conversion. Okay, so you can calculate 14 ounces means how much grams. Next is, which of the following appliances is not an example of maxillary expansion device? Again, very simple appliance. Hyrix appliance, it is. Quad helix appliance is an example. Pendulum with hyrix screw, again, is an example of maxillary expansion device. Whereas Jones jig is a molar distalization appliance. It's a molar distalization appliance. That's why it is not an example of maxillary expansion device. What is the Jones jig? It was first introduced by Jones and White. So it is a buccally placed appliance. It is not placed palatally. So there's an anchorage unit having a modified Nance paddle button. So how is it constructed? You can observe that we have cemented a molar band onto the premolars as well as onto the molars as well. Okay, so these are the molar band which have been cemented on the premolars and molars separately, and the appliance is soldered. These arms of the appliance are soldered onto the premolar band, and an active arm is placed buccally, which has got a spring, which has got a compressed coil spring added onto it. So the compression of the spring produces forces, which is used for distalization of the molars in a distal direction. So this is the same appliance from the buccal view. You can observe that it has got a jig-like configuration of the wire, having a spring wounded onto it, and taking support from the anterior palate as well as from the premolars. This spring produces a compressive force directed towards the distal direction, hence causing distalization of the molar. So this is the appliance in real time, in real case scenario, and this is the appliance in real time in a patient's mouth. Okay. So this is called a Jones jig appliance, and it is not an example of maxillary expansion device, whereas it's an example of molar distalization device. Next question, again an incomplete question and option, hence I need input from the students. Difference between self-etch and conventional bonding system is. Now, I don't know about other options, so that's why I will write just the right answer. That is, the bond strength in a self-etching bonding system is more than that of a conventional bonding system. So in conventional bonding system, the bond strength is approximately 8 to 12 megapascals, whereas in a self-etching bonding system, it is approximately 17 megapascals. That is what the articles quote. Hence, the correct option will be, the correct answer will be that the bond strength is more in self-etching bonding system rather than conventional bonding system. Right? So if that's all about the recall session, I am not sure whether I have covered all the questions. If there are any other suggestions or any other recommendations to improve the language of the question, or if any options were not correct, because these are all memory-based questions. These are all the options and the questions I have placed in the today's presentation just on the basis of memory. which I have obtained from different students, and the DBMCI organization has also obtained from different students. So there are chances that there might be some errors, inadvertent errors, unintentional errors, which might have crept in. So I would want you students to please make a note of those errors, and that is applicable for all the subjects, not only orthodontics, that is applicable for all the subjects. There might be certain discrepancies in the actual question, which was actually asked in the exam, and which is replicated by means of the memory recollection, and that's why there are chances that there might be certain rooms of error, and hence we are all humans. There is always chances of improvement. The organization works tirelessly. Everybody works tirelessly in the organization, including the faculty, the backend team, the students, the management team, everybody, to give you the best possible results, so that there is no doubt, there is no room for any doubt that the students have to second guess the questions or the answer which are put against those questions, and they have to go for cross checking or cross referencing from other authentic source, or other coaching institute platforms. So if you have got any doubts, you are very much welcome to ask any of us on Facebook and Telegram group. And always remember, don't settle, don't stop. And I would want you not to leave this chat, this Zoom meeting right now, because very shortly we'll be starting with the recall session of Pharmacology chapter, Pharmacology subject by Dr. Saurabh Bhatia. So please stay tuned. Have a nice day. All the best.
Yes, so Dr. Kunal, a very good afternoon to you. Dr. Kunal, am I audible? Right, guys. So, welcome to this session, Pharmacology. So it was a great great learning from Dr. Kunal. So although he was not able to connect with us. So I am Dr. Saurabh Bhatia, your pharmacology guru at DBMCI. So we would be discussing this pharmacology question. So as far as the level of question is concerned, which was asked in your exam. So I would say the level is moderate, right? So the level was moderate, right? So the level was moderate. The questions were not very easy. Questions were not very difficult. So according to most of the students, the level of the overall paper level was also moderate, right? So we talk about the various questions. Question number one. The question was, which of the following combination is not a rational combination? So they asked, which combination is not a rational combination? Then you can see they have given you the options of like medicine, sulbactam, tazobactam, and clavulanate, right? And you must be knowing these three compounds are the beta-lactamase enzyme inhibitors, right? So they are the beta-lactamase enzyme inhibitor. It means these medicines are added to the antibiotics. These chemical compounds are added to the antibiotics whenever the bacteria is producing beta-lactamase enzyme against the antibiotic. So when the bacteria is producing beta-lactamase enzyme against antibiotic, then you will add a beta-lactamase inhibitor to the antibiotic. Right? So very simple. The bacteria is producing beta-lactamase against which group of antibiotic? Answer is beta-lactam antibiotic. So here there are three medicines they have given, which are beta-lactam antibiotics. So against three beta-lactam, bacteria can produce beta-lactamase. Bacteria cannot produce beta-lactamase against tetracycline. For tetracycline, bacteria has to produce a different set of enzyme. Right? That's quite obvious. That's why this combination is irrational. There is no point of binding a beta-lactamase inhibitor along with a non-beta-lactam antibiotic. So question number one, the irrational combination is tetracycline plus tazobactam, which was the answer of this question. So we can see most of the questions have come from the same topics like antimicrobial. So they have covered the topic like antimicrobial. They have covered the topic like general pharma. So antimicrobial, general pharma, central nervous system, these are 3 or 4 main topics which these people have covered in your exam. So let's talk about the question number 2, which was based on painkillers. So pain is an important topic in dentistry. We know that whenever we have the tooth pain, we have a lot of pain. We can feel this pain. So question was, which of the following is a selective COX-2 inhibitor? So which medicine is selective COX-2 inhibitor that is available by parenteral administration? So the medicine that is available by parenteral route. So here the answer is parecoxib. So guys, we know that any medicine that is inhibitor of COX-2 enzyme ends with our coxibs, right? So medicines which are inhibitor of COX-2 enzyme, we call them coxibs. Now 4 coxibs names are given to you: celecoxib, rofecoxib, valicoxib, parecoxib, right? Now guys, these medicines are mainly given by oral route. These medicines are mainly given by oral route, but parecoxib is a water-soluble form. It's a water-soluble form of valicoxib. It's a water-soluble form of valicoxib. So this is the one that we can give by IV route, right? So question number 2, answer is D, Delhi. Parecoxib is the answer of this question. So guys, question number 1, we have discussed during our lecture also. In case you people have attended our lectures, you must be knowing the answer was B. It was an easy question. Question 2, although we didn't discuss during our regular batch lecture, but we discussed some drugs names during our lecture, that celecoxib, rofecoxib. So they have this time given one uncommon drug, parecoxib. So this was a thing that was not covered in our lecture, but it's fine because the AIMS people don't give you 10 out of 10. There are some questions which definitely misfire from our usual notes, right? So question number 2, answer is parecoxib. The new question, the new drug they have asked. Now question number 3, it's regarding our drug puromycin. Now guys, puromycin used to be an antibiotic, right? There was a clinical trial which was done for puromycin, but this medicine couldn't hit the market. Because of some safety issues, this medicine couldn't come into the market. So puromycin is a medicine which is actually not clinically used, but this medicine is an protein synthesis inhibitor. They asked the mechanism of action of this medicine, which is a protein synthesis inhibitor, right? So the drug which is protein synthesis inhibitor, now this medicine is inhibitor of an amino acetylated transfer RNA. So according to some students, only transfer RNA word was there, right? According to some students, they have given the word as ribosylated transfer RNA. So guys, whatever was the thing, basically what happens, transfer RNA is the important RNA which has a responsibility to take the anticodon. So this get loaded with the anticodon and place the anticodon at the active site, that is the A site, right? So ribosylated transfer RNA is the one that will take up the anticodon from the cytoplasm and place it on the A site. This is how the protein synthesis will take place, and we call it the process of translation. Now, we have a drug that is puromycin. This medicine is inhibitor of this ribosylated transfer RNA, right? So question number 3, answer is B, right? So here we have a drug elongation factor G inhibitor. So elongation factor G inhibitor, this medicine is a drug known as fusidic acid. So we have a drug over here which is elongation factor G inhibitor. Drug name is fusidic acid. So fusidic acid is a drug which is inhibitor of elongation factor G. And there are many antibiotics you must be knowing which will act on 50S ribosome. So question number 3, answer is B, Bombay. Medicine is inhibitor of transfer RNA activity, that is amino acylated transfer RNA activity. Drug name is puromycin. Now let's talk about question number 4. Now question number 4 is based on medical emergencies, that is anaphylaxis. So the question is, which statement is true about anaphylaxis, which is a severe form of drug allergy or any type of allergy, anaphylaxis. So guys, we people know what is the drug of choice for anaphylaxis. So anaphylaxis, drug of choice is epinephrine. So this we have covered so many times during our lecture that the drug of choice for anaphylaxis is epinephrine. So it is preferred over norepinephrine. Yes. So this statement is true. So this statement is true that epinephrine is preferred over norepinephrine. This is true because epinephrine is a drug. This medicine will act on alpha-1 receptor and can increase the blood pressure, which is one of the reasons why the patient will die in anaphylaxis. The patient dies in anaphylaxis due to low BP. So this medicine can increase the blood pressure, plus this medicine will act on beta-2 receptor. And by acting on beta-2 receptor, this medicine can result in bronchodilation. Medicine can result in bronchodilation, but norepinephrine is a drug which will only act on alpha-1 and can increase the blood pressure, but this medicine has no effect on bronchioles, so this will not cause bronchodilation. So this medicine will not cause bronchodilation. So norepinephrine will not cause bronchodilation. This will only increase the blood pressure. The drug name is norepinephrine. That's why the epinephrine is preferred, because the patient will die in anaphylaxis due to low blood pressure as well as because of bronchospasm. So epinephrine is a preferred medicine for that. Now, how we use this epinephrine in treatment of anaphylaxis? So the best route is intramuscular route. So epinephrine is used by intramuscular route. So intramuscular route is the best route of giving the medicine. In case intramuscular route is not given to you, and if your patient is stable. So if your patient is stable, we can also use medicine by subcutaneous route. So the best route is intramuscular route. In case our patient is stable and we don't want to give medicine by intramuscular route, we will give medicine by subcutaneous route. The second most preferred route is subcutaneous route. Now, if we want to give medicine by IV route, if we want to give medicine by IV route, like if I inject epinephrine by IV route, there is a risk of arrhythmia. So in this patient of anaphylaxis, guys, please remember, because of the effect of histamine, histamine is a chemical that is released in anaphylaxis. So because of the effect of histamine, the patient heart is already in the stimulatory site. The patient is already having the tachycardias, right? So in that condition, if I give medicine by IV route, there is a risk of arrhythmia. So whenever I want to use epinephrine by IV route in patients of anaphylaxis, we have to give very low dose. We have to give very low dose of adrenaline to this patient if we want to give medicine by IV route. Like if I want to give medicine by intramuscular or subcutaneous route, the dose of the medicine is 0.5 milligram of 1:1000 dilution. But if I want to give medicine by IV route, the dose of the medicine is 0.1 milligram. Can you see, guys? I have reduced the dose 1/5. I make the dose 1/5 of the normal dose. So I'm only giving the dose 0.1 milligram. So 0.1 milligram of the drug of the diluted form 1:10,000. Right? Can you see? Like I'm diluting the medicine also. Previously in previous case, I have discussed that I am giving the concentration 1:1000. Here I am giving the concentration 1:10,000, which is even more diluted form of the adrenaline, and the dose is now 1/5. Dose is now 1/5 of the normal dose. That's why the IV route is not preferred. IM route is preferred. The second most common route is subcutaneous route. So if the statement will say subcutaneous route is preferred over intravenous, yes, this statement can be taken as a true option. This statement can be taken as a true option, and intravenous route is preferred over intramuscular. This is a false option that we have already covered, right? So that is already covered. Now, phenylephrine is preferred over norepinephrine and epinephrine. No, guys, phenylephrine is a drug. This will only act on alpha-1 receptor. And by acting on alpha-1 receptor, this will increase the BP. But this medicine has no effect on blood pressure. So just like norepinephrine, this medicine cannot cause bronchodilation. This will not act on beta-2 receptor. So this medicine will not cause bronchodilation. That's why this is not preferred over norepinephrine and epinephrine. So this statement is also false. So two statements are clear-cut false. Now we have to choose a one answer between A and B, right? So guys, if you ask me what is a better answer, so guys, I will go for this one. So this is a clear-cut answer that epinephrine is better drug for anaphylaxis than norepinephrine. It's a clear-cut answer without any doubt. In option B, subcutaneous route is preferred over intravenous, although there is no study which suggests that subcutaneous route is better. But in practicality, we give subcutaneous route, we give medicine by subcutaneous route over the intravenous route. But there is nowhere written, like there is no theory which suggests, there is no comparative trial which has been done where we have compared the subcutaneous route with the intravenous route, because the doses are different. If I keep the dose same, then I can compare these two routes. But guys, there is no such trial have been done. So the better answer which you have to choose out of A and D is A. So A is a better answer to be chosen instead of B. So question number 4, answer is A. Now let's move on to question number 5, which was a very, very easy question. We discussed so many times during our lecture. And I think all of you have marked this question as correct answer, right? So none of the student can mark this question wrong if you're actually preparing for your AIMS exam. So question was, which route of the drug administration has maximum bioavailability? So bioavailability means how much drug is reaching the plasma. So how much drug is reaching the plasma? So it is the amount of drug that reach the plasma. So amount of drug that reaches the plasma is the bioavailability. So it's very simple to know which route has maximum bioavailability. Answer is intravenous route. So whenever we give medicine by intravenous route, 100% drug will reach the plasma. So we say that the bioavailability of the medicine is 1. So bioavailability is always a fraction basically, right? It's calculated in fraction. So maximum bioavailability of a drug is +1. Right? If I say the medicine is given by subcutaneous and intramuscular route, so approximately 80% drug. Approximately 80% drug will reach the plasma. So I will say the bioavailability is 0.8. So bioavailability is 0.8. And whenever we give medicine by oral route, approximately 60% drug will reach the plasma. So the bioavailability is 0.6. So we can say here the bioavailability is maximum by giving the medicine intravenous route. So intravenous route is the best route of drug administration, we all know, and the monitoring is easiest when we give medicine by intravenous route. So question number 5, answer is C, right? So question 5, answer is C. Now, if we talk about question number 6, the question number 6 is also a very easy question we discussed during our lecture so many times. So guys, in case you people have attended our lecture, you must have scored around 70 to 80% marks, because that is easily covered during our lecture. So those things are easily covered, are very commonly covered in our lecture. So you people must be knowing the answers of these questions very well. Now, this was one of the example. Now, H2 receptor antagonist medicines. H2 receptor antagonist medicines will act on which cells of GIT? So very easy. H2 receptor antagonists are the medicines which are blocker of acid secretion. So these medicines are blocker of acid secretion by acting on the parietal cells. Parietal cells are the one which will secrete the acid. So parietal cells are the one which will secrete the acid. So parietal cells will release H plus ion, and now this will bind to the chloride. So parietal cells will secrete H plus ion with the help of proton pump. So on the surface of parietal cells, we have the presence of proton pump which secrete the H plus ion, and chloride ion is the one that is released by the canaliculi cells. So we have the presence of canaliculi cells in vicinity of the parietal cells. We have the other cells, we call it canaliculi cells. So H will bind to Cl, and this will form the acid in our GIT. We call it HCl, right? So G cells are the one that will release the gastrin hormone. This will release the gastrin hormone. So guys, please remember, H2 receptor antagonist. H2 receptor antagonist will never act on G cells, right? So gastrin secretion is not reduced by H2 receptor antagonist. Enterochromaffin cells are the one. Enterochromaffin cells are the one which will release histamine in the GIT. So this will release histamine in the GIT, and they can also release serotonin in the GIT. They can release serotonin in the GIT. So actually, guys, what happens exactly? So we have the presence of enterochromaffin cells. Actually, the exact word should be enterochromaffin-like cells. So the cells are ECL, like we call them ECL, enterochromaffin-like cells. So enterochromaffin-like cells are the one which can release histamine in our GIT. Now, this histamine that is released in our GIT, enterochromaffin-like cells, this histamine will act on a receptor, that is a H2 receptor, which is present on the parietal cells. And now this will activate the proton pump, and when this proton pump is activated, this will release the H plus ion, right guys? So we have the medicines which are H2 receptor antagonist. So the question is, H2 receptor antagonist will act at which location? Answer is parietal cell. They will not act on enterochromaffin cells. So enterochromaffin like cells are the one which release histamine, and enterochromaffin cells are the one which will release serotonin. So guys, in MCQs, if the option was EC cells, serotonin is released. If the option was ECL cells, ECL, enterochromaffin-like cells, then the answer is histamine that is released, right? Now, chief cells are the one which are different cells of the GIT. They're also involved in acid secretion, but here the better answer you have to mark is parietal cells. The better name, the better cells are the better answer is parietal cells. Although chief cells are also involved in acid secretion, but parietal cell is a better answer to mark here. I can see, I can have some doubts also. I can take some doubts. So you people are asking doubts in your groups. So I can see the doubt asked by Dr. Shia. Okay, so the doubt is cleared already. Okay, the doubt is cleared already. Okay, so guys, in case you people have doubts, you can also put a message on this Telegram group. So I'm there with you. This Telegram group is open. So in case you have any doubt, you can also put your queries in Telegram group, right? Question number 7. Now, question number 7, we have also discussed during our lecture. Patients suffer from depression, right? And I think the question is missing a drug. So patient is suffering from depression and she took a medicine. The medicine name which was given in the MCQ was citalopram. She took a medicine. The name of the medicine was escitalopram. So she took a medicine, that is escitalopram. Now, escitalopram is an antidepressant medicine which belongs to this class of SSRI. So she took a medicine, escitalopram, which belongs to a class of SSRI, and she also got a buccal lesion. She was already on antidepressant. Now she has got a buccal lesion for which an antibiotic was prescribed, that is a linezolid. So linezolid is an antibiotic which was given for this buccal lesion, right? Despite of this, like buccal lesion says gram-positive bacteria is involved, so we can give linezolid for there is no harm in giving the antibiotic, right? Now, what is a possible drug interaction that will take place? So, guys, here you must be knowing the side effects of SSRIs. You should also be knowing the side effects of linezolid. So what are the side effects of linezolid? For linezolid side effects, you can remember this mnemonic BSNL line, where the line stands for linezolid. Line stands for linezolid, B stands for bone marrow suppression. B stands for bone marrow suppression. S stands for serotonin syndrome. S stands for serotonin syndrome. N stands for neuropathy. So this medicine can cause bone marrow suppression, serotonin syndrome, neuropathy, and the medicine can also cause lactic acidosis. So these are the 4 important side effects of linezolid that you must be knowing for your exam. Now, if we talk about side effects of SSRIs, so what are the side effects of SSRIs? So for side effects of SSRIs, we can remember this mnemonic. The mnemonic is Go SSRIs. So here the G stands for GIT side effects. So this medicine can cause nausea, vomiting, and diarrhea. GIT side effects means always nausea, vomiting, and diarrhea. Now these medicines can also lead to osteoporosis. So medicines can result in osteoporosis as a side effect. Now these medicines can cause sexual dysfunction. Medicines can cause sexual dysfunction, which is the second most common side effect. The most common is GIT side effects. The second most common side effect is sexual dysfunction. Now, these medicines can also cause serotonin syndrome. So, because of excessive serotonin, these medicines can also cause serotonin syndrome. Now, these medicines can result in recurrence of symptoms. So, there is a possibility of recurrence of symptoms whenever you stop short-acting SSRIs. So, recurrence of symptoms can occur when you stop the short-acting SSRIs suddenly, abruptly. So if you're taking a short-acting SSRI and if you stop it or withdraw it, or if you discontinue the treatment suddenly, abruptly, there is a risk of recurrence of symptom that will occur. And the last is this medicine can cause insomnia. So medicines can interfere with the sleep and can lead to insomnia as a side effect. So SSRIs can lead to 6 side effects. Linezolid can lead to 4 side effects. And you must have noticed what is the common thing here. The common thing is serotonin syndrome. And this is the condition which is suggesting you the serotonin syndrome. So whenever you take linezolid and SSRIs together, this will lead to serotonin syndrome as a side effect. Here the serotonin level will be very high. And this serotonin will mainly act on 5-HT2 receptor. And by acting on 5-HT2 receptor, this will result in hypertension. This can result in hypertension. This can result in tachycardia. So can result in hypertension, can result in tachycardia, can result in tachypnea, can result in seizures also. So these kind of symptoms can be there. Hyperthermia can be there. So the best answer to be marked over is hypertension. So by acting on 5-HT2 receptor, this will result in hypertension. This is a drug interaction between linezolid and SSRIs. So guys, what are the various medicines which can lead to this serotonin syndrome? So linezolid can result in serotonin syndrome. We have an opioid. The drug name is tramadol. Tramadol is an opioid which can cause serotonin syndrome, which is important for a dentist to know because tramadol is one of the very common painkiller that we use in dentistry. So tramadol is a painkiller. Linezolid can lead to serotonin syndrome. Similarly, we have one more opioid, pethidine. So pethidine is a opioid that will lead to serotonin syndrome. Plus, we have some antidepressant medicines. So antidepressant medicines like SSRI, tricyclic antidepressants, SNRI. So all these medicines are never combined together because combined them, they will lead to serotonin syndrome as a common manifestation. So question number 7, answer is C. Hypertension is a manifestation which will occur when you combine SSRIs, that is escitalopram, along with this medicine, that is linezolid. Now moving on to question number 8, guys. So again, the second question is based on second question of adrenaline. So adrenaline is a very, very important drug. I have told you so many times during my lecture that the medical emergencies, particularly this medicine, adrenaline is very important for your exam. So in which condition we will not use adrenaline as a drug? So one we have discussed above in the previous question. So examiner has given 2 questions based on same concept like anaphylaxis. I don't know what the examiner wants to do. So adrenaline is drug of choice for anaphylaxis. This we already know. Now, CPR is a condition that we do in patients of cardiac arrest. So any patient comes to you with cardiac arrest, again, the drug of choice is adrenaline. So adrenaline, drug of choice for anaphylaxis. Adrenaline is drug of choice for cardiac arrest. So the important difference is in the dose. So guys, what is the difference in the dose? Here we use the concentration 1:1000. Here we use the concentration 1:10,000. So here we use the concentration 1:1000 and 1:10,000. Here the dose of the medicine is 0.5 milligram. Here the dose of the medicine is 1 milligram. Here the dose of the medicine is just double, that is 1 milligram. Here we inject the medicine volume 0.5 ml. Here I inject the volume 10 ml. Here I want to inject the volume 10 ml. Now what is the route of administration? Here the best route is intramuscular route. Here the best route is intravenous or the intraosseous route. So here the route is intravenous or intraosseous route. There's a difference between the adrenaline dosage in patients of cardiac arrest and anaphylaxis. Plus, guys, adrenaline is a drug that will act on alpha-1 receptor. And by acting on alpha-1 receptor, this medicine can increase the blood pressure. That is why I'm using this medicine in the treatment of cardiac arrest also. So this drug is used as a vasopressor. So adrenaline can be used as a vasopressor. And in dentistry, you must be knowing this medicine is used as a vasopressor along with local anesthetic drug. So along with local anesthetic drug, this medicine can be given as a vasopressor. So Torsades de Pointes is an arrhythmia. Torsades de Pointes is an arrhythmia where adrenaline has no role. So adrenaline has no role in treatment of Prosthodontics de Pointes. It is a type of arrhythmia where adrenaline is not used. Rather, adrenaline can stimulate this arrhythmia further. So here the drug of choice for Prosthodontics de Pointes is magnesium sulfate. So in acute emergencies, Prosthodontics de Pointes, I can use magnesium sulfate as a drug of choice. So question number 8, best answer is B, Bombay. Rest of the conditions where we can use adrenaline are given this MCQ. The B, the Prosthodontics de Pointes, we don't use the medicine adrenaline. So question number 8, answer is B, Bombay. Question number 9, pregnant female comes to you with UTI. So guys, this is something very serious because female is pregnant and she is having the UTI. There is a high risk that her kidney get involved. So we need to treat this female. So pregnant female comes to you with UTI and you have given an antibiotic for her infection. Now her baby has developed discolored and the malformed teeth. So baby has got discolored and the malformed teeth. When the baby is born, baby started developing. So baby has got this problem of teeth. Right. So I'm a bit doubtful why examiner has given the question like this, because female is still pregnant. Right. So you have given an antibiotic. So when the baby is born, babies usually don't have the teeth on birth. Right. Okay, fine. It's fine. Like they have given a hypothetical state where the baby has got discolored and the malformed teeth. Now, which drug is responsible for this? So guys, we know that tetracycline group of medicines can lead to this problem. So we have different types of tetracyclines which are given. Now, this is a bit difficult question, bit dicey question, because there is no clinical study which suggests the difference between tetracycline and oxytetracycline. No study will say that which drug has more incidence of teeth discoloration. It's a bit difficult to find out, but still there are many studies which have been done. According to those studies, all old tetracyclines, all the medicines which are the older tetracycline group of medicines, they have the more risk of teeth discoloration than the new medicine. Like the newest medicine in this class is doxycycline. So doxycycline is a medicine that we use clinically these days. So this medicine has minimum incidence of teeth discoloration. This we know. This is well proven. There are many clinical studies which suggest that doxycycline will cause minimum teeth discoloration. It's the newest form of the tetracycline. But out of tetracycline, oxytetracycline, which is a better answer? I'm still searching. In case, guys, I'll try to find out. In case I'll come across with any clinical studies which suggest the difference between two, I'll come back to you. So for the time being, I'm just telling you that both medicines can lead to teeth discoloration. But still, out of these two, the older one is tetracyclines. So considering the fact which is proven in many clinical trials, all the old tetracyclines will have more risk of teeth discoloration. I would go for tetracycline as a best answer. Right? I would go for tetracycline as the best answer. I will not say oxytetracycline, but still, again, I will say, excuse me for this question because I'm still searching the answer that which is a better answer in tetracycline, oxytetracycline. But definitely, azithromycin will not cause teeth discoloration. Ciprofloxacin, when given to children, this can lead to tendon and the cartilage rupture. This can lead to rupture of tendon and cartilage. So this kind of history can be given. So if the child has taken ciprofloxacin, or if any old patient has taken ciprofloxacin, the child can develop rupture of tendon, rupture of cartilage. So these problems can occur. So these problems can occur in a patient after taking fluoroquinolones, right? So question 9, A and B, both can be the possible answer. According to me, for today, answer is tetracycline. But in future, if I'll come to know the answer is oxytetracycline, I'll definitely update you on the DBMCI platform, right? Now question number 10. Now, question number 10 is regarding a graph. So there is a graph given to you. In this graph, you have to find out the answer. So this graph is showing you the peak effect of the medicine. You can see there is a graph which is showing you the peak effect of the medicine. And on x-axis, we have given the logarithm of the dose. So peak effect is shown and the logarithm of dose is given. And they have given you the 4 statements and they asked you which statements are correct. So which statements are correct? They asked you this question. So guys, you can see, if we compare the height of the graph, like this is a DRC, we call it DRC, dose response curve. In this dose response curve, if we compare the height of the graph, so if we compare the height of the graph, more is the height, more is the efficacy, less is the height, less is the efficacy, right? So if I say which drug is most efficacious out of all these, which drug is most efficacious out of all this, you can see B has the maximum height, it's the most efficacious drug, followed by C and D. So C and D almost have the same height, so they have the almost equal efficacy, and A has the minimum efficacy because it has the minimum height. Now, the second thing we can compare in this graph is the drug potency. So whenever we have to compare the drug potency, we always look at the position of the graph on the x-axis. So we can look at the position of the medicine's graph on the x-axis. So the graph is on the left side. So any graph that is on the left side is more potent. So any graph is on the left side that is more potent than the graph which is on the right side. Then I will say the drug A is the most potent medicine, followed by B, then C, then D. So in potency, we always look for the position of the graph on the x-axis. Then we compare the most left side is more potent. And in efficacy, we always compare the height. So more is the height, more is the efficacy. So here now we can see easily drug A has maximum potency. You can see here, yes, this statement is true. So statement A is true. Drug A has maximum potency. Now B and C are competitive inhibitors. Right, guys? So if I have to draw the graph of competitive and the non-competitive block, so I will draw the graph like this way. So this is the graph which is showing you the competitive block. So guys, here the most important point you have to consider in a competitive block, this is always said, this is always expressed in terms of one drug. Like the drug should not be changed. I would say this is the graph of drug A, and this is also the graph of drug A, but now I'm giving the high dose of the drug A. So in a competitive block, which is easy to overcome in the body, when I increase the dose of my drug, right? So drug A should remain same. Only thing is I have to increase the dose of the medicine on the x-axis, so the graph will be shifted towards the right side. So in a competitive block, the graph is shifted towards right side. And in non-competitive block, if I say this is a graph of drug A, then the same drug A graph is now become flat. So we call it flattening of DRC. So this is known as flattening of DRC. So flattening of DRC will show you the non-competitive block. So flattening of DRC will show you the non-competitive block. Right shift of DRC will show you the competitive block. But guys, here you have to understand one thing. The graph or the drug remains same. Here, what is going on? Here, the drug is changing. You can see the drug B and drug C. Here, the drug is changing. So how can we say which is competitive or which is non-competitive? We cannot say like this way. So in the presence of a blocker, the drug should remain same, but we have to give the higher dose. So we cannot say that drug B and C are competitive inhibitors. So this statement is false. Now the statement C is saying B is more efficient than C. Yes, this is true because B height is more than C. So this is true. And C is more potent than B. No, guys, you can see the C graph is on the right side. You can see the C has less potency than B. So this statement is again false. So statement number A and C. Statement number A and C are true. So here the answer is C. A and C are correct options. So A and C are correct option. So question number 10, answer is C. A and C, two options are correct here in this question. Now patient is taking NSAIDs. Patient is taking NSAIDs. Now which of the following effect will take place in the body? So the patient is taking a painkiller, that is non-steroidal anti-inflammatory drug. Now these medicines will inhibit the COX enzyme. Now by inhibiting the COX enzyme, they will stop the prostaglandin E2 synthesis. So prostaglandin E2 synthesis will not take place. So this will cause vasoconstriction. This will cause vasoconstriction in kidney, although this will cause vasoconstriction everywhere. So by inhibiting the prostaglandin, this will reduce this will increase the tone of the blood vessel. So vasoconstriction will take place everywhere, including kidney. So that will decrease the GFR. So when you reduce the blood flow towards the kidney by causing the vasospasm, so because of vasoconstriction, kidney blood flow is reduced, so GFR will decline. So GFR will decline when we reduce the kidney blood flow, right? So we can say in the presence of painkiller, diuretic effect of the drugs will decrease. Yes. So diuretic effect of the drug will decrease in presence of painkiller. This statement is true. Now you can see NSAIDs are the medicines which are inhibitor of prostaglandin E2. Now prostaglandin E2 is a protective compound. It's a protective compound in GIT which will protect our GIT mucosa to get injured by the acidic media. So this will protect our GIT mucosa to get injured by the acidic media. So this is a preventive factor. This is a protective factor from the peptic ulcer disease. So whenever we give NSAIDs or whenever we give steroids, So both NSAIDs and steroids can inhibit this. So one is non-steroidal drug, second is steroidal drugs. So both NSAIDs and steroids are the inhibitor of prostaglandin E2 synthesis. By inhibiting this COX, or maybe steroids will inhibit phospholipase A2. So they are result in more risk of peptic ulcer disease. So they can result in more risk of peptic ulcer disease, and that will lead to more chances of bleeding. That will lead to more chances of bleeding. So statement 2 is saying GIT bleeding risk is there if patient is on anticoagulant therapy. So if the patient is on anticoagulant therapy, patient is already at the risk of bleeding. Patient is already at the risk of bleeding, and if you give NSAIDs, then GIT ulcers will also start bleeding. So this statement is also true. So this statement is also true. Now, bleeding risk is increased if taken with phenytoin. So phenytoin is an anti-epileptic drug. Phenytoin is an anti-epileptic drug. Now, this medicine is a liver enzyme inducer. So this medicine can induce the liver enzyme. So because this medicine is liver enzyme inducer, this medicine can induce the metabolism of vitamin K. So vitamin K is a vitamin which is metabolized in liver. So phenytoin is an antiepileptic which can induce the metabolism of vitamin K, and patient will suffer from vitamin K deficiency. So the patient is at high risk of bleeding. Patient is at high risk of bleeding. So this statement is also correct. NSAIDs by inhibiting COX enzyme. NSAIDs by inhibiting COX enzyme, they also stop the synthesis of thromboxane A2, and by inhibiting thromboxane A2, they can also increase the risk of bleeding. So NSAIDs can increase the risk of bleeding. Phenytoin can also increase the risk of bleeding. When given together, the risk of bleeding will increase. Particularly, which NSAID can increase the risk of bleeding? Answer is aspirin. So aspirin is a NSAID which has an antiplatelet property. Aspirin is an NSAID which has an antiplatelet property. This can increase the risk of bleeding. So we are assuming here the patient is taking aspirin plus patient is taking phenytoin. The bleeding risk is increased. Yes, the bleeding risk is also increased. Now, the guys, fourth option is not known to us. So here we can say, like, because this is a multiple choice question, as we don't know the fourth option, we cannot suggest like what are the permutation combination they have asked in the options. So you can say if there is an option A, B, C are correct. If there is an option in this question, A, B, C are correct, this is the best answer of this question. So totally depends upon what is the fourth option. Because if the fourth option is also correct, then we can say A, B, C, D are correct. So totally depends upon what is the fourth option. In case, guys, you people know what is the fourth option, you can directly message me in the Telegram groups. I'm just scrolling the Telegram group side by side. In case you people know what is the fourth option, because we have asked this question from few students, but right now we have so many students listening to us right now. So in case you people know what is the fourth option here, you can also message me in the group. So I will be happy to add on this fourth option over here. So question number 11, answer is D. Answer is ABC are correct. The fourth option we don't know. So according to the options, we can go for the answer. Now let's talk about question number 12. Now question number 12 is a repeated question. This we have already covered. So question 12 is already covered. We have covered this question in a previous part, right? So question number 13, a patient on OCP. It's not OCT. OCT is done in your dentistry. So OCP means oral contraceptive pills or oral combined pills. So patient is on oral contraceptive pills, comes to you with failure of contraception. So comes to you with failure of contraception when co-prescribed. When co-prescribed with which drugs? So guys, this question is very easy. We discussed so many times during our lecture. So you can see only 2 or 3 questions are there which we have not covered during our lecture. Almost 10 questions we have covered during our lecture, straightforwardly asked from our lectures. So this is the beauty of the lectures, right? This is the beauty of this DBMCI regular lectures. So you will come to know which medicines are liver enzyme inducers, liver enzyme inhibitors. So that we have made our mnemonics during our lecture, the medicines which are liver enzyme inducers. So which medicines are liver enzyme inducers? They will induce the liver enzyme and can metabolize the contraceptive drugs. So they can induce the metabolism of contraceptive drug, and this will lead to contraception failure. So the medicines which are liver enzyme inducers, we can discuss a mnemonic that is CAR gas. So during our lecture, we have also discussed this mnemonic, the medicines which are liver enzyme inducer. So we have the corticosteroids. Corticosteroids are the liver enzyme inducers, anti-epileptic drugs. So anti-epileptic drugs are liver enzyme inducers except sodium valproate. So all antiepileptics are almost liver enzyme inducers except sodium valproate. Now R stands for rifampicin. Rifampicin is a drug which is also a liver enzyme inducer. We have a drug grisofulvin. So grisofulvin is an antifungal. This is also a liver enzyme inducer. And your favorite drug, alcohol, which you consume day and night, it is also a liver enzyme inducer. And the second favorite is smoke, that you also consume day and night in metro cities because of the pollution. So corticosteroids are liver enzyme inducer, anti-epileptics are liver enzyme inducer, except sodium valproate. Rifampicin is inducer, grisofulvin is inducer, and alcohol and smoke is also an inducer. So in this MCQ, they have given you three medicines which are liver enzyme inducer. So phenytoin, phenobarbital are the anti-epileptics. So these two are anti-epileptic drugs. Rifampicin, this is rifampicin. Rifampicin is a drug which is also a liver enzyme inducer. So answer is 2, 3, 4. So 2, 3, 4 are correct. So sodium valproate is liver enzyme inhibitor. Rest of the medicines are liver enzyme inducers. So question 13, answer is 2, 3, 4. C option is correct. Now question number 14, again this is asked from our notes. So which beta-lactam antibiotic? Which beta-lactam antibiotic is not given as a monotherapy, right? So answer here is imipenem. So imipenem is a drug which is not given as monotherapy. This medicine is always given with cilastatin. So this medicine is always given with cilastatin. So guys, please remember, imipenem is a drug. This medicine is rapidly metabolized. This medicine is rapidly metabolized by This drug is rapidly metabolized by dehydropeptidase enzyme. So it is rapidly metabolized by dehydropeptidase enzyme. And because this is rapidly metabolized by dehydropeptidase enzyme, imipenem is metabolized by dehydropeptidase enzyme. So in order to increase its effect in the body, in order to prolong its effect in the body, we have to give it with cilastatin. So cilastatin is a drug which is dehydropeptidase enzyme in kidney. It's an inhibitor of dehydropeptidase enzyme in kidney. So it will stop the metabolism of imipenem in the kidney. So it is always given with cilastatin, never given as a monotherapy. Right? So here the answer is C. Rest of the medicine, meropenem, dorepenem, these medicines can be given as a monotherapy, as a separate medicines, right? Now D option we did not know. So in case guys you people know the answer, let me know the D choice. But the answer is going to be imipenem even in that case also. I hope the fourth one is also some penim. Some penim name is given. So question 14, answer is imipenem. Right? So there is one question they have given 2 times. So total 13 questions have been asked in pharmacology. And out of the 13 questions, 11 questions we people have covered during our lecture. Right? So 11 questions we have covered. So 2 questions you have to play the game, because AIMS people will never give you 10 out of 10. This you already know. So guys, this is the beauty of our DBMCI lectures. You can see, right? So you can crack the exam easily because we people have so many courses for you. We'll give you so much of revision. We'll give you so many of tests. We give so many tests to you, and you can assess yourself. You can also have the class notes with you. Also, you have this kind of teaching where we can rule out the other options from one, so that all your concepts will be clear. Concepts are clear, crystal clear. So guys, don't settle, don't stop. We are here to help you out in all the exams. So now I'm ending up this pharmacology session. So I invite Dr. Pooja Johari to come and take the charge or take the lead of this platform. So Dr. Pooja, biochemistry faculty. Dr. Pooja, if you are there, if you're listening me, can you please switch on your camera so that, yes, we can see Dr. Pooja has come. Dr. Pooja, welcome to you. So I'm now giving the baton to you. Take the lead from here and discuss your beautiful biochemistry with students. Okay? Dr. Pooja.
Yeah, hello, good afternoon.
Can you please switch on your camera so that?
Yeah, sure. Yeah, sure.
We can see Dr. Pooja has come. Dr. Pooja, welcome to you.
Yeah, thank you. I'll just.
Now giving the baton to you.
Yeah, thank you.
From here and discuss your beautiful biochemistry with students. Okay?
Thank you so much. Yeah. First of all, a lovely good afternoon to all of you sitting there. So coming over to the questions. So as usual, this time biochemistry questions were, quite a lot. I got some 7 questions. And I'm happy to know this. Normally in, this exam, very few questions on biochemistry are asked. So I was a little bit worried about the subject also, but now, yes. Now, first of all, before starting up with the discussion, how was your, what is your opinion about the questions? Yeah, I can see Himanshu, I can see Preetham. Yeah. Is my voice audible to all of you guys? Is my voice audible? हर्षभ
अनम्यूट यूट्यूब वीडियो को अनम्यूट कर दीजिए जो आपके पास ओपन है उसकी भी आवाज आएगी
अब ठीक है? Yes, now my voice is clear to all of you. Okay, right. So coming over to the discussion of the questions, what is your opinion about the questions? Were they easy? Were they tough? Or what? Because video is blurring. Okay, can you see the questions? Main thing is you should see the questions. And you should hear my voice. That's it. Okay, Preetham. Right. Okay. So the questions which I got from the sources, some of the options are there and most of the options are missing. So what I'll do is I will just discuss the questions and you have to come up with the options. Just suppose we start with the discussion. If we talk about question number 1, okay, you can see the question is mutation in the part of gene that does not cause any effect is known as. So what can be the option to this? One second, beta. Okay, let me just open it. 1 second. Yeah. So question was mutation in any part of the gene that does not cause any effect is known as. Because the problem is that here 2 options are not there. Now, if we just look at the options, okay, so mutation in the part of gene that does not cause any effect, इसमें the correct answer should be silent mutation. Okay, because you know, silent mutation and basically the 2 options which I could gather were silent mutation and non-essential. So you should know what is the difference between silent and non-essential. Can anybody tell me what were the other 2 options? If you have any idea about the questions, can you just tell me what were the other 2 options, beta? Because if we say that does not cause, because you know, silent mutation is what? Basically, wobble hypothesis is there. Suppose if I say CGA is there and it is coding for, say, glutamate. Right. And if I say CGA may CGG is there, it will also code for glutamate. Right. So they are not causing any effect. So it is a silent mutation. And non-essential mutation is the one. Non-essential is one which will basically code the redundant genes, or you can say the non-coding areas. But it has nothing to do with amino acid sequence. Getting my point? Silent mutation mein amino acid sequence is involved. Right. So the correct option is silent mutation. And if you people remember the other 2 options, you can just let me know so that I can just add it up. Because since yesterday, we've been also, you know, literally trying to get maximum number of questions and the correct options. Otherwise, you guys can put these 2 options in my Telegram group so that I can just add it on that. Right? Anybody has to say something? So, isme we can simply say the silent mutation can be the answer. Is it clear, beta? Preetham, Shivam, Karthik? Because if I analyze what questions I got, I found them because most of the questions were discussed in the class also. Most of the questions were asked in the Q bank also. So I don't think, and most of them were straightforward. So I don't think you must have found any problem in solving the questions. Am I correct? Okay, so isme we can say the answer will be silent mutation. Is it clear? Yeah, moving on to the second question. Which of these is true for B form of double-stranded DNA? Now, this question I have discussed in my videos also. We have discussed in the class also. So I don't think there must be any problem, but still I want to know what option you gave for this B form of double-stranded DNA. देखो, we know that DNA is of 5 main types: A, B, C, D, and Z. Okay, but normally we talk about this B type of DNA because there is a difference in the structures. If we talk about this, we know that A, B, C, D, and Z may there is a difference in the base pairs, there's a difference in the major groove, minor groove, so many differences are there. But whenever we talk about Watson and Crick, it is always B type of DNA. Just keep this thing in mind. I have discussed this also in the class. Okay. So here though it is clear the answer has to be Watson and Crick pairing. And we all know that Watson and Crick, what are the main postulates? That adenine always base pairs with thymine, guanine always base pairs with cytosine. Isn't it? Up, what can these options, if we see B, C, and D, they cannot. Why? Now, can anybody tell me what is this HOO? HOO. This is actually Hookstein base pairing. Hookstein base pairing is little bit different, you know, from the normal B type of DNA because here the bonds are different. Whenever we talk about this Hookstein base pairing, यहाँ पे होता क्या है? Adenine and thymine do combine, but there is a difference in the numbers. Okay, so this won't come in this. Guanine and adenine pairing, guanine and uracil pairing, ये आएगा नहीं, तो इसमें तो clear option is without giving any second thought. I think the answer can be Watson and Crick pairing or not. Am I clear or not, beta? I hope this question and the options are correct. What all you answered, Kartika, Shivam, I think this question must be correct. And you people answered it correctly. That is more important. ठीक है, यही options थी ना? If there was a change in the, है ना? Okay, so it is clear Watson and Crick pairing, and this is a very important question, I should say, and very simple question also. So shall we move to the third question? Right. Then third question, again a very simple question. So many times I have told you this question in the class also. Cholesterol is used for the biosynthesis of all except. A very simple question, I should say. है ना? सभी का करेक्ट होगा. आंखें बंद करके इसको तो you can tick thyroid. Isn't it? And I've told you thyroid या thyroxine, if I say वैसे, it can be thyroxine also. And we know T3 and T4 का precursor is, we all know that, we have discussed in the class, tyrosine. Right. And then cholesterol, vitamin D, sex hormones, steroid hormones, because that particular structure, cycloperhydro phenanthrene nucleus, is a characteristic feature of all, isn't it? So the answer has to be A. Is it clear, beta? The answer will be A. So this is again a very simple question, so I don't have to add on much. Yeah, thyroid from tyrosine, yes. And this I have discussed in the class T3 and T4, isn't it? Correct. So I can say biochemistry paper was a bit simple. Then, yes, this though I remember I have been discussing this topic 1,000 times. And if you see your notes also, I told you people to put a question mark because ketone bodies पे question आता ही आता है. Whenever I mention ketone bodies, I mention this is like a signature line from my side कि this question is going to come, if you people remember. है ना? So ketone bodies in plasma increases in which condition? बताओ. ये तो सबका ठीक होना चाहिए. Yes, Karthik, Nitika, Preetam. क्योंकि there is no question of confusion in this question, that is for sure. And in first prof also, you just, you know, this is a very important question from Viva point of view also, if you remember. There are two stages, pathological states in which ketone bodies increases, starvation and DM, isn't it? So obviously it has to be starvation, it has to be uncontrolled diabetes, and we call it also as diabetic ketoacidosis. वेल फेड स्टेट में देयर इज नो चांस, प्रोटीन डेफिशिएंसी में देयर इज नो चांस. इट्स क्लियर. Got my point? So the answer will be A and D. So कौन सी option है? The option will be this. Yes, exactly. There is no doubt about it. Yes. Yeah, so all of you must have got it right, I'm pretty sure. Then moving on to question number 5. This is a question from physiology actually. Bicarbonate. Yes, very good, Nitika. Starvation and uncontrolled diabetes, correct. Then fifth question, bicarbonate release from pancreas. This is basically a question from physiology, but this is a very simple question. We know that from pancreas is stimulated by none other than secretin. Because again, acidic chyme has to be neutralized. So this is again a straightforward question. Answer will be D. Right? Is it clear, beta? हाँ, अब इस क्वेश्चन पे आते हैं हम. ट्रू फॉर हेक्सोकाइनेस. अब इसमें I got these options, right? And now you got to help me that what were the other options, because again, if I come to the question, I have told you so many times about hexokinase. So guys, if you remember the options, please help me in this. बता सकते हो बेटा? Nitika, Kartika, if you remember little bit of this. True for hexokinase was the question. What were the options? Because nothing is clear in this. Otherwise, I'll tell you the properties of hexokinase. Dekho, I have told you hexokinase. There are two enzymes basically, hexokinase. Acha, this was also one of the option. Okay, I'll just write it. First of all, let me just complete the question. Low Km, high affinity. Okay. And what was the fourth option? We know there are two enzymes, hexokinase and glucokinase, right? And glucokinase is nothing but hexokinase 4. Stimulated by glucagon. Okay, chalo, I'll just write stimulated by glucagon. You should remember some of the questions. Best is better whenever you write your exam, na, whatever is there in your mind, na, the moment you enter outside the examination hall, you just write it down, you know, whatever questions. Increase after meals. Chalo, I'll write this option also, increase after meals. Okay. More affinity for glucose. This I've written high affinity for glucose, RIA. Okay. So now if we say there are two enzymes basically, one is hexokinase, the other is glucokinase, right? Glucokinase is nothing but hexokinase 4. We all know that. So the basic difference is hexokinase is present in all the tissues, right? This is present in the liver. So glucokinase is present in the liver. So this option is ruled out. Okay, we'll move step by step. Then we can say that hexokinase has low Km, glucokinase has high Km. And we all know that Km is inversely proportional to the affinity of the enzyme with the substrate, right? So if it has low Km, that means affinity of the, yeah, you can say high affinity with glucose. And it has less affinity with glucose. Right? So this can be correct. Low Km, high affinity. Clear? Now, if we talk about stimulation, insulin always promotes glucokinase, whereas insulin and glucagon, they have no effect on hexokinase. Neither insulin nor glucagon. So this option is also ruled out. Okay. Now, glucokinase always increases when the concentration of glucose exceeds 100 milligram per dl. जबरदस्ती इसको होना पड़ता है रिलीज. क्यों? क्योंकि ये क्या करता है, ये लेवल बराबर करता है. दैट इज व्हाई इट इज सिंथेसाइज्ड इन द लिवर एंड इट इज नोन एज अ क्लियरिंग फैक्टर आल्सो. ओके, सो ये ऑप्शन भी रूल्ड आउट हो गई, राइट? नाउ द क्वेश्चन इज एलोस्टेरिक ग्लूकोज 6 फॉस्फेटेज. नाउ फर्स्ट ऑफ ऑल, एक तो एलोस्टेरिक ग्लूकोज 6 फॉस्फेटेज नहीं होगा ये, इट शुड बी फॉस्फेट. फॉस्फेट, आई जस्ट करेक्ट इट. It has to be glucose 6 phosphate. Okay. And if we talk about this, we all know that this is the reaction catalyzed. Glucose is converted to glucose 6-phosphate. We all know that hexokinase is there and glucokinase is there. Hexokinase allosterically is inhibited by glucose 6-phosphate, isn't it? Because whenever the concentration of glucose 6-phosphate increases, it inhibits hexokinase, not glucokinase. This I have already discussed, so we can say feedback inhibition is possible. So it should be allosteric inhibition by glucose 6-phosphate, not glucose 6-phosphatase, because glucose 6-phosphatase reverse में act करता है. You know that, no? कि वो क्या करता है? It converts glucose 6-phosphate to glucose. यहाँ पे we are not talking about that reaction. Getting my point, beta? So अगर हम सारी options देखें, तो I'll just summarize everything. Hexokinase is produced by all the tissues. It has low Km, it has high affinity. Insulin and glucagon does not act on hexokinase, and glucose 6-phosphate allosterically inhibits hexokinase. Because you know RBCs always depend on glucose for energy, whether it is the fed state, whether it is a fasting stage or starvation. Now, if you know the options, I have given you all the possibilities of hexokinase, all the possibilities of glucokinase. So you can just imagine what can be the options. Is it clear, beta? And whenever I have discussed about hexokinase and glucokinase, if you see your notes, I have put a question mark there. Because I told you this is a very important question. And if you ask about the analysis of biochemistry may accept that mutation wala question. Chhodkar, everything is very clear. And I have discussed each and everything with you people, if you remember. Ria, isn't it? Because some of the students, I still remember the names. Hai na? So the answer, you see, what are the options? If you look at these options, the options mein kya ho sakta hai? These cannot be the options. This is the correct one. This is true about allosteric. This hexokinase, ki low Km and high affinity, it has for glucose, which means even if the concentration of glucose is less, hexokinase has to act. Is it clear to all of you, beta? Hai na? Right. So shall we move to the next question? Yeah, Varshini, now is it clear? Okay, because I have given you all the possibilities, what can be the options. And even if you, maybe say today or tomorrow, because when you, finish up with your exam, at least 3-4 days, like hum logon ko to till 1 month, it used to be like a nightmare for us. Whenever we used to go to sleep also, we used to just recall the questions, kya question tha, kya option thi. Okay, so still you people have time. So if you come to know, about the options, just message them in the Telegram group, and I will just again the question, I will reframe the question and I will discuss it with you. Okay. Yeah. Then moving on to the again, see, which of the following enzyme is not used in gluconeogenesis? Up 3 enzymes, names in each option. This is the question which I got. So if I have to tell you about gluconeogenesis, so many times I have told you about gluconeogenesis, isn't it? And up to my knowledge, I'm just, borrowing a guess. There must be one option. I'm just giving you an option. Pyruvate carboxylase, PEP-CK. This is my assumption. And fructose 1,6-bisphosphate. Right. This can be one option. Other options, I don't know. One option had pyruvate kinase. Okay, chalo, very good. Pyruvate kinase to beta aega nahi. It is not in gluconeogenesis. Isn't it? Because if you remember gluconeogenesis mein, what are the important points about this? Ek to, it occurs in 3 organelles. Kabhi hum bolte hain 2 compartments. One step is in the mitochondria. This also I have told you in the class. Pyruvate carboxylase. This is the only enzyme. If we talk about cytoplasm, all the rest of the enzymes are present in the cytoplasm. Like PEP-CK is there, fructose 1,6. In fact, all the enzymes. And the last enzyme, which converts glucose 6-phosphate to glucose, is present in the endoplasmic reticulum. right? And I told you one thing also in the class कि अगर options आती है mitochondria and cytoplasm पे, तो you have to go for this. और अगर mitochondria, cytoplasm, endoplasmic reticulum 3 are given, then you have to go for this. Pyruvate kinase and phosphofructokinase, okay, they are not the enzymes. I'll just write it. Pyruvate kinase, not of gluconeogenesis. Okay. Then if you talk about phosphofructokinase, not of gluconeogenesis. Right? Any other? I think this should be the option, because these are the main actually, regulatory enzymes. That is why I'm saying this is my assumption that these can be the option. और तो कोई हो नहीं सकती है ना? Glycerate 3-phosphate isomerase. Okay, पहले I'll just write the name of the enzyme. Glycerol 3-phosphate isomerase. Okay. Enolase. Okay. हाँ, अब if you talk about enolase होगा? अच्छा, glycerol, it should be glycerol aldehyde 3-phosphate dehydrogenase. enolase नहीं होगा. enolase क्यों नहीं होगा? Because enolase में क्या होता है? enolase में PGA, 2-PGA is converted into PEP. तो अगर हम रिवर्स में करें तो yes, reverse में it can be there. Glycerate 3-phosphate isomerase. This I'm not getting, beta. This is not an enzyme. Isomerase is an enzyme. Isomerase में हो जाएगा triose phosphate isomerase. देखो basically क्या है कि gluconeogenesis में the 3 steps which were irreversible in glycolysis, they are made reversible. Yes or no? That is what I have told you. So you have to just add these 2 enzymes, this enzyme and glucose 6-phosphatase. Bas, that's it. Rest of the enzymes will be of glycolysis only. So then you can just recall the question, the options. Right, Vasundhara? Got my point? Ravi, sorry, Ravi. I am telling you, just recall the options, beta. Glycolysis or gluconeogenesis में, in glycolysis, the 3 steps which are irreversible, catalyzed by hexokinase, phosphofructokinase, and pyruvate kinase. These are the only 3 enzymes which are not present in gluconeogenesis. Rest of the enzymes which are replaced by this one. And rest of the enzymes are all which are there in glycolysis. Is it clear, beta? हाँ, glycerol aldehyde 3-phosphate dehydrogenase. If we talk about this, now you tell me whether it will be there or not. Glycerol aldehyde 3-phosphate dehydrogenase क्या करता है? Just go through the reaction. It converts what? 3-phosphoglycerol aldehyde to 1,3-bisphosphoglyceric acid. यहाँ पे उल्टा is there. 1,3-bisphosphoglyceric acid is converted into 3-phosphoglyceric acid. Isn't it, Harita? Right. So you have to better see the options. I gave you all the best possibilities. Or any other option if you remember. फिर भी चलो, no problem. Even if you remember other options also, then what you can do is you can always post them in the Telegram group. I think this was all about biochemistry part, isn't it? Anna? This was all about the biochemistry questions. Okay. So I hope your exam went pretty well. So those who are going to crack this exam this time, it's wonderful. But still, if there are any chances, if by, because sometimes what happens is sometimes stars are also there. There are so many factors which are, influential. So don't worry, guys. Okay, at least whatever you attempted this time, next time you are not going to commit that mistake. Just keep one thing in mind, be focused, be positive. This is not the end of the journey. Those who clear it, well and good. But those who, by all means, there are so many ifs and buts. If you are not able to clear the exam this time, there is always a tomorrow, and the tomorrow is always better. Keep this thing in mind. And whatever questions, whatever, the teacher has told you regarding all the subjects, I'm not talking about biochemistry only, keep on revising them. The more you revise, the more questions you attempt, the more thorough you will be with the subject. Okay? And basic subjects, no doubt, all of you know they play a very, very important role, isn't it? Right? So any confusion, anything which you want to discuss with me now in this session, you can discuss with me. But otherwise, after that also, we are connected 24/7, so there is no problem for that. We are always there to help you, right? So even if you recall certain options which are not discussed, and even if you come across with any other question, okay, so just discuss with me or just put it in the Telegram group, so we will be answering there. Right? So shall we wind up the biochemistry session? Because I think, yeah, Dr. Mona Lisa has already joined. So now she will be discussing the anatomy part with you. Okay. So beta, everything is crystal clear from biochemistry point of view? If yes, you can just put a thumbs up so that I'll just hand over the session to Dr. Mona Lisa after that.
Yeah, thank you, ma'am.
Clear hai beta sab kuch? Okay. Right. So now I will hand over the session to Dr. Mona Lisa. How are you, ma'am?
I'm fine, ma'am. How are you?
Yeah, hello, ma'am. How are you?
I'm fine, ma'am. Can you hear me, ma'am?
So now I will hand over the session to Dr. Mona Lisa. How are you, ma'am?
I'm fine, ma'am. Can you hear me,
That's
ma'am?
good, good. So now
Am I-
you take over the session, ma'am. Now you try to solve their doubts of anatomy.
Thank you so much, ma'am. Thank you so much.
Chalo. Yeah, I can hear you. Yeah.
Okay, okay. So,
So chalo.
okay, dear students, am I audible? Screen is clear? Okay, so we can discuss the questions related to the anatomy subject. So let's start with discussing the MCQs. Firstly, I want everybody to please tell me how was the anatomy question and it was of which level. You can just write in the chat box. Yeah, hello everyone. Okay, what was the level of the question being asked? What you felt about the anatomy questions being asked? Yes, Mohit. Yeah, what was the level? Whether it was difficult, whether it was of moderate level, whether it was of easy level. So actually, what I felt that the question which I have gathered and I have received from the students is the 5 only. But I think more questions must be there. So anyone remembers more questions and the options, you can just post in the Telegram group. I will be very glad to solve it. Easy to moderate, yeah, moderate, easy. Yeah, I also felt actually 5 questions and they were directly from the question banks previous year INI-CET power grant test which we have taken the subject wise test. So only I have just seen the options and seen the questions, and I have correlated with the previous sessions also. So I will be able to correlate the both the option for you. So I felt it was very easy. So yes, Siddharth, Mohit, Yashika, everyone is telling that it was easy one, easy to moderate. Yeah, I also felt the anatomy was easy. So let's discuss with the INI-CET MDS Recall 2024 anatomy. So I would like to start with the first MCQ. Okay, so the first MCQ which I have got is that what is the origin of osteoblast in the intramembranous bone formation? Okay. So the option which is given is undifferentiated mesenchymal cell, original mesenchymal cells, differentiated mesenchymal cells, and perichondral osteoblast. Okay, this is exactly which has been asked. So exactly 4 options are there. And if I talk about the MCQs, and if I correlate with the other MCQs being asked, there was also in the Q bank in the previous year, one of the question number PYQ, question number 4, I want you to show. If I talk about these, if I want to tell you about these questions, so there was a question about the ossifications of the cranial bones. Okay, so it is directly correlated with the topic. 100% strike rate I can tell from the previous year MCQs, the question banks, from the subject wise test, from the PCTs which I have correlated. So we have already discussed the intramembranous and that of enchondral ossification. So for this question, so exactly you can see the ossification of the cranial bones. Which bones are going through the intracranial ossifications are the bones of the frontal, parietal, squamous, temporal, and the part of occipital bone. Also, enchondral ossification is 2 stages of development takes place. Firstly, the membrane, and then the bone is formed. So exactly now I would like to exactly correlate with the question being asked. So what was the question being asked? If I talk about exactly the question being asked, it was during intramembranous ossification. If I want to take intramembranous ossification, okay, question is not visible. Okay, let me just check. Okay, I'm checking. Okay, I'm checking. I am just checking. I will go to the Zoom link. Okay, I will just go to the Zoom link. I think they are not able to see the screen. No, this is the previous one. Questions are not visible. As a lonely screen is there on it. One minute. 1 minute, please. Okay. Now, can you see the screen now? Please let me know. Can you see the screen now? So, can you see the screen now? Please let me know. I will. Yeah, okay, it's visible. So, see here, this was the first question. Let me again come up with the question. All of you, please concentrate on the first question, which is showing the option. What is the origin of osteoblast in the intramembranous bone formation? Okay. Yes, ma'am, it's fine. Okay, Mohit. So it's the origin of the osteoblast cells in the intramembranous bone formation. The 4 options were there: undifferentiated mesenchyme cells, original mesenchyme cells, differentiated mesenchyme cells, and that of the osteoblast, perichondral osteoblast. Okay, exactly this was being asked. So exactly, if you will see this options, I will like to solve this, but before that, I want you to show the correlation. What I felt, I just have correlated all the MCQs with the question bank which we have framed for you, the subject-wise test which I have framed, and all the grand test, INI-CET power bank test. I have seen all this, all these topics are directly 100% from that topics being discussed. Only the language and the options has been changed. Like for one of the PY question was about ossification in the cranial bone, and we have already discussed that. And we have discussed which bones are going with the enchondral ossification and which bone is having intramembranous ossification, which we have discussed. And we have seen that Enchondral ossification means 2 steps of formation. Firstly, the intramembranous ossification takes place, and generally intramembranous ossification takes place as a one stage of formation, the membrane and the bone, and it takes place in the parietal, frontal, squamous temporal part of the bone, and the bones of the other bones, mainly that of the bones of the upper limb, lower limb, generally follow the enchondral ossification. Now, I would like now to come with the option being the correct. Intramembranous ossification of the compact bone or the spongy bone, the most important point which was asked in the MCQ, is directly formed from the mesenchyme. So if and undifferentiated mesenchyme. So see here, the option is showing undifferentiated mesenchyme cells. So I will go with A answer, undifferentiated mesenchyme. Okay, if only mesenchymal cell was there, so I would have gone with the mesenchymal cell. But it is, the difference is that the option is a mesenchymal cell, undifferentiated, differentiated, and original. So if the option is undifferentiated mesenchyme, the other two B, C is wrong, and we will go with A. Also, the prechondral osteoblast is not the answer, because osteoblast is the precursor of formation of the osteocytes, which get the osteoblast when it's covered by the osteoid matrix and then form the osteoblast. So we'll not mark that as the answer. The A is the right answer. Now, before proceeding to the next MCQ, I want everybody to just quick revision of the steps of the intramembranous ossification. Intramembranous ossification follows how many steps, my dear students? 4 steps. The first step is mesenchymal cell will group into clusters and differentiate. Can you see this? The first stage was that the mesenchymal cell was undifferentiated. Subsequently, it is differentiated into the osteoblast, and the ossification center is formed. So only I have struck out. I have marked wrong option as the osteoblast and the differentiated mesenchymal cells. After that, the second step is osteoid is a trapped osteoblast, and the osteoblast will subsequently form the osteocytes. Okay, first stage is the formation of undifferentiated mesenchyme. Differentiation starts, osteoblast forms, and then the osteoid is formed. The third step is matrix is formed and the periosteum is formed. And the fourth step is compact bone develops superficial to the trabecular bone, crowded with the blood vessels, and then ultimately the bone is formed. So everyone, is it okay? So I think most of you must have marked this right. So no doubt about this, why the undifferentiated mesenchyme is the right answer. And the topic of formation of bone, that is enchondral and intramembranous ossification, was already there in the question bank. So those who have solved the question bank of the MDS group must have solved this right. So is it okay? If any of the student has got any doubt, please let me know. So the right answer is undifferentiated mesenchymal cells. Okay. Okay, Yashika, Dhruv, Mohit. Now let's move on to the next MCQ. Now the next MCQ. Actually, among the discussion group, the image they were not able to frame, but the students has told me, the students who were there, they told me that there was an image-based question in which the arrow were marked on the superior constrictor muscle. So actually pharynx, we have number of times I have discussed the constrictor muscle of pharynx, and the openings which is lying in between the constrictor muscles of the pharynx is a very important topic. So the question was, what structure passes above the marked anatomical structure? So one of the student has told me the image based question was there and the arrow was marked on the superior constrictor muscle. So exactly this was, I have framed this as an MCQ, and you can see this is the superior constrictor muscle. Okay, the arrow is marked on the superior constrictor muscle. The options are stylopharyngeus, and the glossopharyngeal nerve is traversing recurrent laryngeal nerve, stylopharyngeus, cricopharyngeus, external laryngeal nerve, eustachian tube, and levator villi platini muscle. So my dear, I would just firstly want to frame this MCQ with a question number 18 of the PYQ, which we have discussed. So in the question bank, there was a question number 18 in the PYQ, which it was from the subject wise test. Okay, it was from the subject wise test for the MDS group. So I was given this question from that, and I has framed this for you. And in that option, I has asked you with the openings in the constrictor muscle. So what structure passes with the superior and middle constrictor muscle? And the right answer was glossopharyngeal nerve. So I am not going to explain the question on 18, which was asked in the subject wise test, but I will come to this. This is just to show you the correlation. Now let's come to the question. So this was the image which was there in the question, and here this is exactly the superior constrictor muscle. So the space which is lying above the superior constrictor muscle and the base of skull is the first space of the constrictor muscle. So we have got middle constrictor, we have got superior constrictor, inferior constrictor, and a space below inferior constrictor. And we have to correlate what all structures are passing through these spaces. So there are how many spaces? There are 4 spaces at the end. I have also tabulated the table for you. So we have got altogether 4 spaces. So exactly now it is clear the superior constrictor muscle. Now coming to this space. So this was what has been asked. So exactly if you will see above superior constrictor muscle, above the level of superior constrictor muscle, we have got 4 structures traversing. How many structures, my dear students? 4 structures traversing. And that 4 structures are levator villi palatini, auditory tube, ascending palatine artery, palatine branch of the ascending pharyngeal artery. 4 structures. How many structures? 4 structures. So we have to see in that option whether we have got any of this option. Okay, if I talk about the opening which is lying between, if I talk about the opening which is exactly lying between superior constrictor and middle constrictor, we have got 2 structures passing, stylopharyngeus muscle, and we know the nerve supply of stylopharyngeus muscle is glossopharyngeal nerve. In between middle and inferior constrictor, we have got internal laryngeal nerve and superior laryngeal artery, and below inferior constrictor, we have got inferior laryngeal artery and recurrent laryngeal nerve. Recurrent laryngeal nerve. Okay. So in fact, if I go through the tables of the gap between pharyngeal wall and the constrictor muscle and the structures, so the gap which is lying above the superior constrictor muscle and below the base of skull, which was asked in the image-based question, that space is called as sinus of Morgagni. What is it called as? It is called as sinus of Morgagni. And how many structures passes through it? 4. Ascending, we have got the ascending palatine artery, palatine branch of ascending pharyngeal artery, levator palatini muscle, and auditory tube. So we have got 4 structure which is exactly passing in this space. And below that we have got the 9th cranial nerve, which is piercing, which is giving innervation to only one muscle, the muscle of third pharyngeal arch, that is stylopharyngeus muscle. Between the middle and inferior constrictor, we have got internal laryngeal nerve and superior laryngeal vessel. Between the lower border of inferior constrictor and that below the level of inferior constrictor, we have got 2 structures, that is recurrent laryngeal nerve and inferior laryngeal vessel. So just going to it, again the option. So after this discussion, it is quite clear the correct answer will be eustachian tube and levator villi palatini muscle. Auditory tube and levator villi palatini muscle is the right answer. So how many of you have marked it right? How many of you must have marked it right? So anything among, so exactly these are the options, mixed kind of option I have received, but I just want to know if any of the option was containing levator villi palatini muscle, eustachian tube, ascending palatine artery, palatine branch of the ascending pharyngeal artery, that would be the right answer. Other than that, stylopharyngeus, glossopharyngeal is wrong. Why? Because it is passing through the opening, the space between the superior and the inferior constrictor muscle. Recurrent laryngeal nerve and stylopharyngeus is also wrong option, because stylopharyngeus passes between the space in between middle and that of the superior constrictor muscle. Recurrent laryngeal nerve passes below inferior constrictor muscle in tracheo-esophageal groove. Cricopharyngeus and external laryngeal nerve is not passing through any kind of the space between these constrictor muscle. So is it okay? Everyone has marked it right? Okay. Any doubt? If you feel, you can just write in the live chat box. Any doubt, you can write on the live chat box. Okay. Now coming to the next MCQ. Tubotympanic recesses develop from. Tubotympanic recesses develops from first pouch, second pouch, sixth pouch, or ectodermal epithelium. Which is the right answer? So this is very, very easy, and I think we have already solved the derivatives of pharyngeal arches, the derivatives of pharyngeal pouches, the derivative of pharyngeal membranes number of times. We have seen the cartilages, we have seen the bones, muscles, and nerves derivative. So can anybody tell me the right answer? This was the easy and the direct MCQ. Directly, it was directly from the question bank. So please let me know. Please let me know. Are you? What is the right answer? What is the right answer here? So actually the right answer is first pharyngeal pouch, and I would like to give you the option. So exactly if I talk about the structures of the middle ear, exactly the structures of the middle ear is derived from tubotympanic sulcus, okay, or the tubotympanic recesses. And if I talk about this tubotympanic recesses or the sulcus, it is developed from the endodermal extension from the first pharyngeal pouch. So this is exactly the direct MCQ, and this is the right option. This is the right option. Now, same questions, I'm correlating this question. Yes, Yashika, you're absolutely right. A is the right answer. So a thumbs up goes for Yashika. Yes, Yashika, you are absolutely right. Now, this, I just want to correlate this question with the previous year of the question banks and the INI-CET examination, which was taken for you before the examination. And we have already discussed about the pharyngeal arch muscle and the arch's name. Okay, we have seen the first pharyngeal arch, mandibular arch. We have discussed the nerves of these pharyngeal arches. We have discussed that we have discussed all the nerves of these, like trigeminal and the coda-tympanic nerve is the nerve of first pharyngeal arch, glossopharyngeal is the nerve of third pharyngeal arch, superior and the recurrent laryngeal nerves are the nerves of the fourth and the sixth pharyngeal arch. We have also discussed pre-traumatic nerve of first pharyngeal arch is the coda-tympanic nerve. We have also discussed that tympanic branch of glossopharyngeal is regarded as the pre-traumatic of the second arch. And we have also discussed all the cartilages which are derived, from these pharyngeal arches. Okay, yes, Nitika Bora, you are also right. This was very easy one. Okay, so, and please let me know, have you marked that superior constrictor muscle wala question right or not? Because just before I have shown you the image and all. So we can see that malleus is the first arch cartilage. We can see the second arch cartilage is tape, stelloid, shallow-haired ligament. We can also see the sphenomandibular ligament, spinosphenoid is all the first arch cartilages. We have also discussed the pharyngeal arch arteries. The first arch artery is maxillary. The second arch artery is hyoidal, stapedial. The third arch artery is common carotid, internal carotid. The fourth arch arteries and the sixth arch arteries. I feel everybody must have gone through this derivatives of pharyngeal arch arteries also. And after that, exactly what was asked in the question, we have also discussed the derivatives of pharyngeal pouches. The first pouch, the second and the third pouch. What was asked in the MCQ of this examination was about the tympanic middle ear recesses. So we can see first pouch is first pouch derivative is pharyngotympanic tube, the eustachian tube, the tympanic cavity, which was R. The second pouch derivative is palatine tonsil, intratonsillar cleft. The third pouch derivative is inferior parathyroid gland and the thymus gland. If I talk about fourth pouch, the fourth pouch derivative is superior parathyroid gland and it also correlate with the formation of the caudal pharyngeal complexes. Okay. The derivatives of pharyngeal membrane was discussed. Actually, correlated to the pouch, there was an image-based and a clinical question which has been framed in the discussion of INI-CET power test, and I have taken this image and I have talked about the absence of thymus and gland and what is the marked condition which is seen in this condition. So absence of thymus, that means you should know thymus gland is derived from which pouch and mark the right answer. The right answer is C. So exactly the syndrome which is discussed is dijaw syndrome and thymus gland and the parathyroid gland. Okay, we know that inferior parathyroid gland and thymus gland is derived from third pharyngeal pouch, and we have discussed all the important structures derived and the correlations of this. So you can see inferior parathyroid gland and thymus is derived from third pharyngeal pouch. The same thing was asked here, so I think most of you must have marked this right. So can we go to the fourth MCQ? Everyone, please let me know. Is it okay? Can we go to fourth MCQ? Can we move on to the fourth MCQ? Any of the students who again want to remember any of the options or any of the questions from the previous year or any of the correlation, or you know more of the question being asked, because I have got just 5 MCQs of anatomy. I feel definitely more of MCQs was definitely asked. Yashika, yeah, you have told about the C. Okay. So Yashika, you have marked C for this answer. Yeah, C is the right answer here. Yeah, for question number 10, yeah, C is the right answer, Yashika. It's absolutely right. Yes, it's absolutely right, dear. Now, I think options, one more question was there, which was of bilateral. What was bilateral cleft lip is due to defective embryological? due to defective embryological fusion of these processes. The options are mandibular and medial nasal process. The option is medial nasal process and lateral nasal process, the frontonasal process and the medial nasal process, medial nasal prominence with maxillary prominence. So can you tell me which according to is the right answer? Actually, I will correlate with many of the questions being asked. So cleft lip, cleft palate, how many times, I think more than many of times we have discussed in the previous year of examination. And I'm quite sure it must be discussed in your anatomy class also. And I have correlated just the MCQ from the last examination that was taken NEET PG MDS examination. Also, there was a question related to this topic. So I hope 100% students must have marked this right. So can you tell me which was the right answer according to you? Okay, dear. Okay, so can anybody tell me the answer of fourth cleft lip? Fourth cleft lip. Okay, Harshita, Selva Raj, I got one of the students told me that there was superior constrictor muscle and the structures passing above it was asked. Okay, so maybe only superior constrictor muscle have shown and the structures passing above it must be asked. Okay, okay, dear. Selva Raj is telling, ma'am, question was about structures passing superior constrictor. So we will just discuss. Actually, one of the student and the group was telling above. So maybe I think the structures correlated with the superior constrictor muscles. These are the options. So definitely auditory tube should be masked. If there is an option containing auditory tube, that would be masked as the right answer. So yes, anything you feel that any of the option is different as you remember, what I want everybody after coming from the examination hall, write the questions and the options so that we will get exactly the correct options and the correct question. So no worries. If you feel that something else was asked or some other options was used, you can directly write this in the Telegram group and I will be very happy to solve this options and I will be very happy to frame directly the correct image of that question. Is it okay, Harshita? Is it okay? Okay. Now, Pooja Kumar is telling it's D. Median nasal process, maxillary process is absolutely right. So yes, if Fatima is telling, so I feel that students in. So let me come again with this option. Okay, let me come again with the image-based question because many of the students are getting confused about that. Okay, I will again come with the fourth MCQ, but see here. So yes, I also feel that students, okay, Fatima Farah is telling question was above constrictor muscle. So my dear student, if the question was above, I also feel it must be above. I also feel the question must be above superior constrictor muscle because many structures are passing above superior constrictor muscle. So all the students who are confused, please note down 4 structures are passing: auditory tube, levator villi palatini muscle, ascending palatine artery, and also the ascending pharyngeal artery, palatine branch, ascending pharyngeal artery, palatine branch. Is it okay? So anything, any options like this? Okay, it's clear. So so Fatima is telling no need to explain. It's clear. So anything among this option is there, then you have to mark it right. Okay. Now coming to the next question, which we were in the fourth question. Okay. Now let's come to the fourth MCQ. Yeah. So Pooja, you have given absolutely right answer. Okay, auditory. So one of the student knowledge is telling auditory tube was an option. Okay, so very good. So then, so I'm very happy that you must have marked it right. So auditory tube is the right answer. If the auditory tube was an option, then it was right answer. So I have once again gone back with that image because I felt many of the student has missed that MCQ. Now question number 4. I think everybody 100% strike rate must be there for this MCQ because I can like 4 or 5 questions I can frame exactly like this. So exactly bilateral cleft lip is due to defective fusion of which? A very important question being framed for MDS examination. The correct answer is medial nasal prominences and maxillary process. Is it okay for Fatima? Is it okay, Harshita? Is it okay, Pooja? Is it okay, Nitika Bora? Yeah. So I think Pooja has marked it right. So last session, we have discussed one more question where unilateral cleft lip was asked. Okay, here we have got bilateral. Here the question is about bilateral cleft lip, and this exactly the question I have taken from the last discussion of the NEET PG recall question. There was a question of unilateral cleft lip. Okay, so exactly bilateral cleft lip. The reason is non-fusion of maxillary and medial nasal process. Non-fusion of yes, Pooja, you are absolutely right. So non-fusion of medial nasal process and maxillary process. So I will mark medial nasal process and maxillary process as the right answer. If you feel that other options are there or the language or something else is asked, then you can let me. But I got many students telling me that bilateral cleft lip question reason was asked, and last time in the 2024 NEET PG question, if I talk about NEET PG last time, which I have discussed, there was a question about unilateral cleft lip. Now, most of you must have marked. If I talk about unilateral cleft lip, there is non-fusion of maxillary and medial nasal process, which was asked in the previous year discussion of the MCQs. Central cleft lip is due to failure of development of philtrum of the upper lip. And in this image, we can see A is unilateral cleft lip of upper lip. This is the bilateral cleft lip, which is asked this year, INI-CET examination. Median cleft lip of upper lip, which is also called as hair lip, and this is the lower lip cleft. Now, I also want everybody to know about oblique facial cleft, which we have discussed. If I'm talking about oblique facial cleft, so one of the option was there, which was about the non-fusion of lateral nasal process and maxillary process. Lateral nasal process and maxillary process. So exactly lateral nasal process and maxillary process, if it is not fusing, it is leading to the condition of oblique facial cleft. Cleft palate. Well, if there is a defective fusion of the palates, if the premaxillary and maxillary process are not formed, so that will lead to the cleft lips. Complete cleft lip is due to the maxillary process does not fuse with premaxilla. It can be either unilateral and bilateral. If it is bilateral, there is non-fusion of maxillary process with the premaxilla. Now, I have taken this this chart, this table from the question bank, which we have framed for you for the MDS group, and you can see all the reason. Mandibular process is not forming, and mandibular process is not forming or not fusing. It is leading to the central cleft of lower lip, non-fusion of maxillary, frontonasal process, non-fusion of, or the reasons of cleft lip, and the reasons of the cleft palate. So I have taken all these tables from the discussion which has been uploaded in MDS group question bank. So definitely write itself. This is the same question being repeated exactly. So after that, it is quite clear that we have got the right answer as for mandibular process, medial nasal, lateral nasal process. All these are wrong option, and we have got D as the right answer. Any doubt, my dear students? Can we move on to the next MCQ? Next MCQ. Please let me know, my dear students. Can we move on to the next MCQ? Okay, so we should move on to the next MCQ, that is question number 5th. This is exactly, I got this question from the students, and let me see how many of you have marked it right. Actually, yes, Yashika. So this was exactly, this is also correlated. I have again taken one question from the previous year discussion of MDS question bank, INI-CET and GT examination. Which of the following muscle is the muscle of soft palate? So actually a image-based question was framed for you for discussion of the soft palate muscle. So the option here is tensor villi palatini muscle, levator villi palatini, the palatopharyngeus muscle, the stylohyoid muscle, and the correct sequence of the code has been given, A, B, C, D. So I will just wait for my dear students to mark the right answer, because I feel this is also a very easy one. It is just asking about the soft palate muscles name only, and we must have discussed about the muscles of soft palate, because I have got a discussion of soft palate muscle related image-based question in the previous year discussion of the MCQs question bank. So yes, Fatima, Nitika, Bora, Yashika, Pooja, can you tell me the right answer, or should I come with the explanation? What you feel is the right answer? Exactly. This is an easy one only. Muscles of soft palate, tensor villi palatini, levator villi palatini, and palatopharyngeus. All these three muscles are the muscles of soft palate. Stylohyoid is not the right option. Why? Because stylohyoid is the muscle which is not a muscle of the soft palate. So I am quite sure most of you. So yes, A. So here Adya Gupta, Dr. Abhishek Sharma, Pooja Kumari, Yashika all have marked exactly the right answer. Okay. So exactly, absolutely correct. Okay, so question is exactly right. So yes, so exactly we have got the right answer. Okay. Okay, if it was like that, Nitika, it's a palatopharyngeus is the muscle of pharynx. Nitika Bora is telling question was about pharyngeal plexus. Okay, don't worry. If it is pharyngeal plexus, I will frame the question like that. Don't worry. If it is like question, if the question is directly about the muscle of soft palate, then the answer is 1, 2, 3. So Yashika is telling the question was on soft palate muscle supply. I don't remember it exactly. So question was a bit different. Dr. Ashwin Yatun, 5 questions were different. I think it was a so 5th question is about nerve supply. Don't worry, Ashwin. And I have also tabulated the nerve supply of these muscles. So see here, if the muscle are like this, tensor villi palatini, levator villi palatini, palatoglossus, palatopharyngeus muscle. Okay, which of the soft muscle is not supplied by pharyngeal plexus? Okay, dear. If the question was like that, so the answer will be tensor villi palatini. Tensor villi palatini. My dear students, Dr. Ashwin, Dr. Yashika, Dr. Faria, don't worry. If the question is about nerve supply, I will give you the answer of that also. अगर हम question में nerve supply की बात करते हैं, तो palatoglossus muscle is supplied by the vagus nerve carrying the fibers of cranial part of accessory. If there was tensor villi palatini, then tensor villi palatini is the odd man out because its nerve supply is from medial pterygoid muscle. It's from the nerve to medial pterygoid, that is a branch of mandibular. ओके स्टाइलोहेड और यहाँ पे अगर वो ऑप्शन है तो स्टाइलोहेड इज सप्लाइड बाय फेशियल नर्व प्लाटोग्लोसस है तो प्लाटोग्लोसस इज अ मसल ऑफ so my dear palatoglossus is a muscle of tongue being supplied by the vagus nerve carrying the part of cranial part of accessory. Okay, I got the point. I will discuss all that option, don't worry. Now see here, like a similar kind of question which we have solved in our question bank was the tendon of which muscle is gliding around pterygoid humulus, and that was the tensor villi palatini. So you can see tensor villi palatini is winding around pterygoid humulus. In that case, I have also discussed about the muscle of soft palate, because generally what happens whenever any question is being asked, what I discuss that topic itself, because exactly same question to repeat nahi hoga, exactly same question to repeat hona bhi nahi chahiye, hai na, so that the competition is in good terms. So exactly same question nahi repeated hai, uski nerve supply पूछी गई है, so we can correlate it exactly like that. Like यहाँ पे अगर ये वाला क्वेश्चन तो हमने डिस्कस किया था, which I have taken from the question bank. Soft palate की muscles की बात करूं, they are all in. So see here, if this was like that, see the answer. Muscles of soft palate are 5. Okay, we will discuss all the 5 muscles, and they are all innervated by pharyngeal branch of vagus apart from tensor villi palatini. So my dear students, all the muscles. So all the muscles, palatoglossus is also a muscle which is considered as the muscle. So palatoglossus is also supplied. Palatoglossus is also supplied by the pharyngeal branch of vagus. Only the odd man out will be tensor villi palatini. Okay, tensor villi palatini, which is supplied by mandibular nerve branch, medial pterygoid muscle. Okay. So if you feel the question is not like that, and there is tensor villi palatini, so the tensor villi palatini will be right. So Adya Gupta, Dr. Ashwin, Dr. Wonderful Land, and Dr. Fatima Faria. So in that case, tensor villi palatini will be the right answer. If you want to know the details of individual muscle, let me frame it for you. So levator villi palatini is the muscle. which is arising from the petrous temporal wall of the eustachian tube and inserts into palatine aponeuris. Function is elevation of soft palate. If I talk about palatoglossus muscle being a muscle of tongue, but it is also considered as a muscle of soft palate, inserts because it inserts in palatine aponeuris and pulls the soft palate. Palatopharyngeus is also a muscle which arises from palatine aponeurosis and inserts and the thyroid cartilage upper border, and it is tensioning the soft palate and drawing the pharynx in and helping in the swallowing process. Musculus uvuli is a small muscle attached onto the posterior nasal spine and also onto the palatine aponeurosis, helping in shortening the uvula. And so these are all the muscles of the soft palate. So till now I have got these MCQs. I hope the MCQs which we got has been framed for you, and you must have correlation of the right answer. And as most of the students are telling me, the anatomy questions are easy, directly asked from the anatomy sessions, and also been asked from the GTs and INI-CET's power test and all the grant test and the Q banks and the subject wise test done. So moderate to easy. Most of you are telling moderate to easy. Most of you have marked the right answer. All the best, and please don't get disheartened if any of the question you have not solved it right, because at the end I would like to tell everybody that if you feel that few more MCQs were there, so please add that MCQs in the Telegram group of the MDS group, and I will be very pleased to solve it. All the best and keep studying. Any doubt you can let me know on the group, and we are always available for you 24/7. So don't settle, don't stop, and be passionate. Keep the high spirit in a positive way. Take it in a positive way. All the best, and I hope definitely you will crack this. And thank you so much. One image-based question was there. Option was elevation, depression, protrusion, and retraction. Okay, about Yashika, about which muscle? Muscles of tongue, muscles of pharynx, soft palate. Yashika, can you tell me? Image-based question was of elevation, depression, protrusion, and retraction. So I think these muscles of the TM joint, correlated with the TM joint, we have already discussed. And we know that only the depressor of the mandible is the lateral pterygoid muscle. This was image. Okay. So Faria, don't worry. Right now, I can't go directly in the question bank. So I think in that case, lateral pterygoid will be the right answer. If so, Faria is telling question number 6 for me. She is telling question number 6 for me. So why not I solve it right now only? That there was a question based on the muscles of mastication. So muscles of mastication is number of times done, and image based question is also done. And if it was lateral pterygoid, then the answer was depression of mandible, because depression of mandible is done by only lateral pterygoid muscle. Yeah. And अगर lateral pterygoid muscles है, तो lateral pterygoid muscles के two heads होते हैं. Okay, two heads होते हैं, superior and inferior. And the lateral pterygoid muscle के image में there will be definitely shown that it is attached to the lateral aspect of pterygoid hamulus and also to infratemporal crest of sphenoid bone, and the insertion is going onto the articular disc or fibrous capsule of TM joint and pterygoid fovea. So a muscle which is having two heads like this, and then going and inserting onto the TM joint, inserting into the TM joint, this will be the superior and this will be the inferior head. This muscle is lateral pterygoid muscle. Number of times we have discussed this in an INI-CET examination or before power bank practice of the MCQs we have discussed. So all of you have marked it right. I'm so happy that you are remembering the question also, answers also, and you are confident that it is right. Okay. So that is very very good. Now, before that, before ending, I would like to introduce ma'am. The faculty of physiology, and ma'am has discussed so many times all the MCQs with you, and have so I will hand over to Dr. Abhiram ma'am, physiology faculty. So how are you, ma'am? So now the students want to solve physiology question along with you.
Hello, ma'am. Hello, ma'am. Fine, ma'am. Your anatomy discussion was a great session, ma'am. In depth, you had discussed so many things. Hope I'll also do this.
Yeah, ma'am. So the students are very eager to solve the physiology questions. So I would like to hand over to ma'am. Yeah. Welcome to the platform, ma'am. Thank you so much, ma'am.
Thank you. Hello, everyone. Very good evening to all. Hope all of you are doing good. The sessions are going so well. So I think my audio and visuals are fine. I think you are all able to see the screen as also. Yes, just a minute. Let me get connected to you. Yes, let's start the session now. With regards to physiology, it was not a very difficult type of questions in physiology, not very tough, moderate type of questions. And all the questions, I'm happy to say that we have discussed in our classes. We had discussed in the rapid revision session, in our regular classes, our live classes sessions, and also in question bank. There were so many times repeat questions, almost the same question itself was repeated. So I'm happy that most of you would have done it well. Yes, Dr. Abhishek, Dr. Fatima, Yashika, so many of you are there. So please do correct me if there is any change in the options. So let's start off the session. INI-CET May MDS Recall 2024 on physiology. Over to the first question. Which of the following is not a mechanical motor of the skeletal muscles? The same question itself we have discussed in our classes. Same question I showed you when we discussed the parts of the neuron. Yes, very good evening. A very good evening, Dr. Rajesh. Very good evening. Very good evening, Dr. Pooja. The same question itself I told you, if you have attended the classes, hope you remember this discussion where we discussed on the different parts of a neuron and also the different types of axonal transport. What is axonal transport? How substances are transported along the axon. This is called axonal transport. Very good evening, Dr. Karthika Nagesh. What are the different types of axonal transport? There are two types of axonal transport. Substances can be transported from the cell body to the axon terminal like this, from the cell body to the axon terminal in this direction. So this is the cell body and this is the axon terminal. This is the normal direction. Normally, substances are synthesized in the cell body and transmitted to the axon terminal. This is called anterograde transport. This type of transport mechanism, we call it as anterograde. What are the substances which are transported in anterograde direction like this? Whatever is synthesized from the cell body, like neurotransmitters, enzymes, proteins, all these are synthesized by the cell body. So it has to be taken to the axon terminal only in this direction. And this is called as anterograde transport. Which is that protein which helps in anterograde transport? Kinesin, very important, kinesin. So kinesin is moving substances from the cell body to the axon terminal. Sometimes substances go in reverse direction also, from the axon terminal in the reverse direction into your cell body, maybe like this. From here in the reverse direction into the cell body. And this we call it as retrograde transport. Reverse means retro. So it is called retrograde transport. What are the substances which will go in reverse direction? Just imagine if a dog bites you here in your hands, if your dog bites you. So this saliva of the dog has rabies virus. From the skin, the rabies virus is transmitted in the reverse direction. It goes and attacks your spinal cord and brain. This we call it as retrograde transport in the reverse direction. Rabies virus is transmitted in reverse direction. Tetanus toxin. Let's say I have an injury in my hands. Why do you take TT injections immediately after an injury? To prevent infection by Clostridium tetani, you take TT injections. So if in case I don't take a TT injection, I have an injury here. From this wound, if there is any dust or rusted particle which has Clostridium tetani, it can enter into the wound. It can go in reverse direction and it can attack my spinal cord and brain. So tetanus toxin, which is a Clostridium tetani infection, this can travel in reverse direction. Tetanus toxin. To prevent this infection by Clostridium tetani, we take TT injections. So tetanus toxin goes in reverse direction, which is that protein which helps in this retrograde transport. The protein is called dynein. And those of you who attended the classes, hope you will know how to remember this. What was that easy method that we applied to remember this? Yes, dynein, dye. So if any rabies virus or tetanus toxin enters into your body, enters into the patient's body, patients will die. So dangerous substances transported by dynein. Dye means patient would die. Rabies virus and tetanus toxins are very poisonous substances. So that is DYE. With that, you remember dynein. Kinesin for anterograde transport and dynein for retrograde transport. So that was about kinesin and dynein. So we also discussed this slide. This is the exact slide from our live session classes that we had taken. Physiology sessions, the same slide we had discussed. Molecular motors. What is a molecular motor? Motor means something which is carrying any other substance is a motor. What are all the molecular motors? Kinesin is a molecular motor. Dynein is a molecular motor because both of them carry substances in anterograde and retrograde direction. What about myosin? Myosin is also a molecular motor because in muscle, just recall myosin and actin, which are bound alternatively like this. Myosin heads will pop up, touch the actin, and they'll move the actin. Only when all the actins move like this, the whole muscle will move. So who is moving actin? Myosin only is moving actin. So myosin is also a molecular motor in the skeletal muscle. So kinesin is a molecular motor, dynein is a molecular motor, and myosin is also a molecular motor. Do not confuse this with actin because actin is also present in skeletal muscle, but actin will move on itself. Actin cannot move anything else. It can move on its own. Myosin moves actin, so myosin becomes a molecular motor because it is moving actin. But actin is not a molecular motor because actin cannot carry anything. It will move on its own. So actin is not a molecular motor. So when we discuss about molecular motors, kinesin, dynein, and myosin are molecular motors. And actin is not at all a molecular motor. So that was about the question. Which of the following is not a part of mechanical molecular motor of the skeletal muscle? So the answer to this would be actin because other three, myosin, dynein, and kinesin are molecular motors and actin is not a molecular motor. Hope all of you are okay with these options. Yes, the reliable 4 options which I got from all the students was this only. Over to the second question. Blood pressure is maintained when someone is standing from supine position by. So this question is on BP regulation. Baroreceptor reflex, the options given were baroreceptor reflex, Bezol-Jarisch reflex, cardiopulmonary reflex, and cardiac chemoreceptor reflex. Let's discuss all of this. First, let's do regulation of BP. With that knowledge only, you will be able to answer this question. And in detail, we have discussed in our live sessions on regulation of BP. And I hope the subject-wise test also had a lot of questions from BP and baroreceptor regulation. Yes, let's do that. Regulation of BP. How are we able to regulate our blood pressure? Short-term regulation, intermediate-term regulation, and long-term regulation. What is that short-term regulatory mechanism? Baroreceptor reflex, chemoreceptor reflex, and CNS ischemic response. Baroreceptor reflex has a range. Any variations in BP from 60 to 180 millimeter of mercury, baroreceptors will take care. If BP falls less than 60 millimeter of mercury, chemoreceptors will take care. What are the chemoreceptors? Yes, the respiratory chemoreceptors, peripheral chemoreceptors located near your aortic arch and carotid artery. If BP falls less than 40 millimeter of mercury, CNS ischemic response will take care. This is short-term regulatory mechanism. Short-term means suddenly, if your BP drops, you're changing your position, you're standing up, your BP falls, or you get tense, there's a change in BP. Very short-term momentary changes in BP will be taken care of by short-term regulation. What about intermediate regulation of BP? Capillary fluid shift mechanism and RAS. What is RAS? Renin, angiotensin, aldosterone system is RAS. So any intermediate regulation of BP, intermediate change in BP will be taken care of by capillary fluid shift and renin, angiotensin, aldosterone system. Long-term regulation of BP. Over a chronic period, if there is variation in BP, RAS mechanism will take care. Renin, angiotensin, aldosterone system will take care. So this is the regulation of blood pressure. Now let's discuss in detail baroreceptor reflex. What is baroreceptor reflex? What are the baroreceptors? This is exactly the slide from our class. So let's do that again. What is baroreceptor reflex? The baroreceptors, baro means pressure. They are basically pressure receptors which are sensitive to stretching. So if there is any variation in blood pressure, this will stretch your baroreceptors. If blood pressure increases, if blood is flowing with high pressure into these receptors, they would stretch the baroreceptors. Where are these baroreceptors located? They are located on the arch of aorta and the internal carotid artery. On the arch of aorta and internal carotid artery. They are called as aortic arch receptors and carotid sinus receptors respectively. So these are the two different types of baroreceptors located on the aortic arch and internal carotid artery. What do they sense? If there is any increase in blood pressure, the pressure will stretch these receptors. There is stretching of these receptors and they are stimulated. Once they are stimulated, if aortic arch receptors are stimulated, they will trigger vagus nerve from the aortic arch. If the other one, carotid sinus receptors are stimulated, they will trigger glossopharyngeal nerve from the carotid sinus. So two different nerves. From the aortic arch receptors, vagus nerve, and from the carotid sinus receptors, glossopharyngeal nerve. Basically, your 9th and 10th cranial nerves. So these nerves, when triggered, they carry this impulse into the brainstem. So from glossopharyngeal and from vagus, impulses are taken into the medulla. The center for regulation of blood pressure in the medulla is called as nucleus tractus solitarius, NTS, or nucleus tractus solitarius. And what is the role of nucleus tractus solitarius? This has two different roles. It can activate parasympathetic nucleus and it inhibits sympathetic nucleus. Which is the sympathetic nucleus? Vasomotor center, VMC or vasomotor center. What will happen if you inhibit the sympathetic nucleus? BP will fall. Therefore, there is a fall in BP. Did you notice how an increase in BP through baroreceptor reflex decreases the BP? This is called the baroreceptor reflex for regulation of blood pressure. Along with BP, if you inhibit the sympathetic nucleus, there is also a decrease in heart rate. And this relationship, this inverse relationship between increase in BP causing a decrease in heart rate when they are connected through baroreceptors. What do you call this as? Which is this law? Yes, this was Mary's law. This is called Mary's law. So what is Mary's law? An increase in blood pressure through baroreceptor reflex, how it causes a decrease in heart rate. Usually, BP and heart rate will be on the same side. But here alone, where an increase in blood pressure, when it is connected through baroreceptor reflex, causes a decrease in heart rate. BP is more, but heart rate is decreasing. This relationship is called Mary's law. Inverse relationship between blood pressure and heart rate. So that was about the baroreceptor reflex. What about Chemoreceptor reflex. When BP falls less than 60 millimeter of mercury, chemoreceptors are stimulated. What is the role of chemoreceptors? They are usually peripheral chemoreceptors. They will sense oxygen and carbon dioxide and H plus levels. But remember, chemoreceptors can also sense a fall in BP. This also we have discussed in regulation of respiration. In peripheral regulation of respiration, chemical regulation, we have discussed this. Chemoreceptors are sensitive to fall in BP. So if your BP falls less than 60, chemoreceptors can be stimulated and they can also cause an increase in blood pressure. How will chemoreceptors cause increase in blood pressure? If chemoreceptors are sensing a fall in BP, they will activate the sympathetic nucleus. If sympathetic nucleus is activated, BP will rise. This is how chemoreceptors regulate blood pressure. What about CNS ischemic response? If BP falls less than 40 millimeter of mercury, this is the last response which will help any dying person. What is this CNS ischemic response? If your BP falls less than 40, it means your brain is going for ischemia, CNS. CNS means brain is going for ischemia, lack of blood supply to your brain. If there is lack of blood supply to the brain, your brain can directly stimulate the sympathetic nucleus. But this time, it will be a very strong stimulation. Therefore, BP can increase even up to 250 millimeter of mercury. Sudden sharp rise in BP, even it can go up to 250 millimeter of mercury. And with this perfusion, if you are able to perfuse all the organs, you can even come back alive from the graveyard. And that is why CNS ischemic response is also called as the last ditch stand, the last response which will save any dying person. So that was about baroreceptor reflex, chemoreceptor reflex, and CNS ischemic response. What about intermediate regulation of BP? Capillary fluid shift mechanism. What is capillary fluid shift mechanism? What do the capillaries do? Let's say this is a capillary. These are the arteries. When blood flows from arteries into the capillaries, if the blood pressure is very high, see what the capillaries will do. If blood is flowing with high blood pressure into the capillary, in order to bring down this pressure, the capillary will shift some fluid out of the capillary into the interstitium. This is called capillary fluid shift mechanism. Why is it doing like this? The load is very high, pressure is very high. So in order to bring down the pressure, capillaries are shifting some fluid out of the capillary. That's called capillary fluid shift. And the reverse is also correct because the capillaries, whenever there is a fall in BP, they will take back the fluid from the interstitium into the capillary. Whenever BP decreases, they will shift the fluid again from interstitium into the capillary. So both ways they can do. When BP rises, they will shift the fluid out of capillary. If BP falls, they will shift the fluid into the capillary. Both ways they can act. So this is about capillary fluid shift mechanism, which is also another intermediate regulatory mechanism of blood pressure. What about RAS? RAS is renin angiotensin aldosterone mechanism, aldosterone system. RAS means renin angiotensin aldosterone system, RASS. Anyway, the final product is aldosterone. What is aldosterone? Salt hormone. It will reabsorb salt. And angiotensin can cause vasoconstriction. So by these mechanisms, RAS mechanism also helps to increase your blood pressure. If you reabsorb more salt, BP will rise. If angiotensin causes vasoconstriction, then also BP will rise. So anyhow, RAS mechanism also acts to increase the blood pressure. So that was about RAS mechanism. Same long-term RAS mechanism also, the same renin angiotensin aldosterone system. So what is the trigger for renin? Whenever there is a fall in BP, renin will be produced. Fall in BP is the trigger for renin. So these are all the short-term, intermediate term, and long-term regulation of blood pressure. So going back to the question, Blood pressure is maintained when someone is standing from supine. So you're lying down supine. Suddenly, if you stand up, all blood is pulled into the lower limbs. If all blood goes into the lower limb, the veins are not returning the blood back into the heart. So venous return decreases. When venous return decreases, cardiac output decreases. When cardiac output decreases, BP decreases. When blood pressure decreases, but this is only momentary. Immediately there will be a drop in BP, but after a few minutes, 1 or 2 minutes, BP will come back to normal. That is because of baroreceptor mechanism. So baroreceptor mechanism can act in both ways. If the BP is more, it will decrease the blood pressures. If there is a decrease in BP also, by activating your sympathetic nucleus, it will increase the blood pressure. If BP is more, it will inhibit sympathetic nucleus. If BP is less, it will activate the sympathetic nucleus, so BP can rise. In both ways, it can act. So this is a short-term regulatory mechanism where you are standing up. This is a short-term regulatory mechanism. So this is baroreceptor reflex. That was about the baroreceptor reflex. It's over to the third question. Generation of action potential happens in which part of a nerve cell? And this also in the first part of nerve physiology, in the structure of neuron, we have discussed the same slide in detail. So let's do that. This is the structure of a neuron. What are all the parts of a neuron? A neuron has, like any other cell, a nerve cell also has a cell body. This is the cell body. It has a nucleus. And these processes are called as dendrites. The longest process is called as axon. And this is the initial part of the axon, or the first part of the axon, which is called axon hillock, or initial segment of axon. Initial segment of axon. Along the axon, there are some parts where there is no myelin. This yellow color sheath is myelin. Wherever there is no myelin, these areas are called as nodes of Ranvier. Nodes of Ranvier. This last part is called axon terminal. Dendrites are called as receptor zone because they only receive the signals, electrical signals from the previous neuron. Because dendrites are branching out like this, they branch out and receive the impulses from the previous neuron. So dendrites become receptor zone. How do they receive the impulses? In the form of electrical signals. What is that name given for these electrical signals? Action potentials. But you cannot call it as action potential because they are only small potentials like this. They are not big action potentials. Dendrites can't form action potentials. They form only small local potentials because dendrites lack sodium channels. Sodium entry is very important for action potential. Because dendrites lack sodium channels, they can form only small potentials called local potentials. So dendrites form local potentials. But this local potential, when it travels along this cell body and when it reaches this part, the initial segment of the axon or the axon hillock, immediately it is converted into action potentials. This is an action potential. Why is it converted into action potential? Because axon hillock is rich in sodium channels. Axon hillock has almost 350 to 500 sodium channels per square micrometer. It has so many sodium channels. It is rich in sodium channels. So quickly sodium can enter inside and therefore it can cause action potentials. So where is action potential generated in the neuron? Initial part of the axon, initial segment of the axon or the axon hillock. So generation of action potential happens in which part of the nerve cell? So this part which is marked B, it denotes the first part of the axon or the axon hillock. This is called the initial segment of axon or the axon hillock. The answer here would be option B, initial segment of the axon. Any changes in the options? Hope this was the same question that was asked. Okay. All of you agree with the options? Okay. So that was about generation of action potential and axon hillock. But please do remember, two different questions are here in this section. If it is a motor neuron, initiation of action potential happens in axon hillock. Also remember, if it is a sensory neuron, then the first impulse comes from the first node of Ranvier. Because the structure of sensory neurons is different. It has a capsulated structure. The structure is different. So motor neuron, initiation of action potential, axon hillock. But if the question is sensory neuron, then it would be first node of Ranvier. This is a motor neuron because the structure is multipolar type. Multipolar type neurons, most common neurons are motor neurons. All motor neurons are multipolar type. So you can very well go with this option if this image is given because this is the motor neuron. But if specifically the question is sensory cutaneous neuron, then you will have to go for first node of Ranvier. In the diagram, axon hillock was not given. Dr. Rajesh says axon hillock was not given. I think this part, maybe the junction between cell body and axon was marked, something like that. But anyways, the answer is initial segment of the axon only. Might be the last part of the cell body or the first part, maybe somewhere here there was a marking. Yes, but the answer is axon hillock or the initial segment of the axon. Yes, Dr. Fatima says it was like that. So the concept is where the cell body ends and the axon begins, is that junction or the first part of the axon. So anywhere between this area, so that could be the answer. But anyways, the other one marked here is nucleus. Here it is the myelin, and here it is the axon terminal. So others are definitely not the option. So if option is like this, even if cell body is marked, so it is more towards the part where axon is going to begin. So we can go with that. Yes, Dr. Fatima. Over to question number 4. Phase 2 of ventricular action potential. Yes, you remember this diagram from our class. I'm so happy that all questions are repeated from the classes that you have attended. Cardiac ventricle action potential. In detail, we have discussed this in CVS. This is a cardiac ventricle action potential. Let's mark the phases of cardiac ventricle action potential. This has depolarizations and repolarizations. And in between, there is a plateau phase. This is what very special feature about cardiac ventricle action potential, the flat phase or the plateau phase. What is depolarization due to sodium influx? Sodium coming inside, influx. Repolarization is due to potassium moving out, potassium efflux. Why do you have a plateau phase where there is no electrical activity? What is the reason for this plateau phase in between? Opening of L type of calcium channels. Okay. Dendrites was given Wonderland, doctor. Yeah, dendrites, definitely it's not the option because dendrite can produce only local potentials, not action potential. Rajesh says one option are open potassium, open calcium. Yeah, definitely opening calcium only is the answer. Potassium is not the answer because potassium is responsible for the repolarization, the complete phase 3, not phase 2. Let's discuss this. Why do we have a plateau phase? Why there is no electrical activity only during that phase 2? The reason is opening of L type of calcium channel. But if you note carefully, you will see that in phase 1 itself, repolarization has started because it is starting to come towards negativity like this. And in phase 3, there is complete repolarization. So in phase 1 itself, repolarization means potassium ions are moving out. Potassium is a positive ion which has started to move out in phase 1 itself because it is going towards negativity. So repolarization has started in 1 itself. It is completing in phase 3. But in between in phase 2, there is opening of L type of calcium channel. L means long-lasting calcium channels and calcium ions enter inside. Calcium is also a positive ion. One positive ion, potassium, is moving out. Another positive ion, calcium, is entering inside. Both these positive ions will balance each other and therefore there is no electrical activity happening. And this becomes a plateau phase. That is why in phase 2, because of opening of L type of calcium channels, it remains as a plateau phase. What is the ECG correlation of this plateau phase? When you record an ECG, this depolarization gives rise to ventricular depolarization, which gives rise to the QRS, and repolarization gives rise to T wave. So QRS is due to ventricular repolarization. T wave is due to ventricular repolarization. QRS depolarization and T wave repolarization. In between QRS and T wave, there is an ST segment. It is a plateau. It is a flat segment. Why it is a flat segment? Because it correlates with the phase 2, the plateau phase of cardiac ventricle action potential. When heart is going through this plateau phase, in ECG also you see this plateau phase. So that was about the cardiac ventricle action potential. So phase 2 of ventricular action potential is due to clearly calcium channel. To be very specific, L type of calcium channels, long-lasting calcium channels. Sodium is responsible for depolarization. Phase 0. Potassium is responsible for repolarization. Phase 1 and phase 3. Bicarbonate, there's no role here. So the answer is calcium channels. Yes, Dr. Kartika, plateau for calcium channel. Definitely, Doctor, plateau phase is because of L type, long-lasting calcium channel. And having completed cardiac ventricle action potential, quickly let me tell you about SA node action potential also, because in heart, we have two types of action potential. This is cardiac ventricle action potential. The other one is SA node action potential. So this is an SA node action potential. What is so special about SA node action potential? This phase 4, which is called pacemaker potential or slow diastolic depolarization phase. There are three channels which contribute to this pacemaker potential. The slope. You will not see this slopey phase in any other part of the heart. Only in SA node you have this slope. What is the slope doing? It is moving the RMP to a more positive value so that from here quickly you can get action potentials. That is why SA node is able to produce quick action potentials, the highest rate from the SA node. That's how it becomes a pacemaker also. Who is responsible for this phase 4? IF, which is a funny channel, TCAL, which is a transient type of calcium channel, and NCX, sodium calcium exchanger channel. These three channels, what are these three channels doing? They are trying to bring in positive ions. When they bring in positive ions, from here, they are moving the potential to a more positive value. If already you shift the potential to a more positive value, from here, easily you can get action potential. See, this is like, this point is ground floor. And this point is the first floor. And this point is the second floor. If you want to climb from ground floor to second floor, very difficult. But already, if you have a lift which is carrying you to the first floor, this phase 4, pacemaker potential only is the lift. Already, if the lift is taking you to the first floor, from first floor to second floor, easily you can climb. Only SA node has this lift. That is why SA node is able to quickly produce action potentials. So it means if you are moving the RMP to a positive value, you are accumulating positive ions inside. How will you accumulate positive ions inside? By these three channels. IEF, it is a funny channel. I for current and F for funny. It's a funny current which brings in Na+, sodium, a positive ion. TCAL, transient type of calcium channel which also brings in another positive ion, calcium. NCX, sodium calcium exchanger, which will remove calcium, but it will bring in Na+, sodium. So all these three channels, they are accumulating a positive ion inside the cell. More you accumulate positivity, So this will move the slope towards positivity. So from here, easily SA node can climb for action potential, and that's how it becomes the pacemaker. What is the clinical importance of learning all this? Why are we learning all this? Because in pharmacology, we have drugs which act on action potentials in the heart. If I have a drug which will block any of the phase of this cardiac ventricle action potential, it will control the heart rate. That's how they become antiarrhythmic drugs. So blockers of phases of action potential curve in the heart, they become antiarrhythmic drugs. Drugs which are used to control arrhythmia, heart rate. What are the drugs? Class 1 antiarrhythmics, which are voltage-gated sodium channel blockers. They will block depolarization phase. What are the voltage-gated sodium channel blockers? 1A, procainamide quinidine, 1B, lidocaine mexiletine, and 1C, flecainamide and propafenone. So class 1 antiarrhythmics are sodium channel blockers. VGNC is voltage-gated sodium channel blockers. If I block the sodium channel, I can block depolarization phase. So I can bring down the heart rate. Calcium channel blockers, which are class 4 antiarrhythmics. Verapamil, diltiazem. Calcium channel blockers will block phase 2. Plateau phase is because of calcium channel. So they are all blockers of this phase 2. Class 3 antiarrhythmics, voltage-gated potassium channel blockers. What are they? Amiodarone, ebutilide, dofetilide, and sotalol. They are all blockers of repolarization. Because they block voltage-gated potassium channels, potassium is responsible for repolarization. So they also act as antiarrhythmic drugs. So did you notice that class 1, class 4, and class 3, they act on cardiac ventricle. What about this class 2? We didn't discuss about class 2 because class 2 acts on the SA node. So which is the class 2 antiarrhythmic? Beta blockers like propranolol and metoprolol. They are all blockers of this pacemaker potential. They block the pacemaker potential, or the slow diastolic depolarization phase is blocked by propranolol and metoprolol. So beta blockers are class 2 antiarrhythmics because they decrease the slope of pacemaker potential. So that was an integration of physiology with pharmacology. So the answer is option A, calcium channels. Over to the next question, question number 5. Which of these is the one inhibitory neurotransmitter in the brain? So the question is about inhibitory neurotransmitters in the brain. The two different types of neurotransmitters in the brain, inhibitory neurotransmitters and excitatory neurotransmitters. The most important inhibitory neurotransmitter in the brain, GABA, and most important excitatory neurotransmitter in the brain, glutamate. Both starts with G, don't get confused. GABA is the major inhibitory neurotransmitter, whereas glutamate is the major excitatory neurotransmitter. Another inhibitory neurotransmitter, glycine, but glycine is the major inhibitory neurotransmitter in the spinal cord. GABA is the major inhibitory neurotransmitter in the brain, whereas glycine is the major inhibitory neurotransmitter in the spinal cord. And glutamate is excitatory. Going back to the question, which of this is inhibitory? The major inhibitory neurotransmitter is GABA. All others are excitatory. Serotonin, nitric oxide, and substance P, all others are excitatory. Yes. Over to the 6th question. Yes, Dr. Kartiga, ivabradine, it's also a funny channel blocker. What kind of coupling of dihydropyridine with rhinodine in the skeletal muscle? So this question we have discussed in detail. The two different types of coupling we discussed, it is different for skeletal muscle and it's different for cardiac muscle. In skeletal muscle contraction, what is the mechanism? From the neuron, if this is a neuron, this neuron connects to the muscle, and this junction between the neuron and the muscle, this is the neuromuscular junction. What is the sequence of events in the neuromuscular junction? When voltage-gated sodium channels open and sodium enters inside, there is action potential. And this action potential reaches the axon terminal and it opens up calcium channels and calcium enters inside. What is the role of calcium? Calcium will move the vesicle to release acetylcholine. This acetylcholine crosses the neuromuscular junction and it binds to the muscle. What are the acetylcholine receptors on the muscle? Nicotinic receptors. It binds to nicotinic receptors on the muscle. And these nicotinic receptors, they will sense acetylcholine. And when acetylcholine binds to the nicotinic receptors, there is opening of voltage-gated sodium channels and sodium entry. But this is in the muscle. There is sodium entry in the muscle. And therefore, there is action potential. And this action potential travels into the muscle. And this action potential, when it goes into the muscle, let's see what it does. It goes into structures called T-tubules. If this is the structure of a T-tubule, it is like a T. So this is a T-tubule. So when action potential goes into the T-tubule, this is a T-tubule. On the T-tubule, there are dihydropyridine channels. When action potential arrives at these dihydropyridine channels, action potential is an electrical event. So dihydropyridine will sense this electrical action potential. So this is coupled electrically now. And then what it does, dihydropyridine, if this is dihydropyridine, it will move, it will make some changes like this. It will move inside and it will touch actin. So this is dihydropyridine. It moves inside and it will touch, not actin, sorry, rhinodine. When dihydropyridine touches rhinodine, where is rhinodine present? This is SR, sarcoplasmic reticulum, which has rhinodine receptors. Rhinodine receptors. So dihydropyridine makes some configurational changes, moves inside, it will touch rhinodine. When DHP touches rhinodine, rhinodine will open up. When rhinodine opens up, SR will release calcium. So this releases calcium. So how is this coupled now? Dihydropyridine is touching rhinodine. So it is a mechanical coupling. So now it becomes a mechanical coupling. Initially it is electrically coupled. Later it is mechanically coupled. How is it electrically coupled? Action potential is an electrical sequence. So electrically coupled, sensed by DHP, it will move and touch rhinodine. So now it becomes mechanical coupling. So this is an electrical followed by mechanical coupling of dihydropyridine with rhinodine. So that was about question number 6. Go to question number 7. Postganglionic sympathetic cholinergic innervation is seen in. We have discussed this in autonomic nervous system. In detail, we had discussed this. I told you about the autonomic neurons. The autonomic nerves, there are two types. When autonomic nerves move out of the CNS, they enter into a ganglion. So this is the autonomic ANS ganglion. So the set of nerves before the ganglion, so these are called preganglionic autonomic nerves. From the autonomic ganglion, another set of nerves come out to reach the effector organ. So it reaches the effector organ. This comes out of the ganglion. So this becomes postganglionic autonomic neurons. Postganglionic autonomic neurons. So preganglionic autonomic neurons and postganglionic autonomic neurons. Preganglionic autonomic neurons are of type B and postganglionic autonomic neurons are of type C. In Erlanger-Gassert classification, preganglionic is type B and postganglionic is type C. Now what happens? The preganglionic neuron enters into the ganglion and comes out of the ganglion as postganglionic neurons. What about the neurotransmitters released at the end of preganglionic neuron? The neurotransmitter released is always acetylcholine. It is always acetylcholine. It can be preganglionic sympathetic, or it can be preganglionic parasympathetic. The preganglionic will always release acetylcholine. But what about postganglionic neurons? The postganglionic neuron, the neurotransmitter released by the postganglionic neurons, it is of two types. If it is a sympathetic nerve, if it is a postganglionic sympathetic, then it would release norepinephrine. If it is a postganglionic parasympathetic, it releases acetylcholine. And this postganglionic sympathetic always releases norepinephrine, but there is one exception where a postganglionic sympathetic, instead of norepinephrine, produces acetylcholine. And this we call it as the sympathetic cholinergic. It is in the sweat glands, the sympathetic cholinergics of the sweat gland. So sympathetic cholinergics of the sweat gland, that's why it's called cholinergic. A postganglionic sympathetic, instead of producing norepinephrine, it produces acetylcholine. So these are the sympathetic cholinergics of your sweat gland. So that was about the postganglionic sympathetic cholinergics of the sweat gland. The postganglionic sympathetic cholinergic innervation is seen in, yes, it is your sweat glands. Over to question number 8. Which one of the following is not reabsorbed along with sodium in the proximal convoluted tubules? See, in the PCT, in your proximal convoluted tubules, what happens in the PCT? So let me just show you the events that take place in the PCT. The proximal convoluted tubule. Just imagine this is a glomerulus. If this is a glomerulus, same slide we have discussed in our classes. If this is a glomerulus and plasma is flowing into the glomerulus, it is getting filtered. And this is the PCT, proximal convoluted tubule. So in the proximal convoluted tubule, if this is one part of the PCT, let's say this is one segment of the PCT, what are all the events that are happening in the proximal convoluted tubule? Proximal convoluted tubule has two sides. This side, which is facing the lumen, is called apical membrane. This side, which is facing the blood, is called basolateral membrane. Apical membrane and basolateral membrane. Reabsorption happens in the PCT. What is reabsorbed and how much it is reabsorbed? Reabsorption of 60% sodium, chloride, potassium and water takes place in the PCT. How is 60% sodium, chloride, potassium and water reabsorbed? First, let me show you how is sodium reabsorbed. Through sodium glucose cotransporter. I think you're not able to see the slides hiding behind. Okay, let me take you to another slide. Let me just show you this. Okay, please note down. These are the important events that take place in the PCT. Now I think you're able to see. Yes. So the important events taking place in the PCT are 50% urea reabsorption, 60% sodium, chloride, potassium and water reabsorption, 70% calcium reabsorption, 80% phosphate reabsorption, 90% bicarbonate reabsorption and 100% glucose, amino acids and proteins are reabsorbed. There is also formation of ammonia from glutamine here. What is the use of this ammonia? Ammonia can utilize H+. It is a buffer in the PCT. Conversion of calcifidiol into active calcitriol, active vitamin D. This also takes place in the PCT. So these are the important events related to PCT. So you know that 60% sodium is reabsorbed in the PCT. So let me show you what are the mechanisms by which sodium is reabsorbed in the PCT. Sodium is reabsorbed by sodium amino acid cotransporter, sodium glucose cotransporter. What is the name of this transporter? Yes, SGLT2. And sodium is also reabsorbed along with bicarbonate. bicarbonates. So along with sodium, amino acids, glucose and bicarbonate are reabsorbed. Urea is not reabsorbed along with sodium because urea is reabsorbed by solvent drag. Solvent drag means when water moves, wherever water moves, water will pull urea along with it. That is called solvent drag. So urea is reabsorbed along with water, not with sodium. That was about the 8th question. Over to question number 9. Filtration barrier is formed by all these parts of a nephron except. The filtration barrier is formed by podocytes, yes. Endothelial cells, yes. Basement membrane, yes, but not the mesangial cells. Let me show you the filtration barrier. If this is image A, which is a diagram of one glomerulus, inside which you can see many capillaries. You can see the afferent arteriole and the efferent arteriole also. And in diagram B, we will zoom into a glomerular capillaries. This is one glomerulus. You can see 4 capillaries here. And in between the capillaries, you have mesangial cells. So these are the mesangial cells. What is the role of mesangial cell? Mesangial cell is very closely related to the wall of the capillary. So if this is a mesangial cell and this is a capillary, mesangial cells are very closely attached to the wall of the capillaries. Whenever mesangial cell contracts, it will contract the capillary wall also. If the capillary wall contracts, then the surface area for filtration decreases. Because the capillaries are contracting, capillaries are the filtration bed. When they contract, the area for filtration decreases, so GFR decreases. When mesangial cells relax, they will relax the capillary wall and therefore the surface area of the capillary increases, filtration also increases. So mesangial cell contraction decreases GFR and mesangial cell relaxation increases GFR. That is the role of mesangial cell. Now let's zoom into one of the capillary. This is the structure of a capillary with the inner layer endothelium, outer layer basal lamina, and outer to that you have the podocytes. The green colored foot-shaped processes are podocytes. And the other image, let's zoom into the inside of a capillary. You can see the capillary fenestrations, capillary lumen, basal lamina. Basal lamina is nothing but glomerular basement membrane. Basal lamina only is the GBM, glomerular basement membrane. And you can see the foot-shaped podocytes here. And this endothelium, glomerular basement membrane, and podocytes, they form the 3 walls. The filtration barrier is formed by inner layer endothelium, outer layer basal lamina or GBM, glomerular basement membrane, and outer to that the podocyte. So these 3 layers form a wall. Through this wall, filtration cannot take place. But in between, you have slits, the filtration slit, through which filtration takes place. So what is the filtration barrier? Filtration barrier is formed by the inner wall is endothelium, outer wall is basement membrane, and outer to that you have the podocytes. These 3 layers form the wall for filtration. It's called the filtration barrier. In between, through the filtration slit, filtration will take place. So barrier is formed by endothelium, glomerular basement membrane, and podocytes. Over to question number 10. Which of these parts is responsible for declarative memory or explicit memory? And obviously, explicit memory. Memory is always related to hippocampus. So the answer is hippocampus. Yes, few of you said amygdala was there in the option. Even if amygdala was there, it is not related to explicit memory. It is related to associative learning, implicit memory, not explicit memory. So with these options, the explicit or declarative memory. If you are able to remember facts, it is called, first let's say, let's understand what is explicit memory. Explicit memory. So explicit memory is called declarative memory. This is like a Viva exam. In a Viva exam, if the examiner is asking you a question, it's an oral exam, but the examiner is asking you a question. If the examiner is asking you a question, you should be able to think, recollect the answer, and you should be able to give the answer. You have to say the answer. Or you have to declare the answer. Only if you declare the answer, you will get marks. So explicit memory, where you have to declare the answers, that's why it is called declarative memory. If you are able to remember facts, anatomy, physiology, all these are facts. This we call it as semantic memory. If you are able to remember events, this we call it as episodic memory. So two types of explicit memory, semantic memory and episodic memory. And what are the parts of the brain which are responsible for this? Semantic memory with the help of lateral and anterior temporal cortex and prefrontal cortex. Episodic memory with the help of hippocampus. I think that was the question. Hippocampus, medial temporal lobe and neocortex. What about non-declarative or implicit memory? There are 4 different types of non-declarative or implicit memory. What are the 4 different types of non-declarative or implicit memory? Procedural memory, priming, associative learning, and non-associative learning. Let's discuss all this in detail. The 4 different types of implicit memory. Number 1 is priming. What is priming? Priming means if you are able to learn with the help of clues. If you are able to prime your brain with something which you already know, that is a clue. Learning with the help of mnemonics, stories, all this is priming. For example, if I want all of you to say this word Jerry, what can I do? I can say Tom and dash. So if I say Tom and dash, all of you are going to say Jerry only because you already know that it is Tom and Jerry. So by combining something which you don't know with something which you already know, this is called priming. Example, stories, mnemonics, learning with the help of clues, hints, all this is priming. So let me tell you one question which was asked in your exam on priming. Just see if you are able to answer this. A student was answering a Viva exam and the examiner is asking who discovered EEG? The examiner is asking who discovered EEG? The student doesn't know. So what the examiner does, he's trying to give a clue. He's giving a clue that this is something which you eat at McDonald's. The student is thinking and he immediately answers burger. Burger is something which you eat in McDonald's. And the answer for EEG is also burger. Hans Burger only discovered EEG. So the examiner wanted the student to say this word burger. So he is saying something which you eat at McDonald's and the student is immediately saying burger. So priming means learning with the help of clues like this. Was a repeat question. A case scenario was given between an examiner and a student and this burger term was asked and the student was able to recollect and say. So what was the memory process which was happening on in the student? Priming. So that is priming. Over to the second type of implicit memory, which is called associative learning. There are 2 types of associative learning. One is classical conditioning, and the other is operant conditioning. What is classical conditioning and operant conditioning? Classical conditioning is the famous Pavlov's experiment, the dog and the bell experiment. Once you ring the bell and give the food to the dog, every time you ring the bell, give the food to the dog is learning that if you ring the bell, you will give him food. This is one type of learning, which is called classical conditioning. So let's see classical conditioning. Just see before conditioning what happens, during conditioning what happens, and after conditioning what happens. Before conditioning, this is the dog and you give the food to the dog. Food is an unconditioned stimulus because anybody who sees food unconditionally, you will have salivation. So that's an unconditioned response. Looking at the food, anybody will salivate. It's not a condition, it's an unconditioned response, nature. But neutral stimulus, what is a neutral stimulus? Ringing a bell is a neutral stimulus. So if you ring a bell, dog is not going to salivate. Ringing a bell has nothing to do with salivation. So a neutral stimulus will not produce response. But now what you do, you condition. What are you conditioning? You are giving a condition to the dog that if I ring the bell, I will give you the food. You ring the bell, give the food. Ring the bell, give the food. So every time you ring the bell and you give the food to the dog will salivate. But the dog is salivating for the bell or for the food? For the food only, the dog is salivating. Because still it is in the process of learning. It is during conditioning. It is still learning. But once the dog has learned that if you ring the bell, you're going to give him the food. After conditioning, after it has learned the condition, see what happens. Just you ring the bell. Ringing the bell is a conditioned stimulus because you only made a condition that if I ring the bell, I'll give you the food. So this is a conditioned stimulus and the dog is salivating. Now the dog is salivating for the bell itself because you have trained the dog that if I ring the bell, I'll give you the food. So you just ring the bell. The dog will be able to correlate that bell is ringing. Anyway, you're going to give him the food and immediately it will start salivating for the bell itself. So after conditioning, it becomes a conditioned stimulus and a conditioned response. So that was about the classical Pavlov's experiment, the dog and the bell experiment. It's an example for classical conditioning. Operant conditioning. What is operant conditioning? There are two types of operant conditioning. One is positive reinforcement. Positive reinforcement. And number two, negative reinforcement. What is positive reinforcement and negative reinforcement? Positive reinforcement is when you give some reward to the patients or to the children. If you give a chocolate to a child, the child will be very happy. The reward center is activated. If you clap hands for someone, they are very happy. If you congratulate someone, they are very happy. So whenever you praise someone or you give gifts to someone, you activate the reward center in the brain, and the neurotransmitter for reward center is dopamine, and this is called positive reinforcement. By doing this, you can make somebody to learn. If a child is not learning, you give him a chocolate, he will learn properly. But negative reinforcement is instead of giving chocolate, you start beating the child, you scold the child, then also the child will learn. But that's not the right way to teach a child. Every time scolding him and beating him, that is giving him punishment. So it will create a negative impact on the brain. This is called negative reinforcement. If you activate the punishment centers of the brain, this is called as negative reinforcement. So positive reinforcement, activation of reward centers, and negative reinforcement, activation of punishment centers. So that was about operant conditioning and the two types of operant conditioning. Procedural memory. What is procedural memory? This is also another type of implicit memory by which you learn a procedure. For example, swimming. If you want to learn swimming, swimming is a procedure. You need so many parts of your body to learn swimming. So what are all the parts of your body you need for procedural memory? Just think what all parts of the body you need to learn swimming. Swimming can be learned only if your muscles are working. Only muscles are enough. You need your spinal cord. You need your spinal cord. You need your motor tracts. The motor tracts, they come from motor cortex. So you need your motor cortex. From the motor cortex, you have impulses coming down through the motor tracts into the spinal cord. Cerebellum also has a role in motor movements. So cerebellum also you need to learn swimming. Basal ganglia. Basal ganglia is another part which also has a role in motor movements. So basal ganglia also should function if you want to learn swimming. So all these parts are important for procedural memory. There was, I think, a repeat question previously on this where the question was like, procedural memory, which are all the parts of the brain which are needed? Spinal cord, cerebellum, basal ganglia, muscles, all of the above. So it's all of the above. You need all these parts to learn swimming. Not only swimming, dancing, or any procedure you want to learn, you need to have all these parts. Non-associative learning. This is the fourth type of implicit memory. In non-associative learning, you are not learning it with any association. It's not conditioning, or it's not reward centers, or it's not by giving clue. Just you learn by basic mechanisms of habituation and sensitization. If you are able to learn by basic mechanisms of habituation and sensitization, this is called non-associative learning. So these are the 4 different types of implicit memory. There is also another type of memory based on time. Short-term memory and long-term memory. Short-term memories are converted into long-term memories at hippocampus. This is called consolidation of memory. How short-term memories are converted to long-term memories at the hippocampus. And if there is any damage to the hippocampus, short-term memories cannot be converted to long-term memories. And this we call it as short-term memory loss. Short-term memory loss or anterograde amnesia. What is anterograde? Anterograde means future memory is going to be lost. That is called anterograde amnesia. So short-term memory loss or anterograde amnesia. Have you seen this movie, Gajni? Yes, where Amir Khan is suffering from anterograde amnesia. So he will have an injury to his hippocampus, and from that day onwards, he is not able to convert short-term memory into long-term memory. So what does he do? He'll keep writing all over his body because he will forget every 15 minutes. So that is how he is able to recall things by writing all over his body. He'll have photograph of all the people he is meeting. Because there is damage to the hippocampus, he was not able to convert short-term memories into long-term memories. That is called short-term memory loss or anterograde amnesia. Now, there is another type of injury where hippocampus is fine. Hippocampus is fine, but all the past stored memories have been erased. What type of memory loss this is? If today there is an injury to a head injury to a patient, hippocampus is not affected, but stored memories have been injured. There's a damage to the areas which have stored the past memories. He will forget his past, but from today onwards, he will be able to convert short-term memory into long-term memory. So his future memory is not affected, but past memory is lost. Past means retro. So this we call it as retrograde amnesia. Retrograde amnesia. So that was about anterograde and retrograde amnesia. There is another part in the brain, or there's another type of memory in the brain, working memory. What is working memory? So this is a very temporary form of memory. The brain is not converting these memories into long-term, very temporary form of memory by which you remember OTPs. Very good example is OTP. When you're making some transaction with your mobile, some Swiggy or Zomato you're ordering, it will give you an OTP. What do? You go to the messenger tab, you look at the OTP. Suppose 54321 is the OTP. You come back to this, you put the OTP. Until you put that OTP, you will keep on saying that 54321, 54321, and then you put the OTP. After 5 minutes, if I ask you what is the OTP, nobody will be able to recollect because it is a temporary form of memory. Brain will not store all this. That's why it is called one-time password. You put it one time, after that, you will not be able to use that. So remembering OTPs, especially for one time, and afterwards you don't recollect that, it will fade away as a working memory. So that is working memory, a very temporary form of working memory. So this is the different types of memory based on time. Just for completion, I'll just tell you what are the other areas of the brain involved in learning and memory. So apart from all that what we have discussed, what are the other areas of the brain involved in learning and memory? Thalamus. What is the role of thalamus? Thalamus has an anterior nucleus. Anterior nucleus of thalamus, especially for recent memory. Recent memory is stored in the anterior nucleus of thalamus. Hypothalamus. What is the role of hypothalamus in memory? Hypothalamus has mammillary body. Hypothalamus, this has a mammillary body. What is mammillary body? See, mammillary sounds like memory, no? So mammillary has a role in memory. So hypothalamus helps in The mammillary body helps in memory. If there is any degeneration of this mammillary body of your hypothalamus, this can result in a special form of memory loss, which is called Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome. It's a special form of memory loss, usually seen in chronic alcoholism and thiamine deficiency patients. Limbic system. What is the role of limbic system in memory? Limbic system is related to emotion. So fearful memories are stored in the limbic system. Basal forebrain. Basal forebrain has a nucleus which is called nucleus basalis of Maynard, and this nucleus produces acetylcholine. If there is any age-related degeneration of this nucleus basalis of Maynard and loss of acetylcholine in older people, what is that disease called as? Yes, Alzheimer's disease. Alzheimer's. I'm just telling you all the possible questions which can be asked from memory. Alzheimer's disease. Corpus callosum. What is corpus callosum? Commissural fiber, the connecting fibers between both the hemispheres. If there is any injury to corpus callosum, hemispheric transfer of memory will be affected. Hemispheric transfer of memory. So that was about the questions related to memory. Let's go back to our question now. The question that was asked: which part of the brain is responsible for explicit or declarative memory? Yes, clearly it is hippocampus. Yes, few of you are saying that amygdala was in the option. Even if amygdala is in the option, it is for implicit memory, not for explicit memory. Over to the next question is the last question. When a patient has increase in plasma osmolarity, it will cause increased secretion of which of these? See, whenever there is increased in plasma osmolarity, it means the salt concentration is increasing in your blood. To dilute this, immediately ADH will be produced. What is ADH? A for anti, D for diuretic, and H for hormone. Antidiuretic hormone. What is diuresis? When more water moves out in urine, that is called diuresis. If water is not moving out in urine and you reabsorb water, if water goes into the blood, that is antidiuresis. So what is the role of ADH? To reabsorb water into the blood. This is the role of ADH. When do you want to reabsorb water into the blood? Whenever plasma osmolarity increases. If your plasma concentration increases, you want to dilute your plasma, you can stimulate ADH, and ADH is antidiuretic hormone. It will reabsorb water into the blood, it will dilute your plasma osmolarity. So whenever plasma osmolarity increases, it is the trigger for ADH secretion. What is the other name of ADH? Vasopressin. ADH is otherwise called vasopressin. So that is about vasopressin. Don't confuse with atrial natriuretic peptide, because ANP will be produced in response to plasma volume. Whenever plasma volume is increasing, it will cause natriuresis. It is not plasma osmolarity. Don't confuse with renin also, because renin will be produced whenever there is a fall in BP or there is a fall in the plasma volume. So vasopressin only is produced when there is an increase in plasma osmolarity. So that was a quick review of INI-CET May 2024 recall questions. Hope it was a useful session. Yes, Dr. Kartika, Wonderland, Fatima, Dr. Pooja, yes, Dr. Arvind. Any changes in the options, or you think we have missed any questions, please do comment in the chat box. I think as far as this, there are no controversies with the question or options. If anything, please let me know in the comment box. Yes, with this, we end our session on physiology. Over to the next session on oral surgery with Dr. Himani Joshi ma'am, our legendary faculty. I need not introduce ma'am at all to you. So all of you know ma'am. So I welcome ma'am to the discussion on oral surgery. Thank you, students. Hello, ma'am.
Thank you, Dr. Abhirami, and very, very insightful session that you have taken. Thank you so much.
Thank you.
All right. So I will just quickly turn on my YouTube and to check all your doubts live. 1 second. Just give me a moment. One second. Give me 1 minute. We can all take a little break. All right. I can see 39, 50 of you live here. Everybody just take a 5 minutes break. I am just connecting my iPad with my laptop so that you can all see my screen. So just give me 5 minutes. You can all just drink some water and come back in 5 minutes. All right. Yeah. So I'll just turn on my video, and in 5 minutes we'll see you. You can just grab some water or something. पीयूष, अब इसमें वो कर तो दिया है, अब इसमें ऐसे आ रहा है। Manisha, am I audible?
Yes, ma'am.
ओके, सो मुझे थोड़े से चेंजेस करने पड़े हैं यहाँ पे। हम्म, अ, 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 ओके, सो मैं ना थोड़ा सा स्क्रीन शेयर करने का ट्राई कर रही हूँ, वो नहीं हो रहा है। So guys, we'll just start the session now in a while. And 4:30 exactly, we will start with the periodontic session first. And after perio, we will take oral surgery. All right. I'm very sorry. There's some technical glitch here in my system. So we will start with periodontics at 4:30 sharp. Consider this like a interval between the movie. And Dr. Divya is just starting with the periodontic session in 15 minutes. All right.
बोलो स्टार्ट करें अभी ये तो हटा दो ना आ गया ना स्टार्ट करो Hello everyone. So I'm Dr. Divya Gupta, original guru for Periodontics at DBMCI MDS, and welcome to the Mega Recall session of INI-CET May 2024. Basically, this time the paper was a little bit tricky and a difficult paper. Talking about the periodontics part, from periodontics, the questions, the topics basically were a repeat topics, but you need to be clear with your concepts while answering the questions, because 2 to 3 questions were such in which there were multiple multiple answers were there, and you had to mark the correct answers. Okay. So overall, there were 9 questions from periodontics, excluding the implant part. And with that, let us start this session. So before starting the session, I would like to say that, guys, if you find that any of the question or options are not correctly recalled, we have tried our level best. Like our students helped us a lot in this, and we have tried our level best to correctly, recall all the questions. But still, if some options are missing, or some options are not as that like they were given in the exams, please let us know in the comment section. As I'm going forward with the questions, you can write the question number which is not correctly recalled and what you think was the question from that particular topic. Okay, so that we can make the necessary changes after we go through the questions. So let us start with the session. The first question is, so it was an image-based question, and so it is an image-based question, first question, and this image was directly taken from Carranza. Same to same image is given in Carranza. The first question is the internal bevel incision. The internal bevel incision as marked with number 2 in the image below will raise. Option number A. So here, actually, the image is there, and this was not cancelled in the image. In the exam, it was not there. So from this image only, you can make out what is option number 2, right? So option number A is undisplaced flap. Option number B is an apically displaced flap. Option number C is modified Wiedemann flap. Modified Wiedemann flap. And option number D is coronally displaced flap. Now, guys, the answer to this question is, as you can see in this image, this is a direct pick from the Carranza. This image is a direct pick from the Carranza. And the answer to this question is an undisplaced flap. So here, number 1 and 3, these incisions. What is this incision? This is an internal bevel incision, right? These incisions we have discussed very nicely in our live sessions as well as in the recorded sessions. And okay. Am I not audible? My voice is not coming. Am I audible, guys? अनिल भाई आवाज आ रही है? आ रही है? हाँ हाँ, तो basically this is an internal, all these 3 are internal bevel incisions. Now 1 and 3, this 1 and 3 is the internal bevel incision that is given during a modified Wiedemann flap or an apically displaced flap. So basically what we do is from 1 to 2 mm distance from the gingival margin, we make an internal bevel incision up till the alveolar crest. That is your modified Wiedemann flap and apically displaced flap. Now in undisplaced flap, what we do is, in this undisplaced flap means the flap is not getting displaced from its original position, right? It is placed at its original position only. Now, in undisplaced flap, the incision begins from the depth of the pocket. So what we do is, we take the periodontal probe, we insert the probe up till the depth of the pocket, and we mark a bleeding point here. Here. Okay. Now, this bleeding point, from the apical penetration of the probe, we will start our incision. The incision line starts from there. So, the disadvantage of undisplaced flap is a large amount of tissue is getting detached, right? A large amount of tissue is getting detached. And to do an undisplaced flap, we need to have an adequate width of keratinized gingiva. Okay. Now, this is a direct pick question and a relatively simple question to answer, right? Now, let us move to the second question. The second question is again a repeat topic, right? This is a repeat topic. But still, the options were a little bit tricky here. NUG is a frequently asked topic and it is asked every year, right? So, let us read the question first. Which of the following are the clinical features of acute necrotizing ulcerative gingivitis? Now, the term is very important. Gingivitis, right? Means we are not reaching the periodontal level, periodontal depth level. We are just at gingivitis level, gingival level. We are not talking about NUP. No. Remember, the features of NUP and NUG are different. In NUP, you will see recession. Okay. In NUP, there might be slight bone loss, but severe bone loss, vertical defects will be seen in NUP only. Severe bone loss will be seen in NUP only. Okay. So, let us see the options. Option number 1 is NUG occurs due to viral infection. Now, we know the common etiology of NUG is bacterial. It is due to a bacterial infection. NUG is due to bacterial infection. And which bacteria are responsible for the infection of NUG? This was asked in NEET MDS 2024 also. Fusobacterium, and spirochetes primarily. So, NUG is a bacterial infection. It is not a viral infection, right? So, this option is not correct. This option is not correct. Now, the next question. Bone loss is seen. Yes. In NUG, initial bone loss can be seen. They have not mentioned whether it is a severe bone loss. But yes, in NUG, slight bone loss can be seen. So, we can consider that this option can be correct. Third is punched out crater-like lesion. Now, this option is definitely correct, right? Because punched out crater-like lesion is the characteristic feature of NUG. It is seen in NUG. This we are reading since the beginning. Lastly, recession. So, recession is not a feature of NUG, guys. It is a feature of NUP, right? So, we, by looking at these options, option number 2 and 3 seem to be correct. Now, let us select the correct answer. So, as the option number A says, 1 and 2 is correct. No, we know 1 is not correct. 2, 3 and 4 are correct. No, only 2 options are correct. So, C is 1 and 4. No, and option number D is 2 and 3. So, here the correct answer is option number D, that is 2 and 3. Bone loss is seen and punched out crater-like lesion. Now, guys, if you feel that there is some other option as well to this question, please let me know in the comment section. Okay, so we can discuss it again. Now the third question is again a little bit tricky and a difficult question to answer, though a repeat topic. Smoking in my recorded sessions, during our discussions of INI-CET, also power grant tests, there were questions from smoking, there were questions from NUG. So these are the repeat topics which we have already discussed in our power grant tests, right? So basically, smoking also is an important topic, but here the options which were given were slightly, tricky and difficult to choose between them. But when such questions are there, if you know at least two options are correct, then what you have to do is you have to look here. You have to see the correct answer, and by exclusion of the wrong options, or by knowing even one or two correct answers, you can answer such questions, right? So let us see the options. Periodontal effects of smoking are GCF flow decreases. Now in smoking, the GCF flow decreases initially. In smoking, the GCF flow decreases initially. After that, it comes back to normal. So yes, in smoking, initially there is a decrease in the GCF flow. Second option is subgingival. It is not lingual, it is gingival. This is not lingual, this is gingival. So subgingival increase in temperature is seen. Subgingival increase in the temperature is seen. Third option is increase in fibrogen. Fourth option is decrease in fibrogen. And fifth option is decrease in the number of yellow complex bacteria. Now, during our sessions also, it is not mentioned whether, the number of which complex bacteria increases or decreases, right? This is a little bit tricky option to answer. So, basically what happens is, GCF flow decreases, that we all know is correct, right? GCF flow decreases. Now here, subgingival increase in the temperature is seen in smoking patients. No, we know that subgingival temperature decreases. Subgingival temperature decreases in smokers. There is increase in fibrogen. Now, smoking, what does smoking do? Smoking causes increase in inflammatory mediators, right? One of the inflammatory biomarkers is fibrinogen. Now, this time, guys, there were many, 2 to 3 questions were there from inflammatory part. So, we discussed this inflammatory part in much detail, host response and host immunoinflammatory response, which is the pathophysiology of chronic periodontitis in very much detail in our recorded sessions. We have discussed it. Okay, so if you are clear with how the host responses or how the host responds to bacteria, you will know that during inflammation in the periodontium, there is increase in the inflammatory markers. There are various inflammatory markers such as interleukins, interleukin 1, interleukin 6, TNF alpha, interleukin 10. All these are the pro-inflammatory markers, means cytokines are increasing, prostaglandins are increasing, acute phase reactive protein, C-reactive proteins are increasing, fibrinogen is increasing. So in smokers, as the inflammation is increasing, periodontal inflammation is increasing, that is increase in the fibrinogen level also. There is increase in the fibrinogen level also. So this is the correct option. Decrease in the fibrinogen level? No, it does not decreases. Now, if we know at least these two options are correct, and if we don't know this, the fifth option, decrease in the number of yellow complex bacteria, let us see the options now. Option number 1 is correct, right? And option number 3 is correct. So we need to have an option in which option number 1 is there and option number 3 is there. Okay, so in this, basically, sorry guys, in this, the 1, 3 and 5. Okay, in this basically it is not put correctly here. 1 and 3 should be in the option. So sorry for this. This should be correct. So the option number C is 1 and 3. And the answer to this question is C. Correct answer is C. 1 and 3 is correct. So decrease in the number of yellow complex bacteria. So guys, no. There is no decrease in the yellow complex bacteria. Basically, what happens is the yellow complex bacteria are remaining the same. In this, there is, due to smoking, what happens is the red and the orange complex bacteria increases. There is increase in red and orange complex bacteria, and there is no change in yellow and purple complex bacteria. Okay, they remain as it is. So there is no decrease in the yellow complex bacteria. They remain the same. But yes, the orange complex bacteria and the red complex bacteria are increasing. Therefore, these are the bacteria which are responsible for periodontitis. So they causes increase in the inflammation in smokers. So the answer to this question is option number C. Okay. Now the fourth question is, which amongst these is the clinical sign of traumatic occlusion? Again, a repeat question. This is a repeat question. This has been repeated many times and we have discussed this in our sessions as well. So, which amongst these is the clinical sign, is the first clinical sign of traumatic occlusion? Option number A is mobility. Option number B is attrusion. Option number C is PDL widening. And option number D is pathological migration. The answer to this question is mobility. Okay. Now the fifth question. Again, a repeat topic. Which of these are the steps in osseous resective surgery? So osseous resective surgery and bone loss patterns are repeated topics. They are being asked previously as well. So this is a repeat topic and relatively a simple question to answer. In this, they have asked step by step the procedures which we do in the osseous resective surgery. So in osseous resective surgery, basically we are doing two procedures, right? Osteoplasty and ostectomy. So basically we are doing osteoplasty first and ostectomy. Osteoplasty means reshaping of the bone, right? Reshaping of bone. And ostectomy is removing the supporting bone of the tooth, removing the supporting bone of tooth. So if this is the tooth, guys, I'll just tell you what is the supporting bone in short. So if this is the tooth, okay, this we are seeing the tooth from the proximal aspect. And here is the bone. So the bone which is here, this part, this is the supporting bone of the tooth. And if this is decreasing or we are reducing this part, then it is called as ostectomy. We are removing the support of the bone. We are removing the support of the tooth. Okay, so that is what is called as ostectomy. And osteoplasty means we are just reshaping the bone. So what we do is here the outer cortical plates, this part is reshaped. That is what is osteoplasty. Okay, so in osteoplasty, basically there are two procedures. Osteoplasty, there are two procedures. Vertical grooving and radicular blending. Radicular blending. Okay, so in vertical grooving, what we are doing is we are taking a round burr and we are whatever part has enlarged, exostosis is seen, we create interradicular grooves, interradicular or interdental grooves are created with the help of a round burr like this. Now we cannot leave the bone as it is seen in this picture, right? We need to gradualize it. We need to make it more smoother. So what we do is we do radicular blending. With the help of a round burr, we just take it and reshape the outer portion so that there is a gradualization. Gradualization, a continuity is maintained in the bone. Okay, so these are the parts of osteoplasty. These are the parts, these are the steps of osteoplasty. Now in osteotomy, what we do is osteotomy, as the name suggests, we remove the supporting bone of the tooth. So here, what we are doing is whatever bone. So after vertical grooving, whatever little irregularities were there in the marginal bone in between the teeth, we remove them with the help of a burr, a round burr. So we do a horizontal grooving, means interproximally, we will move our burr like this in the horizontal direction in the interproximal area. As you can see here, we'll move our burr like this in the horizontal direction between the teeth like this, and we will do this horizontal grooving. So horizontal grooving is the third step of osseous resective surgery. And afterwards, whatever irregularities are there here on the marginal bone, we remove them by scribbing. Okay, by scribbing. So this scribbing is also known as gradualizing the marginal bone, gradualizing the marginal bone. Okay, so now the steps you can see of osseous resective surgery are vertical grooving. Second is, the first step is vertical grooving. The second step is radicular blending. The third step is horizontal grooving. And the fourth step is scribbing or gradualizing the marginal bone. So let us see the options now. Option number A is vertical interradicular grooving. Option number B is radicular blending. Option number C is third is horizontal grooving, and fourth is gradualizing the marginal bone. So here, yes, option number A is correct. Option number A is the correct option because it is in the sequence as we have seen already in the discussion. Okay. Okay. We have a doubt in traumatic occlusion widening. In traumatic occlusion, widening of PDL is seen. So why you choose mobility? Yes, the first, see, in traumatic occlusion, basically all the features are seen. Adhesion is also seen. PDL widening is also seen, right? Pathologic migration is also seen. But adhesion and pathologic migration are seen at a later stage. The first clinical sign of traumatic occlusion is mobility. And PDL widening is a radiographic feature. It is a radiographic feature. It is not a clinical feature. Not a clinical feature. We cannot see PDL widening clinically. We can see it only radiographically. And pathological migration and adhesion are the clinical features. Adhesion and pathologic migrations are the clinical features, but they are seen at a later stage. At the initial stage, the first sign of traumatic occlusion is mobility. Okay, understood? Now, the next question, let us move to the next question. And again, a question from bone loss patterns, which is a repeat topic. But mostly from the bone loss patterns, we get questions on reverse architecture. We get questions on crater. In NEET NTS also, we got a question from reverse architecture, right? So it is a repeat topic again. A repeat topic. Just hold on, guys. Plateau-like bone margins is seen in which type of defect? So plateau-like bone margins, this is a definition of one of the bone loss patterns. So let us go through the option. This is a direct question, okay? Option number A is craters. Option number B is ledges. Option number C is vertical bone loss. And option number D is reverse architecture. Now the definition of ledges is, ledges are the irregular plateau-like bone margins. They are plateau-like defects or plateau-like edges that are seen at the bony margins. Plateau-like edges seen at the bony margins. So how does a ledge will look? How does a ledge will look? So if this is the defect at the margin of the bone, because of irregularity in bone resorption, you will see ledges, depressions and elevations like a plateau. These are called as bony ledges. Okay. So the answer to this question is ledges. Now the next question. This is also a repeat question, but guys, this is a repeat question only from a repeat topic, right? But the most of the times, we find it difficult to remember what all are the universal examples of universal curates. Mostly in exams, examples of universal curate is asked. This we have discussed in our live sessions. So, basically, you need to remember the examples because universal curate is one of the most commonly asked question in the exam. This is a direct question. Which of the following is not a universal curate? Option number A is Indiana University. So they have asked not a universal curate. Okay. Option number A is Indiana University 13 and 14. Option number B is Columbia 13 and 14. Option number C is Barnhart 5 and 6. And option number D is Rule 1 and 2. So here the answer to this question is rule is correct. Rule universal curate is there, but the number here is not correct. Here it should be 3 by 4. 3 and 4. So it is a double. So I just hope you all know why 13, 14, 5 and 6 is written, because universal curates are double-ended instruments. Universal curates are double-ended instruments. So at one side it is 3 and the other side is 4. So the answer to this question is rule 1 by 2. Okay. Now the next question. So this is a slightly difficult question. Not slightly, this is a difficult question basically. A difficult question. But if you know immunoinflammatory response nicely, immunoinflammatory response in periodontitis. This topic, if you know, you can answer this question with, little bit brainstorming. So here, actually, we were not able to recall all the options. Okay, I'll just tell you the basic mechanism, what is happening in a patient who is having a cardiovascular disease as well as the periodontal disease. Now, basically, there is what happens in periodontal disease. There are two things that are happening, right? There is in periodontal disease, there is increase in gram-negative. In short, I'll tell you this. There is increase in gram-negative bacteria and also there is increase in inflammatory markers. Inflammatory markers. Now, what are the inflammatory markers and what is the function of these inflammatory markers? So, the inflammatory markers are cytokines, acute phase proteins. These are acute phase proteins, fibrinogen, MMPs, prostaglandins. Okay, so all these are the inflammatory markers. There are other inflammatory markers also, but these are important for us to remember. Okay, there are many inflammatory markers which increases during periodontal inflammation. Now, these inflammatory markers, it is seen that patients who are suffering from atherosclerosis or patients of cardiovascular disease, in them also these inflammatory markers are increasing. In those patients also, there is increase in these inflammatory markers. So what they do is fibrinogen. Fibrinogen is one molecule which is responsible for increasing the coagulability of the blood, right? Acute phase proteins. Which are the acute phase proteins? C-reactive protein. Even fibrinogen is an acute phase protein. So what they do, they increase the coagulability of the blood. So when the blood is more coagulable, what will happen? It will thicken. It will thicken. So what will happen? The flow of the blood will decrease and there are more chances of embolism, thrombus formation in the blood vessels, right? So the chances of cardiovascular disease increases. In periodontal infection also, these inflammatory mediators increases, these inflammatory markers increases, and thus they indirectly reach the blood vessels where there is an injury and they cause more chances of cardiovascular disease. Secondly, a direct mechanism is with the help of gram-negative bacteria. What these gram-negative bacteria do is, these gram-negative bacteria, they reach the blood vessels and there they injure the gram-negative bacteria and the lipopolysaccharides of the gram-negative bacteria. The bacterial cell wall is made up of lipopolysaccharides. So they will reach the blood vessel, they will cause the tissue injury, and at the local site, they will produce increase in the inflammatory mediators, which in turn will cause atherosclerotic plaque formation, and thus there is an increased chance of cardiovascular disease. Okay. So if in the options, we are not sure about the options, so please let us know in the comment section what were the options. Okay, but if in the options, fibrinogen, CRP, interleukin-1, interleukin-6 and TNF-alpha were there, in whichever option they were there, that will be the answer. In this question number 8, what they have asked, which inflammatory markers increase in a person with periodontal disease as compared to a person without any periodontal disease, having cardiovascular disease. So a patient of cardiovascular disease along with periodontitis, in various studies, it is seen that there is 3 to 4 times increased risk of cardiovascular disease or myocardial infarction in patients with periodontitis. Okay. So, please let us know the correct options, and if in the options, these names were there, then that will be the correct answer. Okay. Now the last question, a question from implants. Most of the questions from implants have been discussed by Dr. Ruchi, but one question was specifically related to periodontics. So I'm discussing it here. So in option number 9, attachment of oral, a little bit difficult, not a little bit, but a difficult question, definitely a difficult question, because we don't study implants at undergraduation level in that much detail. But by seeing this kind of questions, these kind of questions in exam, we surely should learn that now some topics such as implants need to be studied in more detail during our graduation level as well, right? So basically here, they have asked attachment of oral epithelium to an integrated implant is by. Integrated implant means the implant has been placed and around the implant there is formation of bone, right? So they are asking what type of oral epithelium attachment is there. So basically in this picture, from this picture, you can make out that here, one half of this picture shows the attachment of the oral epithelium with the natural tooth. In the natural tooth, we know that there is a circular epithelium, there is junctional epithelium, there is connective tissue and alveolar crest. Above the alveolar crest, there is connective tissue, and the length of the junctional epithelium and the length of the connective tissue below the junctional epithelium and above the alveolar crest is called as biologic width, right? So a proper biologic width is present in cases of tooth, and in cases of tooth, there is a proper connective tissue attachment seen around the natural tooth. But in cases of implant, what is there is, see, I'll just draw it for you guys. So if this is the bone, okay, this is the implant. Here is the implant placed inside the bone. So here you will see that the oral epithelium will begin like this, okay, and directly from below there will be bone formation here. There will be bone formation in this part. This is the bone. Okay. This is the osseointegration of implant. Osseointegration of implant. And here in between there is a connective tissue. The collagen fibers here in the connective tissue are parallel to the implant surface. They are parallel here. Okay. And this epithelium which you see here, in cases of implants, here there is abutment. Okay. Here there is abutment over which our tooth is placed. Okay. So this epithelium which you see here, this is called as, this epithelium which you see here, this is called as peri-implant circular epithelium. This is peri-implant circular epithelium. This, okay. This is the sulcus of the implant. The circular epithelium which we see around the natural tooth, the oral circular epithelium which we see around the natural tooth, around the implant, it is called as peri-implant circular epithelium. This, okay, this is similar to the oral epithelium, circular epithelium found around the natural tooth. Below it is the peri-implant epithelium, this epithelium, the peri-implant epithelium. Now it has been seen that this peri-implant epithelium, this is similar to junctional epithelium that is found around the natural tooth. And this junctional epithelium, it is 3 to 4 cell layer thick. Now we know that the junctional epithelium surrounding the natural tooth, the junctional epithelium surrounding natural tooth. So if this is the tooth, if this is the tooth, okay, and here there is a junctional epithelium. Okay, so this junctional epithelium, it is attached to the tooth with the help of hemidesmosomes, right? The attachment of junctional epithelium, the attachment of the junctional epithelium to the tooth is with the help of hemidesmosomes. Hemidesmosomes. Plus, there is an internal basal lamina. Junctional epithelium, we have studied that junctional epithelium is a unique epithelium because it has two basal lamina. One is the internal basal lamina, which is here, and one is the external basal lamina, which is at the side of the connective tissue. So here there is internal basal lamina and this is the external basal lamina. Okay. Now, in various studies, it has been seen that the peri-implant epithelium, this epithelium, it is similar to the junctional epithelium, and the structure of this epithelium also is similar to the junctional epithelium. So the junctional epithelium around the implant has a similar structure like the junctional epithelium around the natural tooth. So the natural tooth is connected with the junctional epithelium with hemidesmosomes and basal lamina. The answer to this question is this: the peri-implant epithelium, which is the junctional epithelium of implant, is connected with the implant with the help of hemidesmosomes plus internal basal lamina. Okay. This was a difficult question, guys. Don't worry. It was difficult for everyone. So please just don't panic with such questions. Okay. And one more thing is, please let me know if there is any change in any of the questions and the options. And with this, we have concluded our session of periodontics. And I would like to introduce our next faculty, who is our endodontics faculty, Dr. Aishwarya Kaushik. So over to you, sir. And thank you all, and all the best for the results, guys. हाँ अनिल भाई, thank you.
नहीं आप इसमें आ जाओ ना, चीप क्वालिटी
पर ट्राई करते हैं।
सेटिंग्स पे जाओ। नहीं इस पे जाओ, क्लोज।
Okay. All right. So I welcome you all back to the mega recall session. And now we are here for oral surgery recall. Thank you, Dr. Divya. Thank you so much for your periodontology recall. And I'm sorry for the technical glitch. Now, without wasting time, let's come to oral surgery. See, oral surgery, most of the questions were difficult. I will not say they were easy or moderate. They were really difficult. Okay. Local anesthesia questions, they were okay. Most of you must have marked it correctly, but there also there were some difficult questions. Coming to the most difficult question. Okay, we'll start with the most difficult question. Okay. In bilateral, you are visible little. Can you guys not see me properly? Am I not visible properly? Shivam is saying that you are visible little. Can you all see me properly? Just give me a thumbs up if you can all see me properly. ठीक दिख रहा है? ठीक है. All right. So maybe Shivam, beta some issues, network issues with you. Okay. So we'll first come to this first question. Okay. Full visible. Okay. In bilateral sagittal split osteotomy, fixation in the neutral zone is best done with. Okay. Now, if I look at whether it's a new question, whether it's a repeat question, let me tell you, it's a repeat question from Senior Residency Oral Surgery AIMS Delhi paper. And I am happy to share that that this was one of the questions that I had appeared for when I was giving my senior residency exam of AIMS, and this was one of the questions there. And I very nicely recall this question. I am surprised why they've asked you here in the MDS exam, but nonetheless. So this is the question, and the correct answer to this question is lag screw. Okay, positional screw, lag screw, mini plates and screw, no fixation need. अब ये आंसर क्यों है? Why is this the correct answer? For this, we have to understand everything. We have to understand what is bilateral sagittal split osteotomy, what is fixation that is done in bilateral sagittal split osteotomy, what are the zones, what is a neutral zone and what is a non-neutral zone, and then we will be able to understand the answer. Okay. Now, very quickly, I am going to show you what is BSSO. Okay, so BSSO, you all know, is sagittal split ramus osteotomy. So medially, you put a medial cut on the ramus. Laterally on the buccal surface, you put a buccal cut. Okay, so this is a medial horizontal cut, something like this, but on the medial side. Okay, and so on the medial side, because the medial side you're not able to see, it will be a horizontal cut like this. This is a vertical cut on the buccal side. And then we connect both the cuts like this with a sagittal cut. Okay, so basically this is sagittal split ramus osteotomy. When you do it bilaterally, you call it bilateral sagittal split osteotomy or BSSO. All right, so this is what BSSO is. Now here you also have to have a knowledge of trauma fixation, because the fixation that you do in trauma is the same fixations that you do in orthognathic surgery. Okay, obviously you don't need recon plates and such heavy fixations in orthognathic surgery, because the cuts that you're giving are very, very organized osteotomies. These are not comminuted fractures. Okay, these are simple linear osteotomies which you are doing. Okay, so जब आप BSSO करते हो, when you are doing BSSO, you are either advancing the mandible or you are making the mandible set back. Okay, तो मतलब mandible को या तो आप आगे ला रहे हो. So this is the proximal segment which is close to the joint, and this is the distal segment. Okay, after BSSO, the distal segment is going to move. Okay, obviously the joint wala segment will not move because it is attached to the joint. The distal segment, which is away from the joint, this anterior segment is the distal segment, and if it comes forward, you call it BSSO advancement. If it goes backward, we call it BSSO setback. All right. Now imagine mandible is not a straight bone. Okay, orthopedicians are lucky that most of their bones are straight bones. Of course, they have scapulas, they have clavicles, and they have all kinds of pelvic bones and everything. But this bone in the maxillofacial region, which is called the mandible, it's a very, very, peculiarly shaped bone. It is boomerang shaped. Okay, and any movement in any part of the bone will affect two joints simultaneously. Both the temporomandibular joints will be affected simultaneously. Okay, so when I'm cutting my mandible like this, unilateral SSRO, and like this, bilateral sagittal split osteotomy, and I'm advancing my mandible, because of the boomerang shape of the mandible, because of the lateral flare of the ramus, because simply speaking, because of the anatomy of mandible, the contact in this segment, okay, the contact which is there in the sagittal segment is not an equal contact. Okay, so if you watch this image carefully, you will see that in some places there is good contact, and in other places there is a gap because of the anatomy of mandible. Okay, whatever gap is created after advancement or after setback, when you fix your advancement or your setback, you have to respect that gap. You have to maintain the gap. It is compulsory to maintain those gaps. Okay, if required, you can put some bone graft in that region. But if advancement is causing a natural gap between the proximal and these are very minor gaps, 1 millimeter, 2 millimeters, very minor gaps. But you have to maintain these gaps. If you don't maintain these gaps, what will happen? you are basically compressing the proximal and distal segments together. So jab tak patient GA mein hai, till the time the patient is under general anesthesia, till the time his teeth are in IMF, there will be no problem. But when the patient comes out of the GA, when his muscles are coming back into tone, when the IMF is opened, what complication will happen? The complication that will happen is known as a condylar sag. Okay, naturally, when you're moving the mandible and it is creating some gap and you're closing that gap, what will move? The only mobile part is the joint, is the condyle. So that condyle will go out of fossa. Okay, there will be a central condylar gap or a peripheral condylar sag. Okay, so two types of condylar sags. So it will basically create complication. Okay, but you want that proximal and distal segments should be connected as much as possible so that healing is better. All right. So the rule in BSSO fixation is whenever there is a gap, maintain the gap. How will you maintain that gap? You will maintain that gap with positional screw. Okay, or mini plates and screws. And whenever the two bony pieces are in contact, means no gap, or when they are in contact, or when they are in neutral position. Neutral position means where the two parts of the bone, the proximal part and the distal part, whenever they are in contact, that is called as the neutral position. So jahan par wo contact mein hai, wahan par you give a very good contact. Okay, make as good contact as possible. And how can you make that contact as good as possible? Using lag screws. So this is the rule in fixation of a advancement or a setback segment. Let me show you one more diagram. For now, just remember these two rules in BSSO fixation. All right. Now I'm going to give you one more diagrammatic explanation. Okay. Now this BSSO is done. Okay. And you can see this is the proximal segment which has the joint. This is the distal segment which is moving. And here advancement is being done. If you watch carefully, you can see that the distal segment is coming forward, creating a gap between the proximal and distal segment. But there is a good overlap between proximal and distal segment in the sagittal region, in this region. Now, the overlap does not need to be absolutely touching each other. Okay. In some places, there will be contact. In some places, there will be gap. Okay. So, all those places where there is contact, there is a natural contact. Okay. There you can use a lag screw. It is better that if you use a lag screw there. Okay. And wherever there is no contact, here you can see there is no contact between the proximal and distal segment. There is a gap. So you have to maintain that gap. If you don't maintain that gap and if you use lag screw here also, then it will cause changes in the condylar position after surgery. And that will cause condylar resorption, headaches, joint pains, TMDs and all those problems. Okay. So these gap sites, these sites you have to maintain. So either use a mini plate or use a positional screw. These screws, which are just simple screws, they will just maintain the position of the bone and not cause any compression. Remember, when we taught you trauma in our oral surgery classes, we taught you that lag screw causes compression. Okay, so you can use the effect of compression in the neutral zone. Okay, the place where there is contract is known as the neutral zone. There you can use the lag screw. Okay, here also you can see here there is a natural contact. Here you can use your lag screws. And wherever there is gap, never use lag screw because it will change the orientation of bones, which we don't want. So in such places, always use positional screw. All right. Giving you one more example of mandibular setback. In setback, the neutral zone is anterior and the gap is posterior. Ulta hota hai. Okay, advancement mein you saw that the contact is posterior, opening of segments is anterior. Iska ulta hoga when you are doing a setback. Okay, when you're doing a mandibular setback, you're removing some bone from the distal segment, you're pushing the mandible back. So there will be good contact in the anterior region, which is the neutral zone. And there will be tension in the posterior region, means there will be gap in the posterior region. So in this gap wala region, you will put a positional screw. And in this neutral zone where there is good contact between the proximal and distal segment, you can use a lag screw. All right. So this is the funda behind lag screw and positional screw fixation in BSSO fixation strategies. Okay. It's really a tough question to be asked to undergraduates because you're hardly exposed to any BSSOs during your undergraduate times. Maybe some of you were fortunate to see a BSSO being done by your guides or in the OT, in the audiovisual room of your hospital. But most of you, I'm sure, have only read about BSSO. And to talk about the fixations in BSSO, it really makes the question very, very tough. I mean, when I sat for the exam, I was sitting there in the exam hall and I was sitting thinking, my God, this question was asked to me when I was appearing for SR exam. And I was fortunate that I had read this good book by AO, which is telling you about the fixations and how to use it. And it is not there in every textbook. Okay, these strategies are given in very, very selected books. So it was tough. It's absolutely okay if you didn't know the answer. Some of you must have done the SR papers, and if you've read the correct SR papers, I'm sure I have given this answer and you would know it. Just to give you the exact lines of the textbook, okay. To avoid the previously mentioned consequences are condylar sag. Positional screws are introduced to fix the segments. Okay. With these, the gap between the fragments can be maintained, which is what we want. Bone grafts may be positioned between the fragments to avoid compression and movement of the proximal segment. Sometimes it is indicated to use lag screw in combination with the positional screws. If you use only positional screws in all the places, that is also correct. Excuse me. Okay, if you use only positional screws, that is also absolutely correct. But you can also use the lag screws along with it only in the neutral zone. When advancing the mandible, the lag screw is used to stabilize the posterior natural contact. And the anterior area is fixed with the positional screws, just what we discussed in the diagram, which can be placed through sandwiched bone graft if required. It should be noted that in setbacks, the natural contact area is situated in the front, just what we saw in the diagram here. All right. So in the front, it will allow a lag screw fixation. All right. So this is the concept of neutral zone. What is neutral zone? Neutral zone is basically the natural contact area between the proximal and distal segments. Okay. So contact area, you can use lag screw. No contact or gap between segments, you have to use positional screws to maintain that gap. Otherwise, you will have a complication known as condylar sag. All right. So this is the first question. This is the solution to the first question. Please let me if you've understood this concept nicely or not. All right. Okay. Coming to the next question. This is easy actually. A patient comes after road traffic accident having displaced mandibular parasymphysis linear fracture. For closed reduction treatment, in this case, what should be the ideal duration of intermaxillary fixation? Okay, now this is your mandible. This is not your mandible. This is the patient's mandible who has a parasymphysis fracture which is displaced. What is the meaning of displaced parasymphysis fracture? It means the segments are something like this. Okay, one part has gone up, other part has gone down. This is the meaning of displaced fracture. Okay. mandibular parasymphysis. So it is an anterior mandibular fracture. The good important hint in the exam or in the question is linear fracture. Linear fracture means it's a simple fracture, single line fracture. There is no comminution. There is no comminution. There is no multiple segments. It's a single line fracture. It's okay if it is displaced. It's okay. It is displaced. We agree that it is displaced. Parasymphysis fracture has to be displaced because your suprahyoid muscles will pull this segment down. Your masseters and medial pterygoids will pull this segment up. So सारी muscles mandible पे सब काम करेंगी. कोई muscle उसको नीचे लेके जाएगी, कोई muscle दूसरे segment को ऊपर लेके जाएगी. So it is very common for mandibular fractures of the anterior region to be displaced. All right. But it is not known whether the patient is elderly, whether the patient is immunocompromised. ऐसी कोई भी history नहीं है. अगर ये लिखा होता कि patient बहुत elderly है, या patient is immunocompromised, patient is diabetic, then we would think on the lines that patient needs more time in healing. None of these facts are mentioned in the exam. So we will assume that the patient is normal patient with a normal healing ability. Since healing ability is not mentioned, the duration of your IMF is dependent upon the healing ability of the patient and characteristic of the fracture. Characteristic of the fracture is that it's a linear fracture. It's a simple linear fracture. Okay. And nothing is mentioned about the healing ability. So we assume that it is normal. So in this case, we will mark the answer as 4 weeks. Okay. Because normally in an adult, in simple linear fractures, the duration of IMF is 4 to 6 weeks. 2 weeks is too less. 8 weeks is too much for a linear fracture, and 12 weeks is also too much. Okay. So the ideal duration of IMF, which is required in simple fractures, in not simple fractures, but linear fractures in a healthy, normal individual, adult individual, is around 4 to 6 weeks. If this patient would be, say, a child, okay, then I would do IMF for only 2 weeks. That would be enough. And I would really start elastic physiotherapy or post-IMF physiotherapy. Okay, so the correct answer to this question is 4 to 6 weeks. Okay, just give me a thumbs up, guys, if you're really understanding question 1 and question 2. Okay, 6 to 8 weeks, no, it should not be 6 to 8 weeks. 4 to 6 weeks is more than enough. Practically, most of the IMFs that we do are for 4 weeks only. You assess the patient every week, and in around 4 weeks, you remove the IMF. 8 weeks is 2 months. Imagine 2 months of IMF, not required. The correct answer to this question is 4 to 6 weeks. So we will choose 4 weeks as the answer. Please give me a thumbs up if you've understood. I'm waiting for your thumbs up in the YouTube live chat. All right. This is easy. This is repeated. This was even asked in NEET 2024. So all those who have attended the NEET 2024 recall session, I'm very sure that you've marked it correctly. Treatment of ameloblastoma extending up to the inferior border of mandible is done with. Okay. So this is the mandible. This is an ameloblastoma which is extending almost up to the inferior border of mandible. Look at all the options. Now let us eliminate all the options and tell me. Marsupialization. What is marsupialization? Marsupialization is a treatment for cysts. Basically, a fluid-filled sac, you create a bony window, and in that bony window, you allow all the cystic fluid to go out, and the cyst shrinks. And when it shrinks, either it is involuted or you take it out. So marsupialization is a treatment for cyst. It is not a treatment for tumors. Okay. This is a tumor. Ameloblastoma is a benign odontogenic tumor. So marsupialization can never be a treatment for tumors. Curettage. Absolutely wrong. Curettage means just scrape out all the pathology. It's a repeat question that if you try and curettage an ameloblastoma, there is 80 to 100% chance of recurrence. Because a tumor will infiltrate, okay? Macroscopically, you can see, okay, tumor itna hi hai. But microscopically, you know that the tumor has the ability to infiltrate into the adjacent soft tissues. Okay, the tumor cells will go and infiltrate into the adjacent soft tissues and bones. That is why you never ever do curettage in tumors. The treatment that we do in tumors is resection along with normal bony margin. Okay, so curettage is wrong. The treatment for tumors is resection. Resection means removal of the pathology along with a 1 to 1.5 centimeter normal bony margin plus the next anatomical barrier. Okay, those who have attended my pathology classes, my classes of oral pathology, I mean oral surgery mein hi, a section is there on pathology, and I very nicely described the gold, uptron, marks, terminologies of treatment of tumors. Everything is defined very, very beautifully. Now coming to this terminology, if this is the mandible and this much is the tumor, very little extent, okay, how can I treat it? I can treat it with something which is known as en-bloc resection, also known as segmental resection, also known as resection without continuity defect. Tumor is limited to the superior margins of the mandible. You remove the tumor along with 1 to 1.5 centimeter of normal bone, and it is removing the whole pathology like a block. In a block, like a simple block of bone. This is known as en-bloc resection or segmental resection. You're only removing a segment of mandible. Just a segment of mandible, not creating any discontinuity. The continuity, even if you remove this much mandible with the tumor, the continuity of your mandible is still maintained. So the correct terminology is en-bloc resection with segmental resection or resection without any continuity defect. But is that the case in our question? Is that the case in our question? No, that is not the case in our question. In our question, the tumor is extending up to the inferior border of mandible. So to remove this tumor, I have to remove this full part of mandible, and this is known as marginal, this is known as resection with continuity defect. I have to remove this much part of my mandible because there is no bone left in the inferior border because the tumor is already infiltrating till the inferior border. So I have to remove this much part of my mandible. When I do that, there is a continuity defect. My mandible is now broken into two parts. So I cannot leave my patient like that. I have to do a reconstruction. And a similar question is asked later on that when you're using a reconstruction plate for reconstruction, what are the rules? So that's a separate question here only. But this is the correct treatment. You have to do a resection with continuity defect. There is a defect in the continuity of mandible. You can use bone graft. You can do without bone graft. You can do a free flap. Whatever you are doing, you have to put a reconstruction plate. Without that, your treatment is incomplete. You cannot just cut the tumor and leave it. You have to bring back the continuity of the mandible by doing a reconstruction. And that is always done with a recon plate, which is a load-bearing plate. Okay? All these concepts have been explained very, very nicely in our lectures. So all those who have attended it, I'm sure you've marked it correctly. The correct answer to this question is resection and reconstruction. This is not an en bloc resection. En bloc resection तब बोलते हैं जब original bone की lower margin preserved होती है. Only a block or a segment or a margin of, the bone is removed and the lower border is still maintained. Okay, this is en bloc or marginal resection. This is whole segment is removed, so that is segmental resection. All right, so the correct answer to this question is resection and reconstruction. Okay. Now, related to that, they've asked one more question. When using the reconstruction plate for a resection defect, which of these is true? Okay, again, it's never been asked before, but if you know the simple rules, okay, you will be able to rule out the answers by exclusion. Okay. The plate should not be closed with layers of soft tissues for the fear of exteriorization. Okay. अब इसमें मुझे आपको पूरा समझाना पड़ेगा. When we put a reconstruction plate, okay, in such a defect, in a defect like this, in a defect which is like this, okay, now this part does not have any bone. So this part of the plate is not integrated. Okay, yahan par the plate will get osseointegrated. But when there is a defect, in that part, there is no osseointegration of the implant, of the plate. Okay. So this is how you reconstruct a resection defect. Okay. Now this is the defect. Now, what will I do that my plate is there for a long time? My plate does not get infected. My screws do not get loose. My surgery does not have any complications in the post-operative period. I will do a lot of things. First, I will try and cover this area with a good layered soft tissue envelope. I will rather resuspend my soft tissues. What will I do? इस region में क्या होती है? Mentalis muscle होती है. I will take my mentalis muscle. I will put a suture around the mentalis muscle and I will suture the mentalis muscle with the plate. Okay, so that there is some fibrosis between the muscle and the plate, and it is trying to bring back the normal anatomy of the region. Okay, so I will put as good soft tissue cover as I can. I will try and put the periosteum back. I will try and put the mentalis to resuspend my mentalis. I will do my, connective tissue closure. I will do my skin closure. So jitna acha ho sake, I will do a very good layered soft tissue closure to prevent the exteriorization. What is exteriorization? Plate bahar se dikhne lagna. The plate is being visible from the exterior. That is known as exteriorization. When will that happen? When the soft tissues of the area are atrophied. Okay, if the soft tissues of the area is thin, okay, is atrophied, then my plate will start being visible. If imagine the plate is here and the skin and connective tissue is not covering the plate, only skin is there, then skin will atrophy, skin will necrose, and in that area, my plate will start being visible from the exterior. That is known as exteriorization of the plate. To prevent that from happening, I will do a good soft tissue coverage. मैं उस पे पेरियोस्टियम भी चिपका दूंगी, मैं उस पे मेंटालिस भी लाके चिपका दूंगी, मैं सॉफ्ट टिश्यू कवर अच्छे से अच्छा दूंगी ताकि सिर्फ स्किन से कवर ना हो मेरी प्लेट. It is covered with multiple layers of soft tissues and it prevents exteriorization. So this option is wrong. The plate should not be closed with layers likha hai, so it should be closed with layers. Okay, so this option is wrong. Now, dusri cheez, let's come to the option number C. Plate should be fixed between the superior and inferior border. Okay. Reconstruction plate, the only rule in reconstruction plate is it has to be placed on the inferior border because it uses rule for recon plate fixation. What are the rules for recon plate fixation? it has to be fixed on the inferior border. अगर मैं middle of superior और inferior border में कर दूंगी और bicortical screws से उसको fix करते हैं हमेशा, we always fix the recon plate with bicortical screws. So imagine मेरे बाकी के जो teeth के root stumps हैं, root apices हैं, my screws will go and hit the root apices. It will injure the roots of my teeth. There is an inferior alveolar canal also which is running here. So my bicortical screws of the recon plate will go and injure my neurovascular bundle. So for that reason, the reconstruction plate is always and always and always fixed on the inferior border or on the inferior surface. The second rule is it is always fixed with bicortical screws. You cannot use monocortical screws to fix the reconstruction plate. It has to be bicortical screws. आप छोटे-छोटे 6 mm के screw से इतनी मोटी plate को नहीं अटका सकते हैं. If you have a very thick plate, you have to fix it with long screws. And long screws means bicortical screws. They have to penetrate through the buccal cortex and come out of the lingual cortex. So these are known as bicortical screws. That is the second rule for recon plate fixation. The third rule is the number of screws should be minimum 3 screws on both sides of fracture or defect. Whatever is your fracture or whatever is your defect, the minimum 3 screws should be there on both sides. Okay, आप सोचो कि आप एक इतनी मोटी प्लेट है, there's a very thick reconstruction plate and you are fixing it with only 1 screw. क्या वो टिकेगी? नहीं टिकेगी ना. It's just like a big painting which you have and you have to fix it on the wall. So you will need at least 2 or 3 points of fixation, right? If it's a small painting, you can hang it with 1 nail also. If it's a big painting, you will need multiple supports. Similarly, when you're fixing a reconstruction plate, it's a thick, heavy plate. So to fix that plate, you need minimum 3 screws on one side, minimum 3 screws on the other side. If it is more than 3, it is very good. But it should not be less than 3. It has to be minimum 3. So these are the rules for using a recon plate. Wherever you're using a recon plate, whether it's a comminuted fracture, whether it's a defect, whatever it is, these are the rules for reconstruction plate fixation. Okay, so the plate should be fixed between superior and inferior border. This is absolutely wrong because it has to be fixed on the inferior border only. I can see a lot of you being disappointed by looking at the answers, but don't worry. May INI is only a prologue, okay? Your main target is November and NEET. So don't worry. Be happy that you've made the mistake here so that you don't make the same mistakes in the main exam. Minimum 2 screws on both sides. Again, it is wrong because you need minimum 3 screws on both sides of the fracture line. The correct answer is locking screws should be used. Now here we come to the difference between locking and non-locking system. Okay. Always prefer the locking system, which is a recent advancement. What is locking system? In locking system, the plate screw head, the plate screw receptacle also has threads. Okay. And the screw head also has threads. Okay. Normal screw कैसा होता है? Normal screw में head होता है और body होती है और body में threads होते हैं. And these threads go and engage in the bone. ठीक है? Basically screw क्या करता है? Plate को bone के साथ चिपका देता है. Okay? But locking screw will not do this. Locking screw will engage the bone also and locking screw will engage with the plate also. तो वो plate को bone के साथ चिपका नहीं रहा है. Okay? It is just maintaining the position of the plate with the bone. Okay? Go back to the trauma videos of oral surgery and there are 6 differences between locking and non-locking system. Except for one reason, all the 5 reasons are there that the locking system is better. Why is it better? No compression, no screw loosening. No means very low. Okay, let me not call it no. There is very low screw loosening. So screw loosening के chances बहुत कम होते हैं इसमें. ठीक है? Because आपका स्क्रू जो है बोन के साथ भी फिक्स्ड है और आपका स्क्रू प्लेट के साथ भी फिक्स्ड है. देयर इज डबल फिक्सेशन. ओके, तो जो स्क्रू लूज हो जाता है, कई बार क्या होता है, व्हेन यू आर यूजिंग रिकॉन प्लेट, द पेशेंट विल कम टू यू आफ्टर 6 months विद अ डिस्चार्जिंग साइनस. वो एक पस डिस्चार्जिंग साइनस लेके आया है एंड यू रियलाइज दैट एवरीथिंग इज ओके, प्लेट इज आल्सो ओके, बट द स्क्रू हैज बिकम लूज because of the continuous types of forces on the mandible. There is tensional force, there is compressional force, there is shear force, torsional force. So many types of forces on the mandible is actually being taken up by the screw. Screw अलग है और प्लेट जो है बोन के साथ इंटीग्रेट हो गई है, तो स्क्रू लूज हो जाता है. स्क्रू लूज हो जाता है, एनीथिंग विच इज लूज विल गेट इन्फेक्टेड. सो टू प्रिवेंट दैट दे हैव नाउ डिवाइस द लॉकिंग स्क्रू. तो लॉकिंग स्क्रू क्या करेगा, बोन में तो जाएगा ही और प्लेट में भी जाके लॉक हो जाएगा. इट विल गो एंड लॉक विद द प्लेट ऑल्सो. So chances of loosening of this screw are very, very low. So the chances of success of the reconstruction plate becomes very high. All right. So always, whenever possible, whenever the cost is not a problem, always use the locking screw. And that is the correct answer for question number 4. All right. Okay. Lot of conceptual questions. इस type के questions को आंसर करने के लिए ना आपको ये सारे कॉन्सेप्ट आने चाहिए. एंड दिस इज व्हाई इट हैज मेड द क्वेश्चंस ऑफ ओरल सर्जरी सो डिफिकल्ट, बिकॉज मोस्ट ऑफ द क्वेश्चंस आपको कॉन्सेप्ट पता होना चाहिए, आपको कॉन्सेप्ट को अप्लाई करना आना चाहिए. एंड इट वाज रियली टफ. आई मीन, for a postgraduate in oral surgery it is okay, but for an undergraduate who has only very limited exposure of any branch, it was a tough question. Okay, so I hope now you have understood it and in future you will be able to answer it. Okay, next question is on lower class 2 mandible. Okay, in edentulous mandible fracture with lower class 2, which of these is an ideal treatment? Now what is lower class 2? So edentulous or partially dentulous मैंडिबल में क्या होता है, एल्व्यूलर बोन हो जाती है रिजॉर्ब. ओके, डिसयूज एट्रोफी. वी नो व्हाट इज डिसयूज एट्रोफी. व्हेन यू एक्सट्रैक्ट अ टूथ, when you extract a tooth, and suppose this place does not have a tooth, so what will happen, the alveolar bone has no function, so the alveolar bone will resorb. So the vertical height of the mandible, in that region will be smaller. Okay, so when a patient has all the teeth missing and all his teeth are gone, the total vertical height of the mandible becomes very, very small, especially in the symphysis and body region. The symphysis, parasymphysis and the body region, because उसी में teeth होते हैं. रेमस में और एंगल में तो teeth होते नहीं है. teeth कहाँ होते हैं, बॉडी में और symphysis में. symphysis, parasymphysis, body तक, molars तक, है ना. तो जैसे जैसे teeth will be missing, the alveolar bone will start resorbing, because alveolar bone का क्या काम है, tooth को पकड़ के रखना. तो tooth ही नहीं है तो alveolar bone का कोई काम ही नहीं है. Alveolar bone will undergo atrophy. That is why atrophic mandible vertical height in this region is very, very short. Okay, so Luer has classified the mandible, the edentulous mandible, as class 0, class 1, class 2 and class 3. What is class 0? Class 0 means there is no atrophy. अभी तक सब कुछ ठीक है and vertical height is more than 20 millimeter. 2 centimeter height है और ठीक ठाक हाइट है, कोई ज्यादा प्रॉब्लम नहीं है. In Luer 1, height is 15 to 20. In Luer 2, it is 10 to 15. And in Luer 3, it is very, very small mandible, where it is less than or equal to 10 millimeters. Okay, so question में पूछा हुआ है Luer 2. Luer 2 मतलब काफी छोटी हो गई है mandible. It is just the second last stage of mandibular atrophy. Okay, so बहुत ही पतला सा mandible है. Now imagine इतने पतले से mandible में कोई load bearing capacity होगी? Do you think a very, very thin mandible, which is where the height of the mandible is very, very short, does that mandible have any load bearing capacity? No, there is no load bearing capacity in such an atrophied mandible. So here, whatever fixation you give, it has to be a load bearing fixation. You cannot give a load sharing fixation because वो load share ही नहीं कर पाएगा. Mandible में ताकत ही नहीं है. एक तो इतना पतला सा है, ऊपर से फ्रैक्चर और हो गया है, तो क्या ही लोड लेगा बेचारा मैंडिबल. तो आपको ऐसा फिक्सेशन देना है जो कि लोड बेयरिंग है, जो कि सारा का सारा लोड खुद पे ले ले ताकि मैंडिबल अच्छे से हील हो सके. Coming to the options, submucosal load sharing plate. अच्छा, अब ई डेंचरलेस मैंडिबल में ना एक और कॉन्सेप्ट होता है. अगर आप सर्जरी कर रहे हो, ओके, व्हेन यू आर डूइंग सर्जरी, what is the blood supply to your mandible? We know that maxilla is nicely covered with a very good soft tissue envelope. But what about mandible? There are only two blood supplies to the mandible. One is that inferior alveolar neurovascular bundle, जो आपकी inferior alveolar artery आ रही है, जो कि mental foramen से बाहर निकलती है. एक तो ये blood supply करती है mandible को, inferior alveolar artery, और दूसरी blood supply जो mandible की होती है वो होती है पेरियोस्टियम से. ठीक है. As the person ages, जैसे जैसे person बूढ़ा होते जाता है, the inferior alveolar neurovascular supply is reduced. Any artery, it will go atherosclerosis, it will go undergo narrowing. The blood supply through the inferior alveolar vessels is reduced. And उस पे भी अगर बेचारे को फ्रैक्चर हो गया, सोचो इधर फ्रैक्चर हो गया, तो जो बची कुची ब्लड सप्लाई थी हीलिंग के लिए जो जरूरी होती है, whatever blood supply is required for healing, that is also now compromised because that vessel is also in the fracture. Of course, the vessel must also be compromised. Okay, so inferior alveolar से आप expect नहीं कर सकते that it will allow healing. The only blood supply now to the mandible is the periosteum. If you are going to put a plate on the mandible, you have to give an incision. When you give an incision, you have to raise the mucoperiosteal flap. Basically, you are giving an incision on the periosteum also, and you are reflecting the periosteum. You are putting a plate and you are putting the periosteum back. तो जो एक आखिरी blood supply थी mandible की periosteum से, वो भी आपने सर्जरी के दौरान काट दी. So imagine what will be the healing ability of such a man. और लगा दिया आपने एक बड़ी सी reconstruction plate. Will it ever heal properly? No, it will not heal. So to allow healing in edenturous mandibles in the palatal region, a lot of times we do something which is known as transmucosal load bearing plate. We put a plate through the mucosa only. It's like an X-fix, but through the soft tissues. Okay, you put a plate in that fractured region and you put the screws across the mucosa. Okay, transmucosal plating. And when the bone heals, you take the plate and screw out. It has to be a load bearing plate. Okay, so transperiosteal, transmucosal plating, circummandibular wiring using the patient's denture. It can also be done, but in lower class 2, I don't think that will be very successful. Okay, because circummandibular wiring is not a very stable form of fixation. Okay, the fourth option is not recalled, although I was sitting in the exam, but I also can't recall. If you guys can recall the fourth option, you can tell me what was the fourth option. But the best answer to this question is a load bearing plate, which can be placed transperiosteally or transmucosally, just to prevent the compromise in the blood supply. Mucosal envelope nahi kholenge, periosteum ko cut nahi karenge. Through the mucosa only, you will put the plate and screws. Okay, something like an external fixation. All right, so this is the correct answer to this question. Okay, now this is a question on obstructive sleep apnea. Again, a very, very tough topic for the undergraduates. We have taught it in our lectures in the miscellaneous part. I have taught about obstructive sleep apnea, but it's not very commonly asked in exam. This time they have asked bang on OSA treatment. 8-year-old boy. अब जैसे ही आप 8-year-old पढ़ते हो, आप CCG mark कर देते हो. नहीं कर सकते. He comes with bilateral TMJ ankylosis. Now, a child with bilateral TMJ ankylosis, this is a normal child with a normal mandible. This is a child with bilateral TMJ ankylosis. This is the difference between a normal child who has a straight profile and a child with TMJ ankylosis bilaterally. This is the amount of airway that he has. Itni si airway hoti hai uski. Okay, whereas a normal child has this much airway. Bilateral TMJ, that is why when the airway is so narrow and the child sleeps, the tongue falls back. It causes something known as obstructive sleep apnea. What does obstructive sleep apnea cause? It causes severe snoring. It causes night time awakening. Patient is sleeping, but he's not able to breathe. यहाँ पर tongue पड़ी है उसकी, और tongue is falling back. So there are episodes of apnea. Apnea means cessation of breathing. The patient can't breathe. So he is ऐसे करके वो रात को उड़ जा रहा है. Okay, there are episodes of apnea because of it. There is nighttime awakening. अब पूरी रात बेचारा खराटे मारते रहा और उठते रहा because of apnea. So what is happening? दिन भर उसको नींद आती रहेगी. Daytime somnolence. 3 characteristic features of obstructive sleep apnea: snoring, nighttime awakening because of apneic and hypopneic episodes, and daytime somnolence. ऑटो चलाने वाला एक पेशेंट था मेरा जो ऑटो चलाता था और हर रेड लाइट पे सो जाता था because he had bilateral TMJ ankylosis with a very small mandible. There are many factors: obesity, short neck, so many factors. But in this case, the cause is bilateral TMJ ankylosis causing retrogenia and retrognathia. The TMJ ankylosis in the child has not allowed the mandible to grow, and he has severe retrognathia. Because of that, there is snoring, continuous waking, and daytime somnolence. अब इस पेशेंट में imagine अगर आपने कर दी gap arthroplasty. Imagine the first option is gap arthroplasty. उसका mandible इधर है. जब आप मुंह खोलते हो, whenever you open your mouth, where is mandible going? Backward. Imagine a patient whose mandible is so backwardly placed. You perform a surgery after which his mandible is going even backwards. What will happen to his airway? His airway will worsen. His airway will worsen very, very badly. So you can never imagine doing a gap arthroplasty in such a patient. Second option, costochondral graft. You create a gap and you put a graft there. Still, when the patient will open the mouth, the mandible will still go back. And this patient has severe OSA. So you're not doing anything about the आप सिर्फ oral surgeon बन के बैठ गए भाई मेरे को तो TMJ ankylosis आता है मेरे को तो उसकी airway से कोई मतलब नहीं है because मैं तो oral surgeon हूँ ऐसे नहीं होता है. You have to take care of the airway first, which is a life-threatening thing. All right. So CCG, you're correct. It's a growing graft. It will help the mandible grow, but the mandible will grow very, very slowly. So in this case, you have to first correct his obstructive sleep apnea. Second treatment will be correction of TMJ ankylosis. The priority of treatment will be OSA and not TMJ ankylosis. So how will I correct OSA? जो mandible so posteriorly placed hai, I have to bring the mandible forward. When I bring the mandible forward, my airway automatically comes forward and my airway opens up. Because my mandible is connected to my tongue, the tongue will move forward. My mandible is connected to my airway. So I bring the mandible forward, the airway also opens up. His OSA is treated. So the first treatment of such a severe OSA is mandibular distraction. You put 2 distractors, distract your mandible, bring it forward. So all your suprahyoid muscles, infrahyoid muscles, all the muscles are pulled forward. Your airway opens up. After that, you put a CCG. After that, the first surgery will be mandibular distraction. Second surgery will be doing a gap arthroplasty and interpositioning the arthroplasty with a CCG. That will be the second surgery. not the first surgery. In first surgery, you will put cuts, you will put distractor, and you will bring the mandible forward. Few months later, when the mandible is forward, his OSA is treated, then you will remove the distractor, and in the same sitting, when you're removing the distractor, you will also operate for TMJ ankylosis. Wait and watch till the child attains adulthood. Very wrong option. आप डॉक्टर इसलिए थोड़ी बने हो कि wait and watch करोगे. You have to treat it. All right. So the correct answer here is mandibular distraction. You have to correct his OSA in the priority. Then you have to correct his TMJ ankylosis. All right. So I don't know how many of you have marked it correctly. Again, a very, very clinical question. Very, very, application based question कि आपको TMJ ankylosis की knowledge भी होनी चाहिए, आपको OSA की knowledge होनी चाहिए, आपको distraction osteogenesis की knowledge होनी चाहिए, आपको different grafts की knowledge होनी चाहिए. You have to integrate a lot many things of oral surgery to be able to answer this question correctly. All right. Again, one tough question, but this is what it is. All right. Now coming to the next question. Again, a very, very difficult question. Although you could rule out, and I'm sure most of you have marked the white eye syndrome, which is the correct answer. But again, it's a very, very indirect question, very, very application-based question. Okay. एंकाइलोसिस में डिस्ट्रैक्शन प्लेस कर सकते हैं, ऑफ कोर्स कर सकते हैं. यहां नहीं करते हैं बेटा डिस्ट्रैक्शन. डिस्ट्रैक्शन एंगल में किया जाता है, इस जगह पे. आपको बॉडी डिस्ट्रैक्शन करना है. एंकाइलोसिस तो कॉन्डाइल में हुआ है ना. If this is your mandibular condyle and this has undergone ankylosis, आपको यहां से थोड़ी डिस्ट्रैक्शन करना है. डिस्ट्रैक्शन तो आपको यहां से करना है. आप बॉडी रीजन में कट लगाओगे, आप यहां पर डिस्ट्रैक्टर फिक्स करोगे और आप एंटीरियर मैंडिबल को डिस्ट्रैक्ट करके आगे लाओगे. The anterior mandible is distracted forwards, okay, or like this. So yes, along with ankylosis, you can definitely, it is very common. Once, by God's grace, even if you become oral surgeon, you will see very commonly in your department that patients come with ankylosis, and first we do a distraction, then we do the release of ankylosis. All right. So your question, ankylosis में distractor place कर सकते हैं, 100% कर सकते हैं और करना चाहिए. All right. Yes, it was way too tough. Even after lecture, if you have watched the miscellaneous part, yes, it is still tough because it is clinical application of the knowledge. Okay, so जिसके तुक्के लग गए हैं वो खुश हो जाओ, जिसके तुक्के नहीं लगे हैं और जो गलत करके आए हैं, it's okay. Now we know that AIMS can ask you any kind of difficulty questions, and now you know the answer. All right. Okay. 10-year-old child comes after road traffic accident with persistent bradycardia and hypovolemia. ठीक है. 10-year-old child, ये भी important है. On CT, there is herniation of orbital contents. Very important. What is the diagnosis? The diagnosis is white eye syndrome. अब हमको white eye syndrome समझाना पड़ेगा. This is the orbit. Okay, this is the nasal cavity. This is your oral cavity. This is your maxillary sinus. Okay, maxillary sinus. Or let me put it more schematically. Maxillary sinus, nasal cavity, orbit or orbital cavity, oral cavity. ठीक है, ऐसे कर लेते हैं. ठीक है ना. तो maxillary sinus forms the floor of the orbital cavity and roof of the oral cavity in the posterior region. ठीक है. Whenever there is an orbital trauma, a very common kind of orbital trauma is known as blowout fracture. Orbital blowout fracture. What is blowout fracture? Blowout fracture means the orbital rim is intact. जो बाहर से ये supraorbital ridge, lateral, inferior, infraorbital rim, ये rim intact होती है. ठीक है. But one of the walls of the orbit, the medial wall or the lateral wall, or most commonly floor of orbit, is fractured. ठीक है, फ्लोर ऑफ ऑर्बिट जो हो जाता है फ्रैक्चर हो जाता है. नाउ इट्स अ 10-year-old चाइल्ड. We know that children have green stick fractures. Children में ना bone is very very elastic. Bone is very very elastic and resilient. तो बच्चों में क्या होता है ना, कंप्लीट फ्रैक्चर्स कम होते हैं, बच्चों में ग्रीन स्टिक फ्रैक्चर्स ज्यादा होते हैं. सो जब ब्लो आउट फ्रैक्चर चाइल्ड में होता है ना, तो क्या होता है, ट्रैप डोर फ्रैक्चर. व्हाट इज ट्रैप डोर फ्रैक्चर? फ्रैक्चर हुआ, कोई ना कोई ऑर्बिटल सॉफ्ट टिश्यू, ओके, इंफ्रा ऑर्बिटल मसल, इंफीरियर ऑब्लिक मसल, सम एक्स्ट्राओक्युलर मसल और ऑर्बिटल फैट और ऑर्बिटल एनी ऑर्बिटल सॉफ्ट टिश्यूज, वो स्नैप बैक जब होता है फ्रैक्चर, उसमें फंस जाता है. तो फ्रैक्चर हुआ, ऑर्बिटल सॉफ्ट टिश्यू उसमें फंसा और फ्रैक्चर वापस अपनी जगह पे आ गया. विद इन सेकेंड्स दिस विल हैपन. ओके, इंजरी हैपेंड, देयर इज अ फ्रैक्चर इन द फ्लोर. The soft tissues of the orbit herniated. Where will they herniate? They will herniate into the orbit, into the sinus. So जब आप CT स्कैन करते हो, आपको कोई बोनी फ्रैक्चर नहीं दिख रहा है, बिकॉज ऑर्बिट में फ्लोर फ्रैक्चर हुआ और वापस स्नैप बैक करके अपनी जगह पे आ गया. That is why it is known as a trap door fracture. फ्रैक्चर हुआ, उसने कुछ सॉफ्ट टिश्यूज को फंसाया और वापस अपनी जगह पे आ गया. So no bony injury is seen on the CT scan, but because of that temporary snapping back, because of that fracture, the soft tissue is entrapped. The soft tissue of the orbit is entrapped into the fracture line. बहुत common होता है children में, very very common in children. So whenever you see a child in the trauma center who has an orbital trauma and you see that everything is okay, there is no periorbital edema, there is no circumorbital ecchymosis, there is no subconjunctival hemorrhage, कुछ भी नहीं है, child बिल्कुल ठीक लग रहा है, ठीक है, but there will be only one finding. What is that one clinical feature which will be there? Restriction of gaze. जब आप बच्चे से बोलोगे कि ऊपर देखो, तो उसकी जो ऊपर देखने वाली मसल है, द मसल विच अलाउज द सुपीरियर मूवमेंट ऑफ द ग्लोब, that is entrapped. The inferior rectus or the inferior oblique muscle is entrapped in the fracture. So one eye which is not injured will be able to look up, other eye will not be able to look up. That is known as restriction of gaze. And a lot of times when the child is trying to do that, he's trying to do that, it stimulates a phenomenon which is known as oculocardiac reflex. It is also a form of trigeminocardiac reflex. TCR, trigeminocardiac reflex, is a phenomenon which is happening here. TCR, trigeminal nerve के वजह से होता है if it is because of V1, V2, V3. When it is because of V1 or the ocular branch of the trigeminal nerve, it is known as oculocardiac reflex. Whenever there is surgery, whenever there is trauma in the orbital region, the oculocardiac reflex is stimulated. Now, what is oculocardiac reflex? Whenever a stimulus comes in the trigeminal nerve, in the dorsal motor nucleus of vagus nerve, it is crossing and it is stimulating the vagus nerve. What is the effect of vagus nerve on the heart? Negative inotropic, negative chronotropic. So it will reduce the blood pressure, reduce the heart rate. So injury orbit में हुई है, effect heart पे आ रहा है. So this is clear cut question showing bradycardia and hypovolemia only and only due to orbital injury. Hypovolemic shock क्यों होगा? कहीं पे bleeding तो हो ही नहीं रही है. The CT is only showing herniation of orbital contents. There is no bleeding. Why will there be a hypovolemic shock? There will be no brain herniation. A lot of times neurologists or emergency people are confused कि अगर bradycardia हो रहा है, hypervolemia हो रहा है, either it's a cardiac issue or it's a neural issue. No, it is neither a cardiac issue nor it's a neural issue. It is purely due to oculocardiac reflex. What is the treatment? Emergency में you take the patient to the OT, give him GA, explore his orbit, release the entrapment of muscle, treatment is over. Trapdoor fracture is there, you don't need to reconstruct, the bone is snapping back to its position, but जो वो soft tissue उसमें फंस गया है, which is causing the oculocardiac reflex, just remove the entrapped soft tissues. That's it. That is the treatment, and it should be done early. All right. So again, a very, very tough question in oral surgery. I'm not expecting this for the undergraduates, but still it is asked. And why is it called white eye syndrome? It's called white eye syndrome because the eye looks absolutely normal. Okay, there is no bleeding around the eye, there is no subconjunctival hemorrhage, there is no periorbital edema because floor में fracture हुआ है. ऑर्बिट की मीडियल वॉल में होगा तो ब्लीडिंग होगी, ऑर्बिट की सुपीरियर वॉल में होगा तो दिखेगा. ये तो फ्लोर में फ्रैक्चर हुआ है, फ्रैक्चर होके वापस आ गया है, स्नैप बैक. सो द आई लुक्स एब्सोल्युटली नॉर्मल. दैट इज व्हाई यू कॉल इट अ व्हाइट आई सिंड्रोम. व्हाइट आई सिंड्रोम इज नथिंग बट ट्रैप डोर फ्रैक्चर of orbital floor. The trap door fracture of the orbital floor. Okay, and it causes an oculocardiac reflex. Because of the oculocardiac reflex, there is vagus nerve stimulation. Because of vagus nerve stimulation, there is bradycardia and hypovolemia. So, itna implied question tha, unless आप oral surgery में post graduation कर रहे हैं और ये phenomenon अपने सामने देख रहे हैं, तभी आपको, there is exposure to this kind of things. Otherwise, nobody has exposure to these kind of things. Still, it is asked, and it has raised the difficulty level of the paper to a much higher level. We have discussed trapdoor fractures, we have discussed orbital floor trauma, we have discussed oculocardiac reflex in our oral surgery videos very, very nicely. Still, it is a difficult question, I would say, because examiner ने ना सब चीजें इकट्ठे पूछ ली हैं. और हिंट क्या दिया है आपको? ब्राडीकार्डिया और हाइपोवोलेमिया, जिसमें आप स्ट्रेट फॉरवर्ड कार्डियक इश्यूज या ब्लीडिंग इश्यूज सोचते हो. ओके, रिमेंबर, जब भी हाइपोवोलेमिया होगा ना तो टैकीकार्डिया होगा. इनिशियली तो एटलीस्ट टैकीकार्डिया होगा, बाद में ब्राडीकार्डिया हो जाए अलग बात है. सो अगेन वेरी वेरी डिफिकल्ट टॉपिक. आई हैव टेकन अप TCR in the miscellaneous topic, Ayushi, that answers your question, and orbital trauma I have taken up in trauma part. So we have taught you everything, but still it is difficult because they have asked everything together. Okay, this is very easy question. Which of these is a confirmatory test for CSF leakage? Now we all know that beta 2 transferrin, ये हम बचपन से रटते हुए आ रहे हैं. And just if you know that tau protein is another name for beta 2 transferrin. Tau protein is another name for beta 2 transferrin. So जिसको ये ज्ञान है उसका आंसर करेक्ट हो जाएगा, because the question is asking you confirmatory test. It is not asking you a clinical test or a general test. Okay, persistent white colored rhinorrhea, yes, it can give you a hint that this is CSF, but it's not a confirmatory test. Halo test, yes, on a handkerchief there will be a white dot, and around that there will be blood. So that is also hint that it is CSF rhinorrhea, but it is not a confirmatory test. MRI, there is no role of MRI. CT हम जरूर करते हैं cribriform fracture देखने के लिए, but MRI का तो कोई रोल ही नहीं है दूर दूर तक. ठीक है, so what is the correct answer? Beta 2 transferrin, जिसका दूसरा नाम है tau protein. So जिसको ये पता है कि beta 2 transferrin और tau protein same है, उसने सही मार्क किया होगा. जिसको नहीं पता है, हो सकता है वो हेलो टेस्ट मार्क करके आया हो. So the correct answer to this question is tau protein. A lot of research is going on around tau protein and Alzheimer's disease and all of that. So उसमें नहीं घुसते हैं, but yes, that is another tricky question, I would say, that was asked. Another question is, what is hyphema? Again, purely orbital trauma. जिसने orbital trauma देखा है किया है, वैसे it is also basics of anatomy also. Okay, when you read about orbital anatomy in your first year, we usually read only osteotomy, only osteology. हम bone की orbit के walls पढ़ लेते हैं, medial wall, lateral wall, floor, roof, conical shape है, pyramidal shape है, optic nerve आ रही है, and we read about the basics of anatomy of the orbit. We never read the basics of the globe. So this is a basic question from globe anatomy. Hyphema में क्या होता है? जो anterior chamber of the eye होती है, उसमें bleeding हो जाती है. And usually it is not visible. Okay, there are grades of hyphema. Grading hoti hai 0 to 4. And how do you check it? You check it on slit lamp examination. I have put a picture here of slit lamp examination. ऐसे slit lamp में हम check करते हैं whether there is bleeding in the anterior chamber of the eye or not. If it is a microscopic bleed, it is grade 0. If it is a full chamber filled with blood, it is grade 4. So this is what hyphema is, okay? And most common cause of hyphema is orbital trauma. Orbital trauma is the most common cause. Spontaneously भी हो जाता है, कभी-कभी thalassemia में होता है, बहुत सारी diseases में होता है, okay? And but the most common cause still is orbital trauma. Okay, so again a difficult question, but if you know the basics of globe, you would probably know ki hyphema kya hota hai. It has never ever been asked before. It's a new question and a difficult one. All right, so remember orbital trauma में anterior chamber of the globe में अगर bleeding होती है तो उसको hyphema बोलते हैं. चेक कैसे करते हैं, डायग्नोज कैसे करते हैं, आप स्लिट लैम्प एग्जामिनेशन से डायग्नोज करते हैं. ट्रीटमेंट कुछ सेपरेटली नहीं होता है. डायग्नोसिस कैसे होती है, पेशेंट विल से आई हैव ब्लरी विजन, विल से आई एम नॉट एबल टू सी क्लियरली, बिकॉज जब माइक्रोस्कोपिक ब्लीडिंग होती है तो कई बार नहीं पता चलता है. स्लिट लैम्प एग्जामिनेशन में भी कई बार ब्लीडिंग नहीं दिखती है. दैट इज माइक्रोहाइफीमा. Microhyphema means microscopic level पे RBCs are coming into the anterior chamber. So it will cause blurring of vision and not so clear vision. So just treat your orbital fracture and slowly the hyphema will resolve. The vision will become more clearer. All right. So this is question number 9. Again, a very tough question from oral surgery. ये easy था. ये question easy है, but options में अगर आपने ऑप्शन ठीक से नहीं पढ़े, जल्दी में मार्क किया है, तो बहुत लोगों ने इसमें भी गलती करी होगी. हर्निएशन मीन्स, हर्निया क्या होता है, कोई पार्ट कहीं से निकल के कहीं और चला गया. आयुषी, दैट इज द मीनिंग ऑफ हर्निएशन. अम्बलाइकल हर्निया में क्या होता है, आपके एब्डोमिनल कंटेंट ब्लैडर में घुस गया, कहीं और घुस गया. हर्निएशन का मतलब होता है वो चीज जो अपनी जगह पे नहीं थी वो खिसक के कहीं और चली गई है. ओके, हर्निएशन ऑफ ब्रेन इनटू द स्पाइनल कैनाल. ब्रेन पूरा खिसक के आपके मेडुला ऑब्लोंगेटा को पुश करते हुए वहां घुस गया है. हर्निएशन मतलब अपनी जगह से कहीं और चले जाना. ऑर्बिट को ग्लोब के अंदर होना चाहिए, ग्लोब को ऑर्बिट के अंदर होना चाहिए. अगर ग्लोब का कंटेंट खिसक के मैक्सिलरी साइनस में घुस गया है, दैट इज कॉल्ड हर्निएशन. ओके, यस, शिवम हैज आंसर्ड यू करेक्टली, इट इज प्रोट्रूडिंग आउट. अब ये क्वेश्चन है, इमेज दिखी हुई है बड़ी अच्छे से, एक सब लिंगुअल सियालोलिथ की इमेज है. ओके, ना आपको रॉन्ग which is not true, you have to tell which is not true. Okay, अब मैं सिर्फ not true ऑप्शन को डिस्कस करूंगी, और इस क्वेश्चन में ना सिर्फ ध्यान चाहिए. All you need is concentration to read the options properly. और कुछ नहीं चाहिए, कोई ज्ञान नहीं चाहिए इसमें. You don't need any knowledge here. All you need is just concentration. इसीलिए कल मैंने एग्जाम एनालिसिस में बोला था कि द वन हु इज काम विल गेट अ रैंक दिस टाइम, नॉट द वन हु हैज नॉलेज. नॉलेज वाले सब लोचा करके आए, बट द वन हु हैज लिटिल नॉलेज and is calm during the exam, that person will get the rank. Option B here was straight short course of the submandibular duct. Absolutely wrong. Long tortuous course होता है. Why are submandibular sialoliths most common? They are most common because जो Wharton's duct होती है ना, वो ऐसे ऐसे आती है, टेढ़ी मेढ़ी आती है mandible में, floor of the mouth में. This is the mandible, this is the floor of mouth, and this is the submandibular salivary gland. लंबी सी डक्ट आएगी ऐसे टेढ़ी मेढ़ी करके, और जो secretions है, the secretions of the submandibular gland are mucoid. They are not serous, they are thick mucoid secretions. So these are the three factors: long, tortuous course, and mucoid secretions, which is why the chances of sialolithiasis is maximum with the submandibular gland. बाकी सारे ऑप्शन में ना कहानी थी, ठीक है, कि पेरोटिड में कम होते हैं, माइनर ग्लैंड्स में भी हो सकते हैं, और एक ऑप्शन था विच आई डोंट रिमेंबर. इफ यू गाइज रिमेंबर प्लीज लेट मी नो, बट वो सब कहानी थी. सिर्फ ऑप्शन बी आधा गलत था, आधा सही था. ओके, thick mucoid secretions increase chances of submandibular gland duct and duct cyaloliths. So आधा ऑप्शन भी सही है कि भाई थिक म्यूकॉइड सिक्रीशंस होते हैं, बिल्कुल होते हैं. इंक्रीज चांसेस ऑफ सबमैंडिबुलर ग्लैंड सियालोलिथ, ये भी सही है. एंड डक्ट सियालोलिथ, ये भी सही है. तो इसका पहला पार्ट है स्ट्रेट शॉर्ट कोर्स ऑफ द सबमैंडिबुलर डक्ट. बैंग ऑन श्योर हूं इस ऑप्शन के बारे में, क्योंकि आई हैव सैट फॉर द एग्जाम, आई हैव गिवन द एग्जाम. आई एम वेरी श्योर. अब जो भी ये बोल रहा है कि ये ऑप्शन नहीं था, ये ही ऑप्शन था, क्योंकि मुझे भैया डेंटल मटेरियल्स तो आता नहीं है, प्रोस्थो तो आता नहीं है, ऑर्थो तो आती नहीं है इतने अच्छे से जितना ऑर्थो एंडो प्रोस्थो फैकल्टी को आती है. मुझे तो ओरल सर्जरी आती है और वो बहुत अच्छे से आती है. तो ओरल सर्जरी, एनाटमी, उससे रिलेटेड हर चीज आई हैव रिटन द क्वेश्चंस माई सेल्फ. I've come back from the exam, I have written them and I'm discussing it with you. तो यही ऑप्शन था. आधा ऑप्शन बी was wrong because straight short course लिखा हुआ था. इतना ही पढ़ना था ध्यान से भाई, इसकी वजह से दिस इज द करेक्ट आंसर. सो जिसने ध्यान से पढ़ लिया, आई एम वेरी श्योर यू मार्क्ड इट करेक्टली. सिर्फ इतना पढ़ना है, बाकी सारी कहानी है. इतना आपने देख लिया कि अच्छा ये एग्जामिनर ने ट्रिक करी है मेरे साथ, फिर आप बाकी को फटाफट रूल आउट कर सकते हो. ठीक है. सो इस क्वेश्चन में आंसर इज स्ट्रेट शॉर्ट कोर्स. ओके, एनेस्थीसिया का क्वेश्चन था. आइडेंटिफाई द ट्यूब बिलो. Dr. Ajay Yadav has taken anesthesia as a one-day class very beautifully. He has discussed it. I have taken airway lectures separately. I have taught it. In the morning motivation session, multiple times I have discussed RAE tubes, which are also called preformed tubes. And when do we use RAE tubes? When do we use nasal RAE? When do we use oral RAE? So Wonderland is saying, जब एग्जाम दे रही थी मेरे दिमाग में एकदम क्लिक किया कि ये शॉर्ट कोर्स लिखा है. वेरी गुड. ऑलराइट, सो दिस इज बेसिकली अ नेजल प्रीफॉर्म्ड ट्यूब, आल्सो नोन एज अ नॉर्थ पोल ट्यूब. इट इज आल्सो नोन एज अ नॉर्थ पोल ट्यूब. ओके, just give me 1 second. I'll charge my phone here because my phone is off. I'll not be able to see your questions. ऋषभ, आईफोन का चार्जर है? Okay, so my phone is off. So if there are any questions, I will be able to take your questions after the session. So just listen to the answers for now. All right. So ये जो है oral preformed tube को बोलते हैं साउथ पोल ट्यूब. और साउथ पोल ट्यूब भी ऐसी दिखती है, but it comes down like this. Okay, so that is how the south pole tube is. It comes down. All right, very good. So now I can see the chats here. Thank you, Rishabh, for showing me the chats here. Please मुझे chats दिखा दो. थोड़ा सा lag आएगा पर कोई बात नहीं. Yeah, okay. So south pole tube, north pole tube, PVC endotracheal tube conventional tube होती है और reinforced endotracheal tube में metal की rings होती हैं. So जिसने morning motivation अच्छे से attend किया है, उनको ये आंसर आता होगा बहुत easily. All right. So the correct answer is North pole tube, also known as nasal preformed tube. Okay, बहुत बार ट्यूब से रिलेटेड क्वेश्चंस INI में आते हैं. नीट very limited times they will ask you anesthesia questions, but like we had predicted, there are always tube related questions in INI-CET. All right, so अगर आपने आपको ट्यूब्स के, because when you are doing oral surgery, the oral surgeon will tell the anesthetist कि भाई I am doing a TMJ surgery, please give me a north pole tube. I am doing a cleft palate, please give me a south pole tube. I am doing a TMJ ankylosis, please give me a flexometallic or a reinforced tube. Whatever it is. I am doing a submental intubation for panfacial fractures, please give me a submental flexometallic tube. All right. So routes of administration, types of tube, types of intubation, कि कब fiber optic use करना है, कब laryngoscopy use करनी है. All these concepts we have discussed, and those who have listened to it, you have marked it correctly. Otherwise, you might be confused between north pole and south pole, that is oral and nasal. But since this is going upwards towards the head, it is a north pole tube, and north pole tube हमेशा nose से डालते हैं. So the correct answer to this question is nasal preformed tube. Okay, Now, this is easy. This is one easy question, thankfully, which was asked in the exam. Systemic toxicity of lignocaine will be seen in what concentration? So we know that the normal dose of lignocaine is 7 mg per kg. This is the normal dose of lignocaine and articaine. All right. So 3 mg, 5 mg, 7 mg, इनसे तो toxicity हो ही नहीं सकती because it's a normal dose है. एक ही dose थी which was more than 7 mg per kg. So that is the correct answer. उसी से toxicity होगी. Okay. Again, this is a repeat question. The one and only repeat question in exam. Which of these is most cardiotoxic LA? The correct answer is bupivacaine. अब आप confuse होते हो tetracaine और bupivacaine. Tetracaine is an ester which is no longer used. कहीं पे भी tetracaine use ही नहीं होता है. तो इसीलिए there is no comparison between the cardiotoxicity of tetracaine and bupivacaine. Tetracaine की cardiotoxicity आप कब check करोगे? जब use करेंगे ना. ये इतना toxic है कि आप use ही नहीं करते हो. It's not used anymore. All right. So out of these three, the correct answer is bupivacaine. So the correct answer, it's a repeat question. We've already given it in the eGurukul app. It's there in the question bank. It is there in the PYQ section. And if you have read that, you know the correct answer is bupivacaine. All right. I couldn't take the screenshots, but it's there. Okay. Okay. Which of these is most commonly used in dental anesthesia? Again, a tricky question. इसमें कोई knowledge नहीं चाहिए. इसमें सिर्फ simple चीजें पता होनी चाहिए. और कुछ नहीं चाहिए. ठीक है? इसमें first option is 2% lignocaine with 1:1000 adrenaline. 1:1000 adrenaline हम कहाँ use करते हैं? हम use करते हैं anaphylactic shock में. हम यूज करते हैं कार्डियक, हम यूज करते हैं बहुत ही इमरजेंसी सिचुएशंस में. इट इज अ वेरी वेरी हाई कॉन्सेंट्रेशन ऑफ एड्रेनालिन. अगर मैं इतनी हाई कॉन्सेंट्रेशन ऑफ एड्रेनालिन दूंगी तो मेरा पूरा सफेद हो जाएगा टिश्यू. So never ever we use 1:1000 adrenaline in dental anesthesia. We always use 1:80,000, 1:1 lakh, and 1:2 lakh. अलग अलग कंट्रीज में अलग अलग नॉर्म्स हैं. इन इंडिया we use these three concentrations. In Malamade, these three concentrations are usually given in combinations of these. Okay, so most commonly we use 1:1 lakh wala. We never ever ever use 1:1000 adrenaline. Bhayankar high concentration. So option A and option B ऐसे ही rule out हो जाएगा. Okay, now option C and option D are 0.5% lignocaine and 2%. Now we know lignocaine is always used as a 2% solution. Okay, bupivacaine agar hota, bupivacaine is very cardiotoxic. It is very long acting. So bupivacaine is much more potent also. So we give bupivacaine in the concentration of 0.5% or 0.25%. ये bupivacaine की concentration होती है. Lignocaine की concentration हमेशा 2% होती है. Okay, so the correct answer here is lignocaine. All right. एक और question था about local anesthetics, about the tissue irritant properties. Okay, I know it was there. This question was there. I searched it in many places, but I could not find an answer. Okay, that was really tough for me also. The question was, which of these is the most irritant local anesthetic to the tissues? I have searched in Monheim's, I have searched in Malamade. मुझे इसका आंसर नहीं पता हो कि in spite of searching at many places, I don't know what and why the examiner has put this question, but in standard textbooks, I could not find an answer to this. That is why I have not put it in the recall. ऐसे questions छोड़ देने होते हैं. मैंने तो छोड़ दिया था ये question. So you just have to leave these questions. भगवान का नाम लेके छोड़ दो. That is always best. And if you can report, you should report it. Maybe it is some article based question, but in these 2 days I've not been able to find it. I will still search for it and I will put the answer in the app in case I find the solution. Okay, ऐसे ही एक question था puromycin पर. If you remember, there was a question and I'm sure Dr. Saurabh must have taken it. What is the mechanism of inhibition of protein synthesis of puromycin? Puromycin एक ऐसी antibiotic है जो use भी नहीं होती है. It is an antibiotic of years back. It is hardly, I don't think anybody uses puromycin anymore. Still, there was a question on puromycin. So maybe now most of the local anesthetic solutions are very, very safe to the tissues. So the skeletal muscle में damage, irritation होती है, but very insignificant. Okay. Still, this question is asked. It's an archaic question. It's a very old question. Okay, so I didn't like this question, but it was there. All right. Again, जो puromycin वाला question था, very archaic question. In fact, I even remember a question on SDS page, एक pathology की electroporation की in situ hybridization की technique थी SDS page. We have failed to recall this question because it was very long, very tough question on SDS page. जब मैं अपने पीजी के लिए प्रिपेयर कर रही थी बैक इन 2010, तब हम अमित आशीष मुदित खन्ना में से ये क्वेश्चन रट्टा मार के जाते थे. So उतने पुराने recall में से भी they have picked up questions and it is not a good thing. So I really found this May INI-CET paper very unbalanced. It was either very extremely tough questions or very old questions. These are all very old questions which are not I don't know if they are even clinically relevant nowadays. I mean, I am too young. The examiner who has made this question is definitely much more smarter than I am, much more intelligent, much more experienced than I am. So maybe उसने कुछ सोच के ही डाला होगा. But to my understanding, these are irrelevant questions. This should not have been there. At least ये दो questions तो होने ही नहीं चाहिए थे. Because आजकल clinical scenarios में कोई भी LA इतना tissue irritating नहीं होता है, puromycin use नहीं होता है. So because of all these reasons, the oral surgery questions were really difficult. कल मैंने अपने recall में भी same चीज बोली थी कि it is very difficult paper, toughest in the last 10-12 years that I have seen. All right, तो जो use नहीं होता है उस पर question देने की क्या जरूरत थी? सही बात है यशिका, you are absolutely correct. पर जिंदगी में हमेशा वो नहीं होता है ना जो होना चाहिए, कभी कभी वो भी हो जाता है जो नहीं होना चाहिए. And your जो भी फर्स्ट आएगा या जो भी टॉप 10 में होंगे ना, उनका रैंक ना इन क्वेश्चंस पे डिपेंडेंट नहीं होगा. उनका रैंक उन क्वेश्चंस पे डिपेंडेंट होगा जो इजी थे, जैसे सैलोलेथ वाला क्वेश्चन, जैसे कार्डियोटॉक्सिक एलए वाला क्वेश्चन, जैसे ब्लो आउट फ्रैक्चर वाला क्वेश्चन, ठीक है, जैसे पैरासिम्पाइसिस फ्रैक्चर, लीनियर फ्रैक्चर में आईएमएफ की ड्यूरेशन. दीज आर रिलेटिवली ओके क्वेश्चंस. अगर आपने ओके क्वेश्चंस को सही मार्क किया है और इन क्वेश्चंस को ना छोड़ दिया है तो भी आपका रैंक आ सकता है. कल भी मैंने यही चीज बोली थी कि जिसने 160 के अराउंड अटेम्प्ट किए हैं, अराउंड 160, सिंस यू गाइज आर आस्किंग मी के क्या क्या है, तो जो भी था, हाँ 80 ईयर के दादाजी ने बनाया, जिसने भी बनाया पेपर, बहुत पुराने क्वेश्चंस लिए हैं. इफ यू हैव मार्क्ड अराउंड 160 क्वेश्चंस आल्सो एंड आउट ऑफ देम अराउंड 130-140 आर करेक्ट, यू हैव अ वेरी गुड चांस ऑफ सिलेक्शन. ओके, 40 एक अगर आपने 0 मार्क्स, 40 में आपके 0 मार्क्स हैं और 30 क्वेश्चंस आपके रॉन्ग हुए हैं, then this I think will be the topper score. मेरे हिसाब से जो फर्स्ट रैंकर है उसका स्कोर ये होगा, because pathology was difficult, micro was difficult, a lot of things were difficult, oral surgery was very difficult. All right, so I will finish my oral surgery session here. We have with us Dr. Aishwarya here. Sir, are you there? Dr. Aishwarya, sir, are you there in the session? Rishabh, Dr. Aishwarya has joined. All right, so I welcome Dr. Aishwarya. I don't think he needs any introduction. Dr. Aishwarya is our senior faculty of endodontics and dental materials. Sir has done his undergrad, postgrad, senior residency, everything from Maulana Azad Institute of Dental Sciences. Sir is an All India rank 6 of his times, and Sir will take up endodontics and dental materials with all of you. All right, so handing over the session to Dr. Aishwarya. Over to you, sir. And thank you so much for being with us for the oral surgery recall.
Hello, friends. Good evening. Hope the paper went well. Well, first of all, I'm Dr. Aishwarya Kaushik, and I'm going to be doing the recall session with your dental materials, cons and endo. A couple of observations, friends. The paper, as usual, in terms of predictability, yes, it was an INI exam. You know, institutions of national importance dominated by the number of aims that are there. if you see the question paper, especially endo and cons, I mean, completely skewed towards questions from traumatology. That has been the trend with the AIMS people since 4 to 5 to 6 years. The question paper was tough, no doubt. It was, frankly speaking, it was a senior resident level question paper. In terms of balance of questions, what can I say? It was not balanced. It was a question paper which was completely heavily loaded towards traumatology. Distribution of questions topic wise, absolutely no consideration given to that. But be that as it may, I mean, that's how the system works. And we just have to follow the trend. As I said, in terms of predictability, yes, to an extent, yes. New questions were there, tricky questions were there, tough for you guys. As I said, MDS level paper doesn't make sense. You know, some of you are going to become oral pathologists, some of you are going to become orthodontists, so on and so forth. But yes, as I said, that's how it is. You know, if you see the past 4, 5, 6 years of senior resident papers as well as MDS entrance papers from AIMS, even before the INI started, you know, it's been about 5, 6 years that, you know, questions are just too much heavily loaded towards dental traumatology. First question, thickness of MTA plug in epexification is, this was actually one of the easiest questions that could have been asked. I mean, basically you're dealing with, first of all, let me just tell you the answer. And then, you know, because sometimes what happens is that we get so engrossed in the discussion part that we forget about telling you the final answer. So the final answer here is, of course, without any doubt, 3 to 5 mm. You know, the mean is around 4 mm. It's basically talking about dealing with an open apex case, guys. So you have a tooth with an open apex, right? And you're supposed to perform, the tooth is diagnosed to be necrotic. You're supposed to perform apexification. Earlier, it used to be multiple visit apexification with calcium hydroxide. Modern times, if you're supposed to do apexification, it's a you know, calcium silicate based barrier. You put a MTA plug, right? Or you can go with a biodentine plug, right? And you eventually do a backfill with preferably thermoplastized guttapercha, or you can do a conventional sectional guttapercha technique, or you can do your lateral compaction, whatever suits you. What is important is get a nice plug of about 3 to 5 mm or simply 4 mm of your MTA or biodentine, and then do a backfill with your guttapercha, right, guys? So that's how the MTA thickness question goes about. As I said, it's one of the simplest questions that could have been asked here. Best prognosis of repair among root perforations. Again, another tricky question. Guys, the toughest to repair is obviously as you go down deeper into the canal, right? So if you perforated in the middle third, it would be tougher to repair than a perforation in the cervical third. If you perforated in the apical third, it would be tougher to repair than a perforation in the middle third. However, the prognosis or the success rate or the predictability of success is exactly the opposite, guys. Just a sec, can I ask my person to maximize my screen? Screen ko bada kar do meri yaar. I can't see myself here. Yeah. Right, guys? So the best prognosis would be the apical third, no doubt. Right? So the best prognosis is the apical third. Related question, tougher to repair. Which is the tougher to repair? It would be apical third, right? So the opposite order follows. The easiest to repair is the cervical third, then middle, then apical. Toughest to repair is apical third, then middle and cervical third, right? The another important, you know, applied MCQ that can come is, why is the prognosis of a furcation or a cervical third perforation poor? Because it is closest to the marginal gingiva, to the plaque, to the bacteria in the oral cavity, and therefore the prognosis of perforations in the cervical third or in the furcation areas are the worst. Right, guys? So I hope there's no confusion here. Again, another application-based question. Type 3 transportation of canal is best repaired by. Now, guys, the answer here is I've put in, obviously, there were only 4 options, but just for the sake of, you know, some discrepancy in the recall value, I've just put in all the possible options that we've recalled. The answer is MTA plug, right? Now, first of all, let's just discuss what this basically means. We're talking of apical transportation of the canal. Now, when you talk about these iatrogenic errors, guys, what do we have here? We have the root here, right? Now we have some curvature here on the root, right? Now, if you're doing, if you're not pre-covering your files, or if you're doing overzealous, instrumentation and biomechanical, you're being too enthusiastic with your biomechanical prep, what you do is you end up cutting more on the outer curvature of the canal, right? So if you're working short of the length, you end up making a ledge, right? If you maintained your length, right, or if you've just gone beyond the length, that is, instead of stopping at the apical constriction, you've gone right up to the apical foramen and you've overzealously prepared the canal. So what happens? You tear apart. You don't respect the original dimension of the apical foramen. You don't respect the Schilder's principles. So you end up, instead of the apical foramen having its natural diameter, which was supposed to be maintained, you ended up being an over enthusiastic endodontist and you ended up tearing the apical foramen and increasing its diameter. Right, guys? When you do that, right, then based on severity, type 1, type 2, type 3, right? Type 1 is very minimal, type 2 is moderate tearing of the apical foramen, type 3 is severe tearing of the apical foramen. You basically end up in a situation of basically a blunderbuss canal, right? You no longer have an apical constriction, right? You have practically a diverging canal here, right? So if you end up doing a routine obturation with your gutta percha in the apical third, you won't have a proper seal. There would be gap in between your master cone and your root canal wall. And then there would be subsequent leakage from the periapical tissue fluids, failure of root canal, right? So what do? You basically want to seal it as best as possible. And the best possible answer here would be doing an MTA plug, right? So you basically iatrogenically created type 3 transportation, apical transportation of the canal. Here would basically type 3 apical transportation of the canal would basically imply that you've created an iatrogenic open apex, or a blunderbuss canal, right, guys? So you have to basically again get a seal that is as best as possible, right, guys? Best treatment for cracked tooth with reversible pulpitis. Again, a trick question. Some of you I know have marked resin or composite restoration. That is not the answer. I'm quoting Cohen. The recommended treatment for a cracked tooth or a cracked cusp is a full coverage crown or an onlay. Basically a cuspal coverage restoration. So first of all, let's just mark the answer. Is a full coverage crown or an onlay, right? Some people have proposed doing a bonded restoration, but that is not the recommended treatment as per the present guidelines, guys. So recommended, the term recommended is very important. Recommended treatment of a cracked cusp or a cracked tooth with, again, this is very important, reversible pulpitis, because the moment the diagnosis is irreversible pulpitis or pulpal necrosis, you have to go for pulpectomy or root canal treatment followed by a full coverage crown. Here you simply do with reversible pulpitis, you simply do a full, and I'm quoting Cohen here, so full coverage crown or an onlay. Essentially, you need to cap the cusps. You need to splint the opposing cusp so that when the patient bites onto it, they don't move, right? And you don't get that sharp shooting pain. And some workers have still proposed that, okay, let's try with a bonded restoration like a composite, or in other words, bonded resin restoration, but that is just proposed. You can do it. It's not contraindicated, but the best or the recommended or the standard of care is a full crown or a cuspal coverage only. For uncomplicated crown fracture, what can be done to avoid pulpal inflammation? Now, guys, see, we have obviously the most common versions of recall: light cured calcium hydroxide, self cure calcium hydroxide, then light cure resin modified GIC, or self cure GIC, right? Now, some people have also said, a simple resin restoration or a composite restoration. Now, if that was in the options, then this is the best possible answer. Simple. Uncomplicated crown fracture is what? Ellis class 2. Simple. Ellis class 2 is enamel and dentine. So dentine is exposed, pulp is not yet exposed. Now, ideally, this question should have come with an added information of what the RDT was, remaining dentine thickness. If that would have been less than 0.5 mm or equal to 0.5 mm, we would have gone for a calcium hydroxide first, right? As a pulpal medicament, or as an agent to do basically IPC, and then a base of resin modified GIC. Now, this is not given, so we are considering that it is not that exceptional case. It's not that close to the pulp. So we have the RDT, which is greater than 0.5 mm, right? If it is not mentioned, that is what we are considering, right? So in that case, the better answer between GIC, conventional GIC and light cure GIC would be light cure GIC, right, guys? So if composite restoration is given in the answer, is given as one of the options, no doubt that is the answer, right? That's what Cohen says. If it is not given in the option, then, just to preserve the pulp, go for a resin modified GIC. It has components of, composite as well. It has got methacrylate. It's going to bond well to the tooth structure. It's going to cure and polymerize upon the operator's will, light cure GIC, right? We're not dependent on, once you mix the powder and liquid, we're not dependent on the fact that it is going to set within, a few minutes. You can contour, sculpture restoration. So any day, resin modified GIC is better than conventional self-cure GIC, right, guys? So that's how you're supposed to approach the question. You know it better. You sat for the examination. In future also, this is the order we follow. You get this question, you get added information regarding RDT. If it's less than or equal to 0.5 mm, go with a base of DPEST pulpal medication of calcium hydroxide, overlay it with resin modified GIC, and then do your composite restoration. If RDT is greater than 0.5 mm, directly go with composite restoration if that is given in the options. If that is not given in the options, which has been the case according to many of you as far as this yesterday's exam was concerned, then GIC light cure is the best answer, right? So I hope you know the order now. For severely intruded tooth with closed apex, guys, when should root canal treatment start? Again, applied question. Severely intruded tooth with closed apex. Number 1 point. Never expected to revascularize. That is a chance that we can take with lateral luxation or intrusion with an open apex case. That's number 1 point, right? Second, if it's not revascularizing, you have to do a root canal treatment, right? Because this tooth has turned, for all practical purposes, it has turned necrotic, right? And it's never going to revascularize. You have to initiate root canal treatment. When do you initiate root canal treatment? Irrespective of any injury, whether it's lateral luxation, whether it's intrusive luxation, whether it's avulsion, when it is for sure, when you're for sure that it is not, it is going to be necrotic and it is not going to revascularize, you have to initiate root canal treatment within 1 to 2 weeks, according to one line in Cohen, or 10 to 14 days, which is practically the same, isn't it? Within basically 2 weeks. Why? Because by 3 weeks, the necrotic tooth is going to be colonized by bacteria. So guys, let me just summarize this here, that I have an intruded tooth which has a closed apex, right? Intruded tooth which has a closed apex. You have to start RCT, essential. So I'm marking star mark here. No chances of revascularization. No chances of revascularization, right? So I have to start RCT within 10 to 14 days or 1 to 2 weeks or simply within 2 weeks. Can you do it in the same appointment? Of course you can. But I mean, the patient has come to you with trauma. The first thing that you do is you reposition the tooth, you do splinting. Now, what is the time period of splinting for intruded tooth? 4 weeks. What is the type of splinting that you do? Semi-rigid or flexible or functional. They're all the same. You understand? Right? So the first appointment, this is what you do. I mean, while doing this, it takes a pretty long time. So why don't you recall the patient after 1 or 2 weeks? That would be your routine follow-up visit also. You can do your routine pulp tests, right? You can, check other teeth as well. You can see the progress of the patient and preferably do it within 2 weeks. It's not that doing in the same appointment is contraindicated. It's just that, giving LA, repositioning the tooth, doing splinting is in itself going to take at least 45 minutes to 1 hour, right? And then starting root canal would be like extending the appointment to 2.5 hours, right? So the best answer immediately after repositioning is not wrong, but within 2 weeks, if that is given as one of the options, is the best answer. Right, guys? So whether it's within 2 weeks, 10 to 14 days, within 10 to 14 days, within 7 to 14 days, within 1 to 2 weeks, all are correct. After 4 weeks, absolutely wrong. Only when the patient complains of pain, absolutely wrong. Immediately after repositioning, of course, that's right. But better answer and more precise answer is within 2 weeks, right? In case of extrusive luxation, which is true regarding splinting, this is basically a memory-based question. Extrusive luxation, 2 weeks of semi-rigid splinting or functional splinting or flexible splinting is the answer. So flexible splinting for 2 weeks is the answer. Some of you have also told us that, the question actually came with regard to lateral luxation. So just to clear the confusion, if the question was for lateral luxation, then lateral luxation is for 4 weeks. So splinting of, just to, combine the knowledge here, always remember, guys, splinting for subluxated teeth, flexible splinting, 2 weeks. Splinting time for extrusive luxation, flexible splinting, 2 weeks. Splinting time for lateral luxation and splinting time for intrusive luxation, 4 weeks, semi-rigid or flexible or functional splint. Is that clear? Right. And what is the splinting time for an avulsed tooth? 1 to 2 weeks. Right. However, if the avulsed tooth is associated with fracture of the alveolar bone, then the splinting time is 4 to 8 weeks. Right, guys? So that's how this protocol works. We've discussed this a lot many times when I do my traumatology and all these videos and lectures. So it was just a quick revision. Again, another tough question. A tooth with lateral luxation. Now, again, we have 2 versions here, and I've put both, right? I want you guys to know the concept and the right answer in case this question or its related question comes in the future. So let's just discuss every possible aspect of these questions. A tooth with lateral luxation, so that's one. You have lateral luxation. We have one version where the trauma was a decade back. Now it's showing discoloration. Patient is asymptomatic. On IOPA, there's obliteration of pulp canal and the periapical index score is 2. Right, guys? Quite a lot of information we have. What do you do? Now, guys, you have a discolored tooth. The patient is asymptomatic still. There's obliteration of pulp canal. What do you mean by that? The patient underwent trauma a few years back, right? 8 to 10 years back. There was a favorable response to trauma. And what is that? Calcification or obliteration or calcification of the pulp chamber and the root canal. That's a favorable response because the pulp is maintained its vitality. Instead of getting necrotic, it underwent calcification. because of which there is a yellowish discoloration. Fine. So all this while, in all these years, the patient was fine. He had to be, because the pulp was still functional, isn't it? Yes, it was calcifying, but that's a favorable response. That is something that is good, right? Now, after so many years, you take an X-ray, and the periapical index score is 2. Now that shows slight widening of the PDL. There's something going on here, right? Now that there are certain changes in the periapical score, despite the fact that the patient is still asymptomatic, what is the treatment that you would do? Ideally, in this question, some more added information regarding vitality testing should have been done, right? If the answer would have been very clearly RCT, if the vitality testing would have been turned negative. However, that is not the case, right, guys? They did not give you any information regarding pulpal sensibility tests. So we are in a situation where we have to assess that, okay, periapical index score is 2. There is evidence of PDL widening. This is not a good thing. So now you can go with RCT, right? Not good to wait and watch. Obviously not going to do pulpotomy here, right? So let me just share this is what is the periapical index scores: 1, 2, 3, 4, 5. In more simpler terms, that's 1 is normal periapical structures, 2 is small changes in the bone structure, right? And according to this diagram, 2 is slight increase of the width of the PDL ligament space, right? Which is not good, right? And obviously periapical index score of 2, of 3, 4, and 5 is just that the periapical, radiolucency and the periapical pathology, it is indicative of the fact that the periapical pathology keeps on worsening, right? So if the question was as simple as this, and the options were as simple as this, go for RCT, guys, right? Another version is that there's this 9-year-old patient. He underwent trauma 1 year back. Again, calcified canal, of course. Yellowish discoloration is there, right? And periapical index of 2 is there, right? So that's a slightly distorted version here. So what do you do, guys? Right now, again, since the periapical index is 2, there's widening of the PDL space. Go with endo treatment, but in terms of managing the discoloration, go with the least invasive treatment first, and that is non-vital bleaching. So the answer here would be endo treatment and non-vital bleaching, guys, right? Now, if you ask me why, sir, why not veneers? Why not full crown, right? So you have to see the order here, guys. See here. This is the table from your Cohen standard textbook. When you have discoloration, you first try bleaching, and that too, when you've done your root canal, internal bleaching and or external. You understand? And if the discoloration is resistant to bleaching, guys, if the discoloration is resistant to bleaching, then only you try for first veneers and then full crown, right? So the order is this: you first try bleaching, and that too internal bleaching, because that's easier, isn't it? Once you've done the root canal treatment, it's like basically walking bleach, isn't it? If you've not done root canal treatment, obviously you're going to go for external bleaching, right? So that's why I chose non-vital bleaching option as the best possible option here. Right, friends? Now, again, a very important and trick question. Sodium hypochlorite irrigation depends on the efficacy of sodium hypochlorite irrigation. Yes, the most important is, of course, volume, right? Next, concentration, of course, it's important. Temperature, controversial. pH, very important. Now, I'll tell you what, guys. This is a trick question here. I'll tell you, the combinations were there, but volume plus concentration combination was not there. Volume plus concentration combination was not there, right? That is in the first appearance, volume is of course the most important, right? And second most important seems to be concentration. That option was not there. So we are left with a combination of volume temperature, volume pH, or temperature pH, isn't it? So we are left with basically, for all practical purposes, volume plus temperature, because we have to have volume, right? Volume is the most important. So volume temperature, volume pH, right? Now, out of these two, what will you choose, guys? What will you choose? That's the controversy here, isn't it? Now, guys, please realize that as you increase the temperature, you increase the tissue dissolving ability of sodium hypochlorite, right? However, if you read Cohen, the last line of this subtopic says that yet, as of today, as yet, there is no clinical evidence that increasing the temperature has got any significant beneficial effects on the efficacy of sodium hypochlorite, right? But as far as pH is concerned, the pH of sodium hypochlorite is greater than 11, roughly around 11.5, 12, basically greater than 11. And for the same reason as calcium hydroxide works against bacteria, that is, it interferes with with bacterial enzymes, it interferes with bacterial metabolism, it interferes with the phospholipids of the cell membrane of the bacteria. The same mechanism is responsible for the effectiveness of sodium hypochlorite, right? So the better answer, and I know there's always going to be controversy here, but this is the answer, guys. Volume plus pH, right? Volume and concentration was not given in the options. You could have gone for volume and concentration if that was given in the options. This is volume plus pH. One of the toughest questions that I could come across. So A and C is the option. Volume plus pH is the answer. Volume is, of course, is the most important. pH, very important, equally important. Temperature, yes, there is an effect, but final verdict from Cohen is that as yet there is no significant clinical evidence which says that temperature, heating up the sodium hypochlorite solution is going to really add any benefit to its effect, right? Best treatment of type 3 apical transportation we've already done. Okay, when a single canal emerges from the pulp chamber, divides into two separate canals with separate apical foramina, it is classified as. So one canal dividing into two, Bertucci type 5, isn't it? Very simple. Let's just quickly revise our Bertucci classification, guys. So what do we have? Type 1, 2, 3, 4, 5, 6, 7, and 8. One single canal, keep on adding 2 if 1 is there, keep on adding 1 if 2 is there. So 1, 2, 1. Type 4 is 2. Type 5 is 1 dividing into 2. Type 6 is 2, 1, 2. Type 7 is, and type 8 is 3, right? So we have been asked one canal dividing into 2 and then ultimately exiting the root as two separate apical foramina. So the answer is type 5. Is there any doubt, guys? Very simple. So this is also a tough question, but one of the simpler ones in this paper. What can I say, guys? Okay, another trick question here, but this is a repeat actually. Best treatment plan for left central incisor, 2, 1. So guys, there was an X-ray, right? With both the central incisors, upper central incisors, suffering from trauma, right? Right? Both having open apices, right? 2, 1 having a periapical radiolucency. So no doubt this is necrotic, isn't it? There's a chronic abscess or chronic apical periodontitis. Irrespective of that, it's basically necrotic, right? Open apex. So what are we left with? I mean, we cannot do vital pulp therapy because it's necrotic. So what are we left with? Either revascularization, number 1, or MTA apexification. Now, the literature is very clear. Based on the level of root formation or root maturation, root length, that is Schweck's classification, Schweck's classification of root formation, guys. You're going to decide type Schweck's type 2, 3, 4, 5. You're going to decide whether you're going to go for revascularization or MTA apexification. So if it's type 1, that is when the root end is less than half. Type 2 is equal to half. Type 3 is equal to 2/3, right? Then type 4 is almost has achieved its final root length, right? Final length, right? And type 5 is proper closed apex, right? So obviously this is eliminated. This is a proper tooth with a closed apex. So there's no, no question of attempting apexification here. This is conventional root canal treatment. Now, the thing is, guys, when you are in 1, 2, and 3, you have basically an open apex with diverging canals, right? With diverging canal walls. So that is known as blunderbuss. BB, blunderbuss canal, right? Proper wide open apex and thin dentinal walls to the extent that your canal walls are diverging. So here, you will always do revascularization. Right? Type 4 is you still have an open apex, guys. You still have an open apex, but the walls of the canal are converging. Walls of the canal are converging, right? You still have an open apex. So here, you can go for either revascularization or MTA apexification. Right, guys? So we're very clear with this. Now, obviously, the examiner is smart. He wants you to interpret this X-ray, right? So it's a proper open apex. It's a proper, very thin dentinal walls. And it's a proper, kind of a diverging canal walls, or just parallel or diverging, but definitely not converging. So it's either a Schweck's type 2 or type 3. So here you are definitely wanting to go for a regenerative protocol or a revascularization protocol, right? So the answer is regenerative endodontics. Applied question, but this has been asked before. So I would not say that this was one of the toughest questions, right? Next, again, I can say this is the question of the century, I think. This is one of the toughest questions that you can come across in endo. Root canal morphology of MB root of maxillary molar is dependent on or is influenced by. Now, guys, this is an applied question. You're basically talking about length, angulation, right? First of all, please understand, the moment you say root canal morphology, your mind should go towards Bertocci classification, right? Whether it's 1, 2, 3, 4, 5, 6, 7, 8, right? Now, what is it? What amongst these options would most closely influence the morphology, right? So let's look at the options. Distance between MB1 and MB2 canals. Now, what happens is, that's my occlusal view of my upper molar. That's my oblique ridge, right? That's my molar triangle, right? That's my MB1, that's my distobuccal, that's my palatal, right? Now, the mesiopalatal or the MB2 canal lies in a straight line palatal or slightly mesial up to 2 mm and palatal up to 3.5 mm, right? It can be very close. It can be as far as this. You understand? So as far as this can be my MB2 canal. Now, there is this concept, guys, that in a single root, the farther are the canals, the more are the chances of them having separate exits. The closer are the canals, the more are the chances that they're going to merge towards each other and then exit as a single canal, right? So if they are too far apart, right, then you have two canals exiting separately as two, and that is Bertocci type 4. If they are very near to each other, they might, not necessarily, but they might merge and exit as one. And that is Bertocci type 2. So it is the distance which definitely has an effect, which can have an effect on whether it's what kind of Bertocci classification, right? Depth of MB2 canal, yes, it can lie at the same level. It can be just 0.5 mm below. It can be up to 3 mm. It can be up to 3 mm. So that's okay, na? It can be up to 3 mm deeper than the normal floor of the pulp chamber. So you have to do some countersinking, some troughing with your ultrasonics, or very careful reduction, very careful troughing with a small round burr. Length of MB2 root, angulation of MB2 root, why would that have an effect on Bertocci classification? So the closest answer which can have an effect on the Bertocci classification is distance between MB1 and MB2 canals, right? Preferably, it's one of the tougher questions. You should have left it if you had no idea. If you attempted, pray to God that you put one as the answer, right, guys? I mean, really, man, seriously tricky questions. SR level question paper. But anyways, that's the reality. What can we do? Crazing is due to dental materials, guys. Dental materials. Crazing is due to very simple, straightforward. Number one, tensile. There are three reasons why crazing happens, right? Crazing is basically small cracks in dentures, right? Or in porcelain restorations, right? So it happens due to tensile forces. Number one. It happens because of these tensile forces, the polymer chains separate. They are separated from each other. And a third reason is that if you immerse it in a solvent like ethyl alcohol for prolonged periods, then these three reasons can lead to crazing, right? So obviously we did not have the option of solvent. The correct answers are tensile stress and mechanical separation, and the option would be C and D, right? Would be C and D, right? If you have to mark one single best option, then it would be tensile stress. As simple as that. So I'm going to highlight tensile stress. And if you have a combination option, it would be both tensile stress and mechanical separation of individual polymer chains, right, guys? All of the following can be used to obtain a definitive cast for indirect restoration, except, right? So basically you want good accuracy, right? Elastomers are accurate. So addition silicone, polyether, polysulfide, they're all accurate. हो गया मेरा. It's almost done. नहीं, निकलना है. Right? So all of the following. So you have addition silicone, polyether, polysulfide, they're all elastomers. Yes, polysulfide is a tricky one because it's no longer used. But guys, it is an elastomer, and it is definitely more accurate than irreversible hydrocolloid, which is alginate. I mean, you do not take alginate impressions. Ideally, you do take, but you're not supposed to take alginate impressions for inlay, onlay, and full coverage crown, or partial coverage crown for onlay, or for any indirect restoration, right, guys? So the answer is irreversible hydrocolloid or alginate. No doubt about that. Rough and chalky appearance of dental cast following impression with non-aqueous elastomer is. Now, guys, the direct pick from your textbook was that rough or chalky stone cast, right? So inadequate cleaning, excess water, excess wetting agent. All these three are the first 3 points here, and all are correct, right, guys? So we have 1, 2, and 3. All right. So 1, 2, and 3 is the correct answer. 1, 2, and 3. Right? Ratio of density of high noble to base metal alloy. It's very simple. Basically, high noble, or you're basically consisting of gold, right? More gold or more, noble metals. That's almost, the density is almost 14 to 15 units, and base is almost 7.5. So it's almost double, right? So 2:1, and double is the answer, right? Material used for air abrasive polishing. Now the catch here is air abrasive polishing. Material used for air abrasion simply is aluminum oxide, but for air abrasive polishing is sodium bicarbonate, guys. So this was, as I said, guys, a tricky paper, and well, what can we do? Tough questions, and but yes, as I repeated initially also, I mean, that's the trend with INI now. They are too skewed, too, heavily loaded towards, traumatology questions, you know, traumatology, open apex, management of open apex. The time and again that they're asking these questions. But despite that, yes, a tough question, new questions, very few repeats as far as cons, endo, and DM is concerned, guys. Right? So, guys, I hope you could do well in this paper, and yeah, best wishes, guys.
लिंक भेजा अलग आयुष चैनल से। और रुक।
हेलो
चुप रहना।
हेलो
चुप रहना।